morning to everyone joining us today in this today's conference, Big Updates, Recent Advances in Gastroenterology, a scientific program. I assure you that this 8th annual conference of Bhopal Institute of Gastroenterology will prove to be fruitful and informative to all the members participating in the conference. Along with Dr. Pranav Raghuvanshi sir, I, Dr. Riya Panchal,
Farooq Ahmed.
we will be your host for this 2 days conference. It is our pleasure to welcome you all on behalf of Gastrocare family in this conference.
We cordially welcome all eminent speakers and guests from all over the country. We welcome to the all faculty. We commence by a floral welcome. I request Dr. Sanjay Kumar sir to please welcome Dr. C.C. Chobal sir.
Sorry, I was just. Sir, okay.
I request Dr. Neetu Kumar ma'am to please welcome Dr. Amol Bajpayee sir. Amol Bajpayee sir. I request Dr. Naveen sir to please welcome Dr. Mohan Ramchandani sir. So I request Dr. Sandesh Sharma sir to please welcome Mohan Ramchandani sir. I request Dr. Rohan sir to please welcome Dr. Rajesh Puri sir. I request Dr. Mayank sir to please welcome Dr. Saurabh Mukherjee sir.
Gastrocare Liver and Digestive Disease Center is a dedicated center of Central India. We are providing our services since 2012 and face behind this organization is none other than Dr. Sanjay Kumar sir and the dedicated team. Now I would like to call Dr. Sanjay Kumar sir for his welcome speech.
Good morning, everyone. A very warm welcome. I'm immensely pleased today to have all of you here. I would say rather I am overwhelmed to see all these stars of endoscopy from all over India gather together at our center. It is really a pleasure and honor for us that all of you have agreed to come for this workshop in CM. I have no words to thank you, in fact, all the faculty. I welcome all the delegates also who have come from various parts of Madhya Pradesh, and many of them are from Bhopal itself. In fact, I have, as Riya has already said, I have so many people to thank today. In fact, as she said, we started Gastrocare in 2012. And first of all, I would like to thank my family, my wife, my father. In fact, my father, it was my father's 73rd birthday when we started the center. And every year we hold this conference on his birthday or the foundation day of our institution, that is 8th April. Only this year we have shifted to 22nd because you all know that there were several conferences in the country around that time. So we all celebrate this day with great joy and happiness. So it's my pleasure that you all have joined us on this day today to celebrate with us. It has been our endeavor to continue academic activities in this institution, though we started with a small nursing home. we had only 18 employees at that time when we started in 2012. And now the number, the family is 250. So by the grace of God and with the support of my team, I think we have been growing. And academics, we never left. In fact, most people used to say that you got a kind of nursing home, why you go to these scientific activities. But I always believe that you can do best for your patients only when you are well informed. So teaching remains an important part of healthcare, irrespective of the fact that you are, whether you are in a teaching institution or not. So with that in mind, we have continued, and we started having this big update. Big actually stands for our institution. Big is Big Bhopal Institute of Gastroenterology. So that is how this term was coined, Big Update, in 2012. And we have tried to do some of the other activity every year. Meanwhile, I will welcome Dr. Mohit Bhandari. Please come. Mohit is just joining us. He is also one of our second. I request Dr. Pranav to welcome Dr. Mohit Bhandari. So, अभी एक फैकल्टी और बचे हैं, यही रख देना है. Dr. Rajput is on his way. So what I was saying was that in whatever you do in life, it is the team which matters. So one of the songs which I was hearing last evening only, चले थे साथ मिलके, चलेंगे साथ मिलकर. So that's how every new endeavor gets into a shape. So I'm really thankful to my team, which has been with me all along, and that is how we've been able to serve the society better and have been able to hold such academic events also. So we are all looking forward to an exciting day of endoscopy. Let me first welcome my faculty who have come, who have consented to come for the workshop today. First of all, I'll say a few words about Dr. Chaubal. Sir is the senior most gastroenterologist of the state. And in fact, it was because of him that I got interested in gastroenterology. Not only because of, not only me, I think several of us were sitting there who belong to this state, got into gastroenterology because of him. I truly consider him as my mentor and as they say, guide, philosopher and friend. He's a great friend. So about him, I would just like to say that he starts his day with several cups of tea along with several books. And he's a voracious reader. And he has continued this trend all over. I mean, youngsters should take an inspiration from him. We all do that. And his day ends with friends every day. So that is another thing to learn from him. Welcome, sir. Welcome, Dr. Chaubal. We would all like to see you performing a case today. Then I would like to welcome Dr. Amol Babai, who has come all the way from Pune. About Amol, I would say that in early 2000s, we used to hear that there is some Dr. Babai. We were in early practice. And he's a great endoscopist. He brought EUS in the western part of the country. And when we got EUS scopes, the radial as well as linear. So somebody told that he's the only one who, he says that why do you need a radial? You take only linear, you can perform everything with linear. So that was a new thing, before that we were not aware. So he is a pioneer in this country, and to tell you the truth, he along with several of others are going to various countries to perform procedures, and he is actually a third space and US specialist in this country, and they have brought, along with Rohan, they have brought the POEM, Z-POEM, and all the third space procedures in this country. Welcome, Dr. Amol. Then I would like to welcome Dr. Mohan. Mohan is not only a friend, and he has always been with us. In fact, this may be the fourth time that he's coming for a workshop to this center. And he has actually established poem procedure with us in this hospital. And he is a great endoscopist. He has a keen understanding of GI endoscopy. And whenever in trouble, I always have a strong shoulder in form of him. I would give him a call that I am stuck in this procedure, please guide me. So please welcome to the clap, Dr. Amol. I would like to welcome Dr. Rajesh Puri. Rajesh is a great endoscopist, very enthusiastic. We see him performing here and there in all the conferences. He is from Vedanta Institute, Delhi. He is basically an US specialist, but he does all kinds of interventional endoscopies, and he is currently the Secretary of Society of GI Endoscopy of India. And you will all see today that how with great finish he will be performing the procedure. Welcome, Dr. Rajesh Puri. Then the next is Dr. Mohit Bhandari. I think he needs no introduction. Anywhere in India or abroad, if somebody talks of obesity, bariatric surgery, endobariatrics, number one name would be Mohit's name. And at his young age, he has actually achieved so much in field of obesity that we all admire him for his qualities. I welcome Dr. Mohit. Mohit is at Indore Center. Part of SAIMS, the Sri Aurobindo Institute of Medical Sciences, their Dr. Mohit Center, which is a dedicated center for bariatrics. The youngest of our faculty is Dr. Saurabh. I remember once his father, Dr. Shrikant Mukewar, is senior to me from PGI, and he is also a good friend. So long back we went to Mauritius along with sir, and he was a young guy at that time. And he was there for some time. He was perhaps preparing for PG, preparing to go to US at that time. So from that day on, Saurabh has really matured into a great endoscopist. And in very short span of time in India, I think about a couple of years, 3-4 years, he is back from US. And he has really earned a name in interventional endoscopy. And it's really my pleasure to have him here today, Dr. Saurabh. I think I have not covered everyone. Dr. Rajput. So Dr. Rajput is on his way from airport. So we will not wait because we have a lot of cases lined up. Just to tell you a brief about him, he is my contemporary. He is in Ahmedabad. He used to run a dedicated endoscopy unit called Ansh Clinic, which has really grown very well over the last 10 years. We never met all these years, but only in the last 2 years we met because his son and my son are doing MD together at Indore. So that is how we never met all these years. But he is a very exciting endoscopist, all of us know. He is a very fast decision maker, and we would all love to see him perform today. So I think all of you are waiting for an exciting day of endoscopy. And as I said, we have 17 cases lined up. 2 OTs will be running simultaneously. My colleagues, Dr. Naveen, Dr. Mayank and Dr. Rohan will be coordinating from operations theatre. And the entire staff is also very eager to serve you. So I think we'll all begin. Handing over to Riya. Thank you.
It's a light that illuminates the path ahead of us and helps us see the way forward. So now it's a time for lamp lighting. I request all the faculty members for the lamp lighting. Dr. Amol sir, Dr. C.C. Chobal sir, Dr. Mohan Ram Chandani sir, Dr. Mohit Bhandari sir, Dr. Rajesh Puri sir, Dr. Saurabh Mukewar sir, Dr. Sanjay Kumar sir.
सर आप लोग वहाँ आगे सर आप लोग पास सर और पास
I request all to stand at your place. Now let us all sing together our national anthem.
Okay, so video na.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तब शुभ नामे जागे तब शुभ आशीष मांगे गाए सब जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे। सो भारत माता की जय।
Dr. Amol, should I start?
Yes, yes, please.
So, good morning, everyone. Thanks to Dr. Sanjay and the entire team for giving this opportunity. And I'm going to talk about EUS guided FN and FNB. What are the tricks to get the best result? So, because we are already late, I'm straightforward coming to the topic. The most important thing which I always feel whenever a patient refer for endoscopic ultrasound, you should be able to answer the question which your colleague or your surgical colleague wants. Because many of the time a CA pancreas refer to you and we write everything, but the people forget writing about the SMV and SMA. What the surgeons want, is it the artery is involved or not? Is the vein involved? Because that is going to change your entire treatment. So this is very important. Look at the paper, what your colleague or surgical colleague want an answer. And the aim of FNA, FNB is you should have a diagnostic accuracy more than 90 or 95%. And what is called as the best sample, it should be cellular, it should be least bloody, the bloodiness should be less, and it should be adequate in quantity to give the final result. Those who are learning endoscopic ultrasound would like to say, when I started and my cytopathologist says you send 40 slides and it take entire day to read. So this is very important. You should make minimum slides. It should be less bloody so it can give an appropriate answer what is desired from the examination. So before that, just want to tell you about the parts. If you know, this is the sheath. This is the needle inside. This is the hub. This is the stylet. And there are the two screw. This is one and second is here. This is for the adjustment of the sheath. And this is for taking out the needle out. So this is important. And the sheath, I'm not going into the details of this, but every component has its own advantage and disadvantage and relevance. So if you look at the type of the needle which is available in the market, there are various by Cook, by Boston, by various companies, the needles are available. So what is the importance? The question comes, any needles given to you and you are going to use, or the make of the needle make a difference? That's very important, because all needles are not same. All needles, the material from which they have made, they are different. So if you look at the EcoTip Cook, and if you look at, they are made up of the stainless steel, and the tip is lancet design, and the sheath is resin. Just to highlight, the coil sheath or the metal sheath is always better. Any needle which has a coil sheath or a metal sheath, I have shown the diagram prior to that, sheath, because it goes inside the biopsy channel of the scope, it covers the needles. So the sheath which is made up of the metal is always better in comparison to the resin or the plastic sheath. That's very important. Second, when we talk about the material, three materials are available in the form of stainless steel. Second is cobalt chromium, and third is nitinol. So when we talk which is the best needle, which is made up of the nitinol, because this is a super alloy and which has a memory. And what is the meaning of memory? Even you use the elevator or even the hardest of the lesion, it is not going to bend. It may bend, but it comes back to its normal. So when we talk about the thin needles, 25G needles, when it goes to the uncinate process of the pancreas, and when you take out the needle, you see the entire needle got bent like this. And most of the time, our assistant keep on straightening it. So stainless steel needles, they have a tendency to bend, while the nitinol sheath, which is made up of the super alloy, which has a memory, they doesn't bend. So needle which is made up of nitinol and the spiral sheath, they are always better in comparison to available rest of the material. The another important thing, talk about the needle tip geometry. Why this is important? Because the needle tip geometry is in the form of lancet, mahogany, or francine, or the new shark core needles, because they have different designs and they have a different penetration depth, penetration power, through which they are going into the tissue. So depending upon that, a lesion which has a lot of desmoplastic reaction or fibrotic, the ease of penetration is also going to make a difference. So I'm not going into the needle tip, but they are also very important. And you see some needles has a three, well, the company guy comes, he says he has a three bevels, somebody will say five bevels. So what is the importance? Because it give a cutting power to the needle and help in penetrating the hard lesions. So as I said, does the needle choice matter? Definitely it matters. Because we always talk about the cost. We don't talk about the characteristics of the needle, but it make a lot of difference when you are doing your FNAC. So sheath, I said the metal is always better than plastic, and the spiral sheath at the distal end, which make it more stable, is better. When we talk about the constructor material, I talk about the nitinol is better than cobalt chromium, and it is cobalt chromium and the nitinol is better than the stainless steel. Sono visibility is again important, but there is a study from Peter Willman, and that has shown that the sono visibility of most of the needles are more or less same. And what is the most important thing is sono visibility of a distal 1 centimeter of the tip of the needle. That's very important. And especially this is very important when we talk about the 25G needle. Because when 25G needle goes to the uncinate process of the pancreas, it is very difficult to see the distal tip. So the sono visibility is given by the laser etching or sandblasting or dippling. All designs currently. Are you listening some disturbances? Okay. And the stylus has no significant impact, the various studies have shown. So regarding the technique, I think most of you are doing, and what is outlining the lesion, which is very important, and it will depend from where your needle is coming. If the needle is coming from your left side, then the lesion should be focused at 5 or 6. If the needle is coming from the right side, then it should be focused at 6 to 7. Meaning that when the needle, without using the elevator, it comes to the center of the lesion, which is important. You insert the needle, which is important. Puncturing the lesion again, before that you apply the power Doppler. And once you take the FNAC, then it is also very important how to use the cytological material which you have taken in the needle, because 50% of the work comes how you have handled the cytological specimen or the histopathological specimen. I think that is 50% weightage to an FNA, and this has been well proven in the studies. A center which has started their EUS and FNA, this is from the Europe, and their diagnostic accuracy was 38%, because the most of the uh, specimen was read by the cytological specimen was read by the pathologist, and when it was just seen by the cytologist, this diagnostic accuracy had risen from 31% to 87%. So specimen handling, whenever you are doing, it is important you should go and discuss with your cytopathologist and from which area your needle has passed, because when it goes to the esophagus, it goes to the stomach and duodenum, also make a lot of difference, because it may shows about the metastatic nature when you are taking an FNA. So the route from where you have passed the needle is also very important. As I said, correct positioning, why it is important, your needle when it is coming, it should come towards the center of the lesion. If it come towards the periphery, even by elevating, you cannot scan the entire lesion which you want. So the focusing of the lesion you can do by pulling or pushing the scope, or by making the big wheel. That is most important. That is called a spanning technique, making the big wheel towards you or away from you. Elevator give around 15 degree of the deflection of the needle, but elevator, when you use the elevator, it gives so much of resistance to your needle. So my request, those who are learning the EUSFNA, try avoiding using the elevator, because you will face a lot of resistance while doing this. The position of echo endoscopy is also very important. While taking a FNA, your scope should be in the straight position. So whenever you are taking the FNA in the D1 and D2, you find that the scope is in the torque position and it is difficult to take FNA. So try to take in the D1, D2 in the short scope position rather than taking in the long loop position. And in the esophagus and the stomach, it is always been the straight position. This is very important. You should always able to see the full length of the needle. What happened is, in a sonographic image, if you are not able to see the distal tip of the needle, then there's a possibility you are seeing the bent position of the needle and you may injure the down structures which is there, either maybe a blood vessel or any other organ. So in sono view, it is important you should be able to see the complete length. If you are not able to see the complete length, make sure that the tip of the needle should be visualized when you are doing the to and fro movement. So these are the few important topic I have talked about the needle. Now the technical factors and the sampling method which I'm going to talk. So you know that the needles are available in the 25, 22 and 19G needle. So this is a comparison between 25 and 22G needles, and various studies in the meta-analysis shows that either you use the 25 and 22, the diagnostic accuracy is same. So there is no difference. This is a one meta-analysis shows the 25G needle is better for the transduodenal pancreatic lesion. When we talk about the extra pancreatic lesion, then the difference between the 25 and the 22 is not there. So if you are planning to puncture an uncinate process of the lesion, then it is better to use the 25G needle. Otherwise, my request, my feeling is 22G needle is the best needle to be used, and it has a many advantage, right from the visibility, because as I said, 25G needle, the visibility is poor. Number second, the adequacy of sample. You may get the good cytological specimen, but when you talk about the cell block, or when you talk about the histological core tissue, 25G needle is not sufficient to give. So the only indication of using the 25G needle is a uncinate process, or patient has a coagulopathy, or you are planning to go through the transvascular route. I talk about the esophagus. I think in the straight position, the sensitivity is more than 95. But in the transduodenal location, you see the scope is bended, and what you require a thin needle or the flexible needle. That is the second important thing. So which is the best flexible needle? The needle which is made up of the nitinol is the flexible needle. Now this is an important study if you look at, because these are the small thing matters. So this is by Bang et al. GI endoscopy 2013, and what they have done, they have made the algorithm. And what is the algorithm? When they are planning to go through the transesophageal and the transgastric route, they chosen a 22G needle. And when they are going transdural, they use 25G needle. And interventional procedure like requiring a core biopsy, transgastric transdural 19G needle, and transjejunal they use the flex 19G needle. And what is the difference? In the phase 1, when this algorithm was not used, the technical failure was more. In the phase 1, when the algorithm was not used, or the failure of the needles, the cost and the diagnostic accuracy was less. So the important message is, before doing the procedure, you should know which is the best needle. So 22G needle is the best, as I said. 25G needle is more flexible, less bloody sample, easier penetration, better in the transdural route, small lesion which is less than 1 centimeter, or vascular lesion like spleen or coagulopathic patient, or you are planning to do the transvascular FNA. 19G needle mainly used for the core tissue, like in a patient of lymphoma, autoimmune pancreatitis, neuroendocrine tumor, subepithelial tumor, where you require a core tissue, you try to use, or all therapeutic procedures when you are planning for the biliary drainage or the cyst aspiration, you use the 19G needle. Now, this is commonly asked question in most of the conference, the role of suction. So, if you look at these 3 studies, the suction is not advisable when you are planning to do the EUS FNA or FNB. The reason is that when you use the suction, the bloodiness is more and the number of slides are more, but the diagnostic accuracy is same while using the suction and no suction. So the answer for this is no suction. But there are certain indication when you can use the suction. And what is my practice? If you look at what I do in my practice, the first pass I use without suction, and if the yield is adequate, there is no need to do the suction. If we don't get the material that is a paucicellular or acellular material, we definitely use the suction. Third thing is a tactile feeling. It happens many times when you are doing a pancreatic tumor which is very hard, or a chronic pancreatitis with a mass where there is a lot of desmoplastic reaction, lot of fibrosis, or patient who has treated for tuberculosis and you have a lymph node which is a fibrosis, or if a lymphoma is there, in those cases, now this is I'm talking about the FNA, not talking about the FNB, but these are the situation where you can use the suction. But in the first and the second pass, if you're getting the adequate material, try not using the suction because your number of slides will be less, it will be less bloody, and you will be able to give the result in a better way. Another important thing, when you apply the suction, lot of blood comes and that make a coagulum and the entire material entangled in the coagulum, and it is difficult to disperse on the slide. So cytopathologist may not be able to give the answer. Stylet, the same answer is when these are the study which shows when you use the stylet, the specimen is more bloody. So avoid using because diagnostic accuracy and adequacy is same between the stylet versus non-stylet, but the specimen will be more bloody. Now, regarding the various technique, I think the best technique is a fanning technique, which you should understand. And this is a study which shows that the fanning technique, the first pass answer is more in comparison to the standard technique. So what is fanning technique? If you say, in fanning technique, you start from the one side, either from the left side of the lesion, and you go entirely to the right side, meaning that you scan the entire sample, entire pathological specimen. And how you do, you use the big well towards you or away from you. So it makes the movement of the lesion from one side to other side, that's number one. Or you can pull and push the scope, that's number two. Number third, you can use the elevator. Now, fanning not always doesn't mean that your needle will always remain inside. Actually, cursor, can you see my cursor here? The fanning doesn't mean
Yeah,
that.
sorry, requesting Dr. Puri, please bind up your time is up.
Yeah, I'm just.
You exceeded.
So
2 minutes.
fanning means that you scan from all the sides and do the to and fro movement. That is going to help, and this is the best result. I think I will go. How many jabs? The 10 to 15 jabs in the lesion. That is when you are doing fanning. Every time you do 2 to 3 passes on all the 4 quadrant, that is going to make around 8 to 10 jabs. Then the important slide is yes. When you get an FNA negative, there is no need for you to immediately send the patient for the CT guided or the interventional radiology guided, it is better you repeat. And these are the study which shows if you repeat the FNA in after day or two, the yield increases again from 60 to 80%. On-site cytopathologist always increases the yield, and the experience of endosonologist make a difference. I think last few slide, when you once you get the specimen, this is important. So use the slide which has a uh, marking on the side, so you can write the UHID number of the patient. Make the slides by sandwich method, that is, you make a angle and spread material from one side to other side, which has a head, body, and tail, and the tail side is the sparse material where you can see the cytological specimen. Always send the air dried and the wet fixation. Wet fixation is around 2 to 3 slides, and air dry the rest, because wet fixation with an alcohol give the better nuclear detail, and the air slide give the better results of the cytoplasm. Then FNB needles I have talked. This is the, I think, is one of the best needle shark and four. The diagnostic performance when you talk, the FNB needles between the acquire versus sarcor is same. I think cell block I'm going to talk when I'm going to demonstrate there. The only thing is the last two slides. So what is the trick of FNA in the duodenum? As I talk, take the scope in the short loop position, use the smaller size of the needle, adjust the big wheel to take out the needle. This is important. If you are not able to take out your sheath, bring the scope to the important thing. This is important when you are taking the loading the needle in the stomach and taking it to the duodenum. Ensure that there should not be a perforation. In my department, I have seen two perforation. The younger colleague was doing, he was not able to take out the needle. He loaded the needle in the stomach, and while going, then the torque of the scope goes because the needle gives the strength. And that is one of the cause of perforation. And use the smaller needles. The disadvantage of smaller needle, I said, it goes out of the ultrasound field, is as a tendency to wobble, and you get the small pulse. So what is the best if you want a pathology? Use the flex needle 19, which is made up of nitinol. The cyst I'm going to overcome. So to summarize, the objective is to address the question. Diagnostic accuracy should be around 95%. Presence of on-site cytopathologist is better in a patient when you are doing the cytology. But for the histopathology, that is FNB, you don't require rows. If you get a negative result, repeat the non-diagnostic case after a day or two, or refer to a more expert person. Standardize your specimen processing. This is very important because I always feel 50% of the cases you get a failure result if your cytopathologist is not mature. You should have a critical volume around 2 to 300 per year to get the good results. Use 22 or 25, better is to use 22G needle. No suction, no stylet. Fanning is the best. If you don't have a rose, then at least 7 passes for the pancreas, 3 for the lymph node. And this, what is the difference between FNB and FNA? The FNB, what has shown the superiority is it give the less number passes, it give the positive result. So average is around 1.8 to 2 passes required for FNB to give the result, while FNA has 3 to 4 passes to require. Thank you.
Question to Ajay Jain, sir. Please join here as a chairperson. Ajay Jain, please. The session is open for any questions or comments.
So we are generally not using for that, but the media which is making going to make a difference.
What's your comment on the new sharp core needles in terms of the comparison with the other needles?
So I think I was talking, and if you look at the literature, there's a the comparison wise between the Flex 19G and the Shark Core is same, and the difference is the Flex has a 3 bevel which is at the 120 degree, while the Shark Core has 6, and one Shark Core the bevel is more longer in comparison to the rest, and that longer help in penetration, while the rest is for holding the tissue. So in my personal use, I have used the Shakor, and I think it's a fantastic needle. But the literature-wise, Shakor and the Acquire needle has an equal result. Both are same.
Rajesh, very often we find that we have to do an FNA or FNB, but the vessels are coming. So, how often do you feel that this problem is there, and how do you circumvent it?
So I think it's a very good question. And number one, I think 95% of the time you are able to circumvent the vessel. You can change your direction, change your field of FNA you will get. If you are not able to get, the safer is transarterial puncture. The second is transvenous. And third, avoid collaterals because they bleed more in comparison to that. So first is avoid. If there's a no, you have a no indication, you have to go it. Then transarterial is safer in comparison to transvenous. In comparison to venous versus collaterals, the venous is safer.
Thank you.
Use the thin needles.
Secondly, in D2, we often have a problem because the scope is curved. Uncinate FNA or FNB, if you have to do, then the needle often doesn't function as well.
So I said the two things: use the thinner needle, 25G needle, or use the flex needle, which is made up of nitinol. So those needles has a memory; they are more flexible, so they will be able to use. So the material which is made up of nitinol is better. Yes, and do in the short scope position.
See, now one technique which is becoming very popular for gastroenterology is using coils and the glue. What is your policy in this situation? Because injecting coils is all right. What we do over the glue? The same needle, because the needle gets technified immediately. What are you going to do in that situation? Or you remove the whole thing and then go with your conventional scope and put the glue at the next.
No, I will tell you. I will just tell you about it. So the two kinds of glue available in the market. One is N-butyl cyanoacrylate, which is available in the India, and in the West, the N-octyl cyanoacrylate glue is available. The difference between these two, N-butyl has a solidification time of 5 seconds, and N-octyl cyanoacrylate glue has a solidification time of 20 seconds. And why I'm saying, because when you use the glue with the long US needle, there is a high chances these needle get blocked. So what I do in my practice, I think more than 100 cases we have done, I always do 1:1 lipidol mix. And it has I did yesterday night also a 5 centimeter large fundal varix. And trust my words, it doesn't embolize. We always talk that we are not giving a complete lipid oil. We can do 70-30, we can do 50-50, we can do 40-60 mixture. The advantage is you can slowly push the lipidol mix cyanoacrylate glue that is not going to block your needle. And if the amount is less, you can reintroduce. So your needle blockage can be prevented. And the most important is not the needle blockage. Your glue should go inside the varix. Most of the time what happens is when you inject, the entire glue remain inside the needle, it doesn't go into the this. So if you use the lipid oil, it is not going to create a problem. Second advantage is under fluoroscopically, you can see the radio opacity of the lipid oil, and you can see the embolization also if it is happening. So you tell your assistant to slowly inject. Our practice, what you have seen when we are using with an upper GI, your assistant forcefully inject the glue. When you inject with the lipid oil, you can inject drop by drop, drop by drop, drop by drop. So it is not going to block your needle. And the coils act as a scaffold to the glue, and the glue remain inside the coil. Chances of the embolization. I've done more than 100 cases, and we have published also 82 cases. None of the cases embolization. So the 2-3 things. Number one, we generally use the used needle. That's number one. But that's not right because hollow needle should not be reused. So the best answer is use the lipid oil mixed with the cyanoacrylate glue, or arrange the N-octyl cyanoacrylate, which is a 20-second. So you don't require a lipid oil to be used in those cases.
Second lecture is by Dr. Amol Bape, requesting chairpersons to please call our speaker and introduce the speaker, please.
Thank you, Dr. Yadav. It's a pleasure to introduce a good friend, Dr. Amol Bapai, who is a pioneer in the field of third space endoscopy. He is Chief of Gastroenterology at Dinanath Mangeshkar Hospital and Research Center, and his areas of interest are third space procedure, and he has pioneered poem with fundoplication, ESD, and I think full thickness resections. So it's pleasure to have you here, Amol, and it will be a delight to listen to you. Please.
Thank you, and thanks to Dr. Sanjay for this kind of invitation. Pleasure to be here amongst our friends and colleagues. So, Dr. Sanjay wanted me to talk about hilar strictures. I took the liberty to also add a little bit about indeterminate biliary strictures, because basically hilar strictures, the challenges are when they are indeterminate. Otherwise, the treatment is pretty much standard. So that's how it is. So I'm just going to give you a quick overview. So we know that 60 to 70% of cholangiocarcinoma is located at the bifurcation or the classical Klatskin tumor. Know that. And by definition, a biliary stricture is called indeterminate if after a cross-sectional imaging and standard ERCP with routine breast cytology and biopsy is non-diagnostic. And also strictures arising within 2 centimeters of bifurcation are termed as hilar strictures. So that is how it is. And this is a Bismuth correlate classification of perihilar tumors, which we are all familiar with, type 1 to type 4, and then 3A, 3B, and 4, all of them are there. I'm not going to go into the details. What you need to remember that up to 1/4 of malignant biliary strictures ultimately turn out to be benign. So suspected malignant biliary stricture does not mean that it is malignant. And preoperative diagnosis, therefore, is highly desirable to plan appropriate treatment, including the whatever it may be. And the Indian scenario, 63 to 75% of all strictures, extrahepatic biliary obstruction can be malignant. That means approximately 1/4 to 1/3 of patients have benign disease. And that's what we need to remember. We have a lot of tools available, but yet the diagnostic accuracy needs improvement. Etiology wise, I have colored the hilar ones in yellow, but these are all the kinds of biliary strictures which are present. And I'm not going to go into read all of them out because we are all familiar with them. So when it comes to diagnosis of hilar strictures, it all starts with the history, biochemical investigations, tumor markers, IgG4 levels, imaging, ultrasound, CT, MRCP, EOS maybe sometimes, ERCP, breast cytology, even a PTC gram at times, intraductal ultrasound, cholangioscopy, as well as confocal laser endomicroscopy. So all of this armamentarium is available to us. So let us look at some of them. So tumor markers, particularly CA19-9, which we are so fond of advising to all our patients. The confounders are benign conditions in acute cholangitis, cirrhosis, cholestatic liver diseases. It can be high. And other cancers also, it can be high in other cancers as well. And we can have 5 to 10% false negatives. So that is the biggest problem with CA19-9. CT, probably good overall for biliary strictures, but probably a little bit less for hilar strictures. But it can, if there is a mass lesion, it is better seen on a CT scan. If stricture length more than 1 centimeter, that is a pointer towards malignancy, as well as asymmetric stricture, as well as hyper enhancement on contrast imaging. The overall sensitivity is around 75 to 80% with a specificity of 60 to 80%. But probably for hilar strictures, an MRI with MRCP is probably more beneficial because it also gives us a clear demarcation about the level of obstruction, up to 98% accuracy for that, and 88% sensitivity and 95% specificity for diagnosis of malignancy. And what are the features which favor malignancy? Stricture length more than 12 millimeters, wall thickness more than 3 millimeters, irregularity, asymmetry, hyperenhancement, all these factors favor malignancy. But what is important to note is an MRCP can also differentiate between other forms of benign biliary strictures in the at the hilar level. So this is IgG4 cholangiopathy. This is a post liver transplant anastomotic stricture and a non-anastomotic, ischemic stricture, and this is also a post cholecystectomy stricture, which you can see over here. And how do we differentiate between IgG4 cholangiopathy and primary sclerosing cholangitis? We can see this, the bleeding appearance is very much different in PSC as compared to IgG4 cholangiopathy. So that's how it is. The mainstay, of course, is ERCP with breast cytology or intrarectal biopsy with or without the guidance of cholangioscopy and stent cytology also at times. So the sensitivity of ERCP and breast cytology, a 10-year review of literature revealed that the sensitivity is only about 41% and the negative predictive value is about 58%. Therefore, the conclusion is that just breast cytology has a very low sensitivity and a negative predictive value. And there have been various methods to improve the yield of breast cytology, including these novel kind of brushes like the infinity brush and brushing after dilation and ILC, as well as fish for diagnosis of the cytology that is obtained on using the brush. However, when we combine breast cytology with an intrarectal biopsy, the accuracy, the sensitivity, and the specificity increases somewhat. The sensitivity is still around 60%, but the specificity is around 100%. And as compared to any of the single modalities, it is superior. And accuracy falls whenever we have flat lesions or non-bile duct cancer or something which is extrinsic compression, or very short strictures also very difficult to locate. Fish has shown some kind of promise, fluorescent in situ hybridization of the specimen that is obtained, and then it improves the yield of ERCP and breast cytology as well as intrarectal biopsy. And up to 80% pancreaticobiliary cancers show chromosomal abnormalities, but that is the basic thing. The caveat is that there is a reduced specificity in primary sclerosing cholangitis, which is probably the biggest challenge of diagnosis of cholangiocarcinoma in the setting of PSC. So that is where the problem lies. Endoscopic ultrasound, again, overall for intraocular indeterminate biliary strictures, probably yes, because it can help us detect small mass lesions which may be missed on CT scan or MR. And therefore, it is always preferable to perform an EUS before an ERCP and stenting. At the same time, it is important to understand that this is a meta-analysis which is shown that ERCP and EUS, it gives us a EUS has a far better sensitivity and specificity. But when we are talking about hilar strictures, the sensitivity of EUS falls in as compared to ERCP in this situation, where ERCP with probably cholangioscopy is a better alternative. And this is how this is a systematic review and meta-analysis which actually gives us this thing. So as I mentioned, distal versus hilar strictures. The hilar strictures give us a lower sensitivity. That is a problem. The other point in hilar strictures is there is a theoretical risk of tumor seedling. Therefore, caution must be exercised when performing FNA from hilar strictures. And FNA is contraindicated in patients with hilar strictures who are scheduled for a liver transplant also. So that is important. That brings us to cholangioscopy, which is the new kid on the block. Nothing new actually. It has been around for many years, but with the advent of the single operator cholangioscopy in the last decade or so, this has become much and much popular. So cholangioscopic evaluation is based on visual impression as well as targeted biopsies both. And both are equally important because both have a role to play. And the visual impression, it gives us a significantly higher sensitivity of 93 versus 82%, but the specificity is slightly lower as compared to an cholangioscopy guided biopsy. The challenge is that even with the current available cholangioscopes, that sample that is achieved with the biopsy is much smaller. Although the second generation, the third generation DS scopes have given us better samples, we still desire for more. The visual impression is limited by poor inter-observer agreement, and that is the biggest challenge. So one needs to be experienced, and the eye has to be experienced to identify lesions in a proper manner. So these are the consensus guidelines on the role of cholangioscopy to diagnose indeterminate biliary stricture. And what are the criteria that were used? Tumor vessels, papillary projections, nodules or a mass, and infiltrative. So all these four formats were there, and sensitivity, specificity, accuracy, and the inter-observer agreement all was mapped. And we can see that the inter-observer agreement is the biggest challenge. Otherwise, the accuracy is reasonably fair. This is how an IgG4 associated cholangiopathy looks on single operator cholangioscopy. And when we add biopsy to the cholangioscopy, it helps us to improve the sensitivity, specificity, and the accuracy somewhat, but not that much. This 81 to 93% still remains 93%, does not go up to 97 or 100%. That is where we have to remember that that is the important part. And these are some of the factors which reduce the diagnostic yield of cholangioscopy. Distal strictures, which is not actually the matter of debate over here because we are discussing predominantly hilar strictures, but operator experience less than 25 cases, severe hyperbilirubinemia, and presence of a indwelling biliary stent can compromise the visualization, and that is one of the reasons why if one is suspecting a malignant biliary stricture or a hilar stricture, there may be a role of a primary cholangioscopy at the time of the index ERCP as well. That is important. And these are some of the strategies to improve yield of single operator cholangioscopy. Touch imprint cytology and 3 biopsies for offsite evaluation. This is what actually gives us probably the best results. And these are the Mendonza criteria which were described by Kaela et al. Visualization of tortuous and dilated vessels, irregular nodulations, raised intraductal lesions, irregular surface plus or minus ulcerations, and friability all are characterized as one of the criteria. A word about intraductal ultrasound. This is a 6 French high frequency 12 to 20 megahertz probe which is introduced through the working channel, and a normal 3-layered structure of the bile duct wall is seen. And this is how we can see this eccentric wall thickening, disruption of the normal 3-layer structure, and dimensions and regional lymphadenopathy and vascular invasion can also be identified. However, this has certain limitations. Biopsies are not possible, and the depth of field of imaging is quite low. However, the sensitivity is quite high for cholangiocarcinoma, as we can see over here. So this is the diagnostic algorithm for an indeterminate biliary stricture. Based on the location, we are talking about a hilar stricture. There is no regional lymphadenopathy. Preoperative drainage is indicated. Then a peroperative cholangioscopy, visual plus biopsy, and possibly an EUS FNA and a repeat peroral cholangioscopy. And then subject to availability and intrarectal ultrasound, next generation sequencing, and other things are also available. And if everything is negative, then observe and a close follow-up of these patients, and the stricture remains stable at 6 months, consider benign. If there is progression, consider surgery on a suspicion of malignancy. That is what is important. And if we are using cholangioscopy more often, then this is how we can modify the algorithm, that we can perform the cholangioscopy first and then proceed with how it goes. And if despite EUS and cholangioscopy, the stricture remains indeterminate, we have to follow up these patients very carefully for 6 months. Management of malignant biliary strictures, these are just the principles. Establish surgical resectability and potential for cure. And we should not be draining atrophic lobes. And the target is 50% of the liver volume should be drained. Preoperative drainage, if indicated, one can use plastic stents. That is preferable, although metal stents have also been described in this situation less often. Palliative drainage is always metallic stents, and benign or indeterminate strictures, again, use plastic stents or fully covered stents which are removable. That is important. And these are the indications for preoperative drainage as standard for any other preoperative drainage. Hilar cholangiocarcinoma, SEMS versus plastic. And this is how the ESG guidelines say SEMS definitely give a superior patency and one should only use uncovered SEMS when we are talking about palliation. And when there is no definitive decision about curation or curativeness or palliative care, one should stick to plastic stents. And unilateral versus bilateral stenting. Bilateral stenting, unilateral gives a higher technical success, but bilateral probably gives longer stent patency. And side by side or stent versus stent, probably the efficacy is very similar in both groups. A word about ERCP versus PTBD as a route. Bismuth type 1 and 2, ERCP is the first choice. Type 4, PTBD is the first choice. Type 3, there's always a controversy between ERCP and PTBD, and I think it depends on the locally available expertise. However, a recent description about a combined ERCP and an EUS guided approach where the right duct is stented by the ERCP approach and the left duct is stented by an EUS guided hepatogastrostomy approach is also very much feasible. A last word about tumor ablative therapies in hilar cholangiocarcinoma, photodynamic therapy, radiofrequency ablation, and brachytherapy all are available. Majority, all three of them are predominantly used to improve stent patency rather than for a curative intent. So improving stent patency can be used, any of these three modalities can be used, and they have shown a fair amount of success. So these are the Asia Pacific recommendations for endoscopic and IR in management of hilar cholangiocarcinoma. And metallic stent is the way to go unless there is, the survival is expected to be very poor. To summarize, accurately diagnosing cancer in hilar or indeterminate biliary strictures probably remains the most important clinical dilemma. We have several diagnostic modalities available. However, the accuracy is still elusive. EUS and cholangioscopy form the mainstay of diagnosis. Intrarectal ultrasound has specific utility in some situations. EUS is superior for distal strictures, but cholangioscopy is superior for proximal. And ERCP or a PTBD guided stenting, guided by an MRCP roadmap, mind you, is very important. The target has a 50% liver volume that needs to be trained, and clinical judgment along with judicious use of available diagnostic and therapeutic armamentarium is likely to provide optimal clinical results. Thank you so much.
Yeah, thank you, Dr. Amol. And this is a very challenging topic for all endoscopists. I'm sure there are lots of things we can discuss and debate, but because of lack of time, we are just withholding the discussion right now. We can take all the questions during your live demonstration.
Now, Dr. Sanjay Rajput sir is with us. I request Dr. Jayant Yadav sir to please welcome Dr. Sanjay Rajput sir.
May I request Dr. Ajay Jain sir to present the memento to Rajesh Puri sir. I request Dr. Viren Chaudhary sir to present the memento to Dr. Amol Bape sir. I request Dr. Pranav Raghuvanshi sir to present the memento to Ajay Jain sir.
I request Pranav Raghuvanshi sir to please welcome to present a memento to Viren Chaudhary sir. I request Pranav sir to present a memento to Dr. Uday Somsekar sir.
Thank you, everyone. I think we are already late. Are we live there? Dr. Naveen, is everything set there? Can you hear me? In the OT? Mohan, we can see you but can't hear you at the moment.
Oh, can you hear me?
Mishra ji, can you
Can you hear
just
me
look into
now?
that? Hello?
Can you hear me?
We are not able to listen to you. We can only see a slide.
We are ready with the first live case.
Okay, can you hear me now?
Naveen, what is this? You are presenting the first case?
Yeah.
The voice is not clear.
So we are presenting the first case of the live case today. Am I audible?
Okay. Yeah, now it is audible.
So the history of the first case goes like this.
A 23-year-old presented
कहाँ देखना है? अरे बाबा.
first with dysphagia, nasal regurgitation of food for last 1 year. Sir, I am audible.
Yes.
Yes.
Her endoscopy was done, showed dilated, poorly peristaltic esophagus, liquid residue in esophagus. G junction is spastic, open up on the pressure of scope. Stomach and duodenum are normal. Barium swallow shows the dilated esophagus, still smooth tapering of esophagus. Her manometry increased LES pressure, 100% failed peristalsis, and mean IRP is 42. This is the slide. This is the slide of barium and the manometry. And the planned procedure is POEM. Now we
The
are live to
chairpersons for this,
OT1.
Arvind Namdev. Dr. Sunil and Arvind. Okay.
Section चालू है.
Good morning. As we can see.
Good morning. Yeah. No. Can you hear us? Can you hear us?
Yes, Mohan, we can hear you very well.
Okay, so let me introduce my team. I have with me Bhagwan.
Hello.
If Bhagwan is there with us,
Arre.
then who can do what?
Then you don't need anything.
Yeah, so Bhagwan is there with me, and that's good that.
And I am with Mohan, another Bhagwan with me.
So here. And
So
we
nice.
have our champion technician with us, Srinivas. He has come all the way from AIG. And whole team is there, almost 50 people are there in our hall. And we are just, as you see here, in this case, we have a lot of food residue in the esophagus. And we'll just start it as soon as we clean it. Okay. So I have to just clean this, otherwise everything will go into the tunnel. Do we have the suction, proper suction?
So, Mohan, which scope are you using?
So I'm using X1 platform, 1500 cc scope, and this is the X1 platform, which is from Olympus, and it has the many features, including EDOF, extended depth of vision. We have TXI, the color and texture enhancement, and we have RDI, that is known as red dichromatic imaging. So anybody who is doing POEM should be very, very worried about this when we see so we do a lot of cleaning before we start this procedure. So I took for granted that it is cleaned. Full. Anyway, I will take 2 minutes because that is the most important part of this procedure to clean so that we have a good. So all rice, dal and rice you can see here.
She is apparently fasting for 24 hours.
Yeah, yeah. So that you can see the amount of spasm at the G junction, which is not allowing. And in fact, these are the patients who will benefit by this procedure a lot, because you have a spastic segment, and you can see here, this is not a problem, which we can clean in 2 minutes.
So is the patient intubated?
Intubated, yes.
So do you recommend to do an endoscopy before intubation? Because during
Always we
intubation
do.
also they can aspirate.
Yes, luckily this patient did not, and I sort of skipped that step. Otherwise, I would have been.
Yeah.
I was in the hall at that time, unfortunately.
Yeah.
So
Because
anyway,
anesthetist Dr. Argal would never let us do any procedure like this.
yeah,
He
but
would
today
always
he was
ask
a
us
bit lenient,
to
I
clean
think.
the esophagus before intubation.
Today he was a bit
Check
lenient.
one, check one.
Hello, hello, hello. Mohan sir,
Yes, yes.
hello.
Yeah, please tell me.
Sir, I'm audible over
Yes,
there.
yes, yes, yes.
Sir, as we are seeing lot of food residue here, and the question came whether we should always do an endoscopy before doing poem,
Yes.
because is it mandatory to evaluate mucosa also, because long-standing food will cause some changes in mucosa, healthy mucosa or unhealthy mucosa?
Yes, absolutely. You are absolutely right, because there are now reports and many classifications available which can tell us whether the appearance of mucosa can tell us about the submucosal fibrosis. If, if there is severe esophageal candidiasis, there is a theoretical chance that you may cause this candida to go into the mediastinum. So always avoid doing in active candidiasis, and also if there is mucosa is too much unhealthy, you may put a Ryle's tube or uh, put a nasojejunal feed for some time. And if there mucosa, you can see that this mucosa is absolutely normal. Usually, if the mucosa is abnormal, there can be submucosal fibrosis. So you will be careful. And if there is candidiasis, you can avoid this procedure for a week and then go. So almost we are clean now.
Mohan,
Yes.
Devinder here.
Yes.
Is it a better idea to put the patient on elemental diet for 48 hours before poem so that this cleaning job gets a little easier? Like we can see, rice and dal, everything there. If they are on very soft diet, maybe this cleaning thing will be,
In fact,
easier for them.
we follow that, Dr. Devinder, in our institute. Whenever a patient comes and being evaluated for anesthesia, we don't allow them to eat at all. We just ask them to drink juice or some liquids, so that by the time they are getting ready for the procedure, this type of problem won't come. And we have one patient who was shifted to ICU, ventilated because of severe aspiration. So this step is very, very important.
In fact, this patient is also fast. Yeah, maybe she arranged in the ward. Meanwhile, Naveen, am I audible there?
Yeah, yeah.
Can we, meanwhile, Mohan is cleaning up, can we go to second OT and
Yeah,
see
yeah.
what Dr. Mohit is doing? You can present the second case.
Dr. Rajesh Puri sir is demonstrating the case. The history of the case goes like this.
Yeah.
A 41-year-old male, a known case of chronic pancreatitis since 2020, now presented with complaint of abdominal pain for last 1 month. His CT showed gas with a pseudocyst of 240 in the neck and body region, distal to seen. Query SV thrombosis. MRI plus done showed the pseudocyst.
Don't have video from the.
Pseudocyst of 3 centimeter at pancreatic neck and body. No solid. Cyst appears to be communicating with the. This is the picture. Plan Pseudocyst of
Hello.
pancreas.
Ma'am, your voice is not clear. It's breaking.
Hello.
Yeah, yeah. Audible, but not clear. Yes.
Hello. Now I am audible, sir. The
Yes, yes, now audible.
planned procedure is of pseudocyst of pancreas. If feasible, use guided cystogastrostomy.
डबल चैनल स्कोप रहेगा तो 2 मिनट में हो जाएगा.
Hello. Dr. Puri. Hello. Am I audible? Yeah, you're audible, but not clearly.
Am I audible now?
Yeah, yes, yes. Now very clearly and loudly.
Now audible?
Yes, yes.
So, thank you, Dr. Sanjay. And I always feel this is a small gathering, family, we know each other. So, I just want to know what the audience needs from me in this case. Because for the anatomical demonstration, a normal pancreas and the rest of the things are important. I will show the normal anatomy also. But what is the choice of the audience to demonstrate? If they can tell, I can highlight my demonstration accordingly.
Very good. जल्दी दो.
Yeah, start from the basics, please.
Okay. So I'm using the linear endoscope, that is 180 series, and EMU2, and I have Amit with me and Dr. Chandra, who is giving the anesthesia, and patient is the propofol in the left lateral position. You have CT scan, you have seen the MRI. This patient has a chronic pancreatitis with the pseudo pancreas.
Yeah, the voice.
Jenny. So I will demonstrate right from the beginning.
माइक की प्रॉब्लम है, बता माइक मुख पास आएगा तो अच्छा है.
So I introducing my scope in and gone across the across the upper esophageal sphincter. Now, one of the most important thing, especially in the chronic liver disease patient, because it is an oblique wing scope and you are not able to see the esophagus, and if there is a esophageal varices are there, there's a high chances of turning of these varices. So what I do is, I make my big knob away from me, my hand is visible. I lift my scope like this, and you can see the, like an endoscope you can see here. Air is not coming. Can somebody open the air? Okay. Now can you see the esophagus very nicely? So I'm doing the upper GI with the EUS scope for any stricture or any varices. So that is important. Once I go into the stomach, the next important point is to look there's any solid material. Can you see there's a lot of solid material is inside? Have you noticed? In this situation, the best is either patient should be intubated, but let's demonstrate, and what I'm going to do
Arvind, is this mic better? Hello, Arvind, Hall.
Hello. Yes, sir. Hello.
Voice better audible? Or no, it is
Sir,
still.
it's better voice, but it's still interrupted. Definitely louder voice.
Is my voice is audible now?
Sir, your voice is audible, but little volume is lower side.
क्या है? रात में wow. Close.
Am I audible now?
Yes, sir.
Am I audible? Close. So the most important thing, if you have realized, there's a lot of food in the stomach. So either patient should be intubated or he should be fasting. So what I'm going to do it now, my scope is at the G junction. Can you see the liver? Open. Can you visualize the liver?
नहीं यार कभी.
So this is the liver. Can you see the liver?
The voice is still not clear.
My voice is audible now?
Its volume is very, very low and not very clear.
Clear?
Not yet.
Now?
Yeah, it is clear now.
Is okay. I think the changing the from the left to the right. So what I'm you see the lot of food residue. Can we have suction is blocked? Open. Is the suction? No, this might have blocked here. This.
Hello.
Yeah.
Puri sir.
Yes.
Sir, by convention, you are going from this images, US images from left to right or right to left?
I'm going from left to right. So
can we reverse the image, sir? Because most of us are comfortable from right to left.
Yeah, I will. See the aorta? Can
Yes.
you see the aorta? Is the aorta visible?
Yes, sir. That's better, sir.
Okay. Is the aorta visible? This is the descending aorta. Left of the diaphragm. Celiac trunk. I do a Can you see the spleen? I do an anti-clockwise rotation. Can you see the collaterals? Am I audible?
Dr. Amit.
Hello. Now voice is clear?
Yes, yes.
I'm in the second part of the duodenum. Can you see the aorta?
Yes.
I have rotated my scope clockwise. This is the descending duodenum. Here. This is the one of the collaterals. This is the head of the pancreas. I'm doing clockwise rotation. Can you see the pancreatic parenchyma here?
Yes.
And you see in the pancreatic parenchyma, there is a hyperechoic foci, hyperechoic stents. Can you appreciate? Can you appreciate the hyperechoic foci and stents?
Yes, sir.
Can you see the multiple collaterals?
Yes.
Inside the pancreatic parenchyma that indicate one of the vessels is blocked. And if you look at here, I can't see the SMV. Is the SMV is thrombosed in this case? Okay, can you see the SMV is not visualized? You see the thickening of the stomach and the duodenal wall? Here. This must be the pancreatic duct. Yeah. So one of the very important information, if you look at here, you have seen the CT scan and MRI. So I think that when was the CT scan was done? 1 month back, na? So now most likely this collection, what was shown on MRCP and CT, has resolved. Can you appreciate here? This is the most of the
Dr.
contents
Rajesh?
are solid. Can you appreciate here?
Hello.
Yes.
Yeah, is there any quick mass in the red pancreas
No, there
that
is no
looks
mass. There is no mass. Can you see this collection is now more of organized, is like it has given away, and that's why now the solid component is there. It got infected. Is the patient running fever? No.
Dr. Rajesh, can you hear me?
yes.
I can hear you.
Yes. The Manoj is asking, is there any mass lesion in the pancreas head?
No, I don't see any mass lesion in this. I don't see any mass lesion.
Hello.
Am I audible?
Yes, you are audible.
So can
Yes.
you see this is the collection? Can you appreciate the thick wall of the stomach, so thickened? The entire wall is thickened.
Now your scoop position is in. Dr. Rajesh,
Yes.
hear me?
Am I audible? What is the question? My scoop is in the stomach. नहीं आ रही?
Presently, scope in the stomach.
There's a lot of food. You can't do anything else. Am I audible there?
Yes, Dr. Rajesh.
So if you look at here, this patient has a dilated pancreatic duct. This patient has an SMV thrombosis, and the collection appears to be, it looks like that collection has given away. It is not anechoic, what was seen on the MRCP. If you look at the MRCP image, it appears like a clear cyst. But now, it is not. It is like it has given away. Any question?
Puri sir, what is your advice for the further treatment of this patient?
This patient should be treated conservatively. I don't think any scope of endoscopic intervention in this case. This patient
There are a lot
doesn't.
of collaterals.
Yeah, not only collaterals, he don't have any well-defined collection which requires to be drained. He don't have
Have
any
you seen the
well-defined.
portal
Organized solid collection, I think.
Can you see the CBD also here? This is the bile duct.
Yes.
This is the bile duct.
Okay. And
This is the bile duct.
now we are seeing video from other OT.
Okay, so Are you listening to me? Can you hear me?
Yeah, Dr. Mohan.
Yes,
Yes, you
yes.
cleaned the esophagus now.
Yeah, so it's now, you can see completely clean.
Not
It took
very clear.
yeah,
Yes.
half an hour, but that's the prerequisite. You cannot do
Okay, okay, okay.
a poem with food inside. It will go into mediastinum. And see the mucosa, there is a vessels which can be clearly seen. So this is a healthy mucosa, unlikely to be fibrosis. So I measured the G junction. There is slightly sigmoid shape. You can see it's not straight. It's taking a shape to the left and then it's going there. And I'll come around 7 to 8 centimeter proximal. So this is the at 7 o'clock you can see the bulge of spine. So that is posterior. So you can do only either anterior or posterior poem. Posterior is 5 o'clock, anterior is around 1 to 2 o'clock. So we'll start doing posterior poem, and if we have many other cases, we can show other. So first thing is to inject. I think all of us know this procedure very well. So you can see I'm injecting and then pulling back so that a good bulge is created. And once this bulge is created, then what we will do is we'll exchange the accessories to the TTJ knife, or you can do hybrid knife, whatever knife which is preferred by you, you can do that.
Mohan,
Yes,
Mohan,
yes, yes.
Mohan, asking what is the advantage, disadvantage doing the anterior posterior?
Yeah, so
And what is your preference?
yeah. So
What's the
posterior
difference?
is much easy. You can see our accessory come at 7, and our area of interest is also almost 6 o'clock. While if you are doing anterior, the accessories is coming at 7, and you have to take a bend and come like this. So there is a bend.
Okay,
So for a beginner, if there is a mucosal incision or there is a submucosal dissection or you're cutting muscle, you tend to fall down. And if you fall down, you will cut the mucosa. So for a beginner, this may be slightly difficult, while posterior poem is much easy. There is no angulation there. So that's why for a beginner, it is important to start with posterior. And you can see here, I am doing a cut, a mucosal cut, which is around maybe just equal to the
Mohan, is there
scope
any
thickness.
difference in the outcome?
And you can
Any
see now,
difference in the outcome?
outcome we'll discuss. So I'll
Yes,
just
yes.
explain this step. You can see this for
Okay, okay,
beginner,
okay.
very
Yes.
important to have a proper cut at the V. You can see I'm doing slightly transverse cut there. So don't push your scope. Do this type of cutting underneath. You can see I'm doing this type of cutting underneath. And then once you do this, your scope will slide in like this. See that? So that's the easy method. And then once you are in the tunnel, then you can do just a very quick tunneling from.
Stomach wall at the site of collection.
So you have to just see that now this is the muscle layer. That's the muscle layer, and you can do tunneling from right to left or left to right. I'm using the spray coagulation in YO3 machine, and I will keep a close watch on the muscle layer so that I don't go into the wrong direction. If I am seeing the muscle layer, that gives me an idea where I am going. So injection, please. So we'll keep on expanding this submucosa and keep on going like this. So you can see here I'm starting from one corner. Even there is some injury to the muscle, there is no problem. But I keep on exposing the circular fiber so that I have a proper close out. So I have close. So that's how you have to keep on going. And then once you finish your fluid, you inject. And then again you are ready to go from one end to other.
Hi, Mohan.
Yeah, Amol.
So, can you tell us how you maintain your direction within the tunnel? Because that is, I think, one of the other challenges that beginners face.
Yeah. So Amol, fantastic question, and you can see there are two fibers. There is one circular fiber below, and I can make a imaginary perpendicular line to the circular fiber, and that directs me to there. And then there is an aberrant longitudinal fiber. So this means that you are very near to the G junction. So I keep on following the circular fiber out. So we'll keep on doing this. you are right at the G junction now. You should not bother about these small vessels. Out. These can be removed very easily. Out. The dissection should be very precise so that you are out slightly. So I'll burst this vessel and then we'll keep on going down. So this is for me. Yeah, this is the G junction. So we'll inject. So inject, expand the G junction. You are very close to the G junction. So I see that I'm doing superficial muscle burn to expose the circular fiber so that I know where I have to go. Because here the disease in the mucosa, muscle. So you can damage the muscle slightly, but don't damage the mucosa. So that now we are entering into the stomach. You can see it will gradually widen, and I'll push. See that that's a salmon color mucosa there. I push it here and push it with water, so it runs away from me. I am not supposed to injure the mucosa there. So I'm just cutting onto the muscle like this. Even see that this is the real G junction here. So I'll just.
The earlier part was the tight LES, just proximal to the G junction. So the LES tight LES can be a little bit variable in length sometimes, and you may have a long segment which is tight.
So here the dissection should be very precise and not to injure anything. This anatomy is very important. See here we cannot see any submucosa. So I'll inject. Inject please. So whenever in doubt, inject. That is the dictum of third space endoscopy. Define your layers. So I'm defining the layers. This is the very tight G junction. You can see.
Extremely tight. It's still.
See that where is the submucosa? The vessel is guiding. Here is the submucosa. So I'll tell you, this is the mucosa, this is the vessel going into submucosa, this is the submucosa, and this is the muscle. So you have to inject, expand the G junction like this. And once it is expanded, some of the muscles which are very close to the mucosa will go away. There is no problem. So I'm just cutting, and going into the stomach. See that now we are in the stomach. But once you are in the stomach, go to the lesser curve on the right side. Inject, please. So I'm not going towards the greater curve. I'm going towards the lesser curve. And Dr. HP was asking, what is the difference between anterior and posterior? So this is the difference. In anterior, you are not bothered about going into lesser curve because there are no sling fibers there. But once you are doing posterior poem, you are bothered. You are bothered to go onto the lesser curve because you don't want to damage the sling fibers. So once you are on the right, see that on the right on the lesser curve, you are okay.
So Mohan, what is your thought about the perforator? We have not seen the perforator yet. I believe you've gone straight to the right side. That is the reason probably you might have left them on the left somewhere.
Yeah, so that's a very important point, Amol, you have made. So we should not bother about seeing the perforator. But as you have said, I am right from the beginning onto the right. I don't see the perforators. But if I see, I can demonstrate that. And you can see the dot vessels. They are very classical of gastric cardia vessels.
Those are the spindle-shaped vessels on the muscle layer that you can see.
And here you can see there is some, but it is not a very big one. Inject. So now what we'll do is we'll not dissect for the perforator, but we'll dissect up till what time we want to go. See that these dot-shaped vessels, can you see the dot-shaped vessels over there? These are the vessels which will tell you that you are in the stomach. And if you come here, see that there are no vessels on the mucosa, almost no vessels. But as you come down here, you can see a vessels which are ending here. So these are palisading vessels on the mucosa. So these end at the G junction and the cardiac vessels begin there. So that is the stomach, this is the esophagus. So that's very important to know whether you have gone enough into the stomach or not. And once you come out, you will know that by following this blue line, you can see that this is the blue discoloration which has dipped down into the stomach, gradually going down, and you have come almost 1.5 to 2 centimeters. So what we will do is we'll cut the muscle here, and then what we will do is we'll extend our incision by a centimeter. So you can see this is the mucosal defect. We have gone into the tunnel, but we'll not cut the muscle right from here. We'll give a gap of 1 centimeter to create a flap wall, and then now cut the muscle. So we'll start cutting the circular fiber like this, and you can see I'm
Mohan,
exposing the longitudinal
yeah,
muscle.
Mohan,
Yes,
can I ask one question, Mohan?
please, please.
How deep is your tunnel beyond G junction?
So
How deep you go
About one
tunneling
and a
into
half
the
to 2
stomach?
centimeters.
never more than 4 centimeter. That is dictum, and never less than 2 centimeter. I think 2 centimeter is the ideal because everything heals. So we don't want the fibrous scar to be strong to cause recurrence. See that up till now I was preserving the circular fiber or longitudinal fiber. I'll now do full thickness cutting like this. See that? You can cut like this, and you will go to the G junction.
Is it always necessary to do the full thickness, Mohan?
It is safe.
So now
Or just
I'll
doing the
ask
circle five?
HP, you can ask, then I'll ask Bhagwan's concert. Bhagwan is also asking. Kindly go ahead, Dr. HP. You can see now we have reached to the G junction and mucosa is very close. So you have to be very, very cautious. I'll go from above downwards to protect the mucosa. I don't want to hit the mucosa. And I'll go to the right corner at the G junction like this. And this is our bottleneck, which is causing the symptom. So a very, 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 very small burst. See that? And then that will open up. Open. So now we have reached almost to the our tunnel end, but we'll go as we planned. That will go 1 centimeter more. Here you can see now this is the end. I'll inject, expand the submucosa so that I can go 1 centimeter more. Now, so this is the muscle layer. So without dissection, you can do this type of myotomy at the last part of the stomach. See that that's the peritoneum down, and this is the muscle, and that is the submucosa. We have not even exposed them. So I'm just cutting for 1 centimeter, 1.5, not more than that. So I'll end here. So this is my end point. See that that's completely opened up the tunnel like this, and you come out and you will see the G junction wide open. So that's the end. So now you can see there are three. So there are three zones. Here you can see the mucosa which is covering the muscle, and muscle is completely cut. And then second zone is the flap wall zone where the muscle is intact and mucosa is intact for a centimeter or so. And then there is a zone where mucosa is gone, but muscle behind is completely intact. So that creates the safety zone. So now we have seen, we have completed the procedure, and we'll quickly close this. It's required 3 or 4 clips. Again, posterior is much easy to clip as compared to the anterior because clips are right in front of you at the same level, and you have to just go to the corner and clip. So Olympus clips are cheaper clips. They are reusable. The handle is reusable, but the drawback is the rotatability. There is less rotatability, and the open and close. Open close. So open close is difficult. I mean, not possible at all. Once it is open, it's open forever.
The mucosa is thick, very thick. Sometimes we use single use clips.
See that both the edges should come inside. Tail is sharp, yes. So you can see it's very, very important to have a nice, clean mucosal incision. Because if the mucosal incision is clean, your closure is very easy. So we'll go now very close with the scope shaft and then do suction there and apply like this. And slightly tangential, better, so that it covers more part. So almost 4 or 5 clips are required usually to close this. And I'll go, see that I don't apply from a distance. I go with the shaft there, press, suction and close. So that's the technique. Don't apply from a distance. If you apply from a distance, your force exerted on the tip of the clip is less. So always open the clip with a distance because they require some distance to open up. You cannot open like this. So you have to open in a tunnel, in a long lumen like this, open. Once it's completely open, you align it with and then go with the shaft and then suction and apply. So that's it. So this is our end of procedure. Thank you.
Excellent demonstration, Mohan. It was very quick procedure, and you took longer time in cleaning the food than in the procedure itself.
Yeah, and I'll advise everybody to learn this procedure because this is the procedure where we understand the mucosa, submucosa, muscle anatomy. Majority of GI disease are now tackled not like cutting the organ. It is separating the gut wall. If there is a ESD, you can make a tunnel, preserve the muscle, cut the mucosa. Similarly, if the muscular disease like a pyloric spasm, preserve the mucosa, cut the muscle. So one has to understand this, and poem is the most easy procedure to understand. If you do 20 poems, your easy ESD rates will be much better. Your other procedures, even for say for example, duodenal ulcer bleed, your confidence level will be much, much higher.
Mohan, during tunneling, you didn't encounter any vessel. Is it technique or it was your luck?
Bhagwan was there. But if you are using spray coagulation, you can use the spray coagulation is more coagulation, less cutting. So you can once you are doing dissection, these are encountered within the dissection. You need not. But if there is a bigger vessel, say for example a vessel which is thicker than the blade or the shaft of your TTJ knife or hybrid knife, then it is time to exchange, because if you do cut and then there is a lot of spillage of blood, your demarcation between mucosa and muscle will go away, and then if you are a beginner, the procedure difficulty will increase.
What is your protocol post-procedure, post-poem?
So Amit is also asking. So Amit's question is, what is the GERD rate after poem? So GERD rate of poem is much lesser, as has been shown by many now newer studies, because this is limited hiatal dissection. In left fundoplication, you come from peritoneum, you dismantle the esophageal attachment to the diaphragm, and then there is lot of anti-reflux mechanism which are dismantled. And that is why they have to do fundoplication. While in poem, it is only LES is cut. And we saw how not to go too deep into the stomach, one, and two, how to preserve sling fiber. If these are followed, the reflux rate is not more than 10 to 15%. Yes.
Mohan.
Yes. Yes, yes.
But
yeah.
See, it is also said that although if you document actually by manometry all these things, the incidence probably of reflux is more. But sometimes somehow or other the symptomatic reflux is less common in these situations. What is the reason? What mechanism is altered that you have less symptoms in these patients compared to the usual ones?
So, Dr. Jobal always asks a very scientific question. So, the question is, why the patient are not troubled, they are not complaining of reflux, we have done 5,000 poems, but the manometry is showing 50% reflux. How this mismatch? So, what we are doing is extrapolating our the pH metry results of a normal esophagus, like a good peristalsis, into the esophagus. That's why the acidification in esophagus in achalasia may be because of stasis, maybe because of fermentation. These all are picked up by automatic machine as reflux. While that is not reflux. Reflux is only when the acid is coming from stomach into esophagus. So that part, if you somebody sees carefully, manually the pH metry, then from 65% in our study, the automated machine said there is acidification in esophagus. But we manually counted, it comes to 30% because we ruled out, we cancelled the fermentation pattern, the even if you do not a good myotomy and if you eat acidic food, that will be picked up by a machine as reflux. But that is not reflux. So in that way, if you do proper manual evaluation, the pH metry results also correlates with the symptoms, like 30%, not more than that.
Yeah, Mohan, I think that's a very important point because reading of the reflux episodes is very important because if there is a flat line and a gradual drop and only 0.5 or so, then that is more often because of fermentation.
Yes.
And if there is a rapid drop, sharp drop below 3.5, then it is probably a two reflux event.
But the automatic machine,
Automatic
everybody
machine,
says.
everything catches up reflux. And the other thing is probably mucosal sensitivity also has changed
Yes.
in these patients because of long-standing stasis.
Yeah,
So that's
yeah.
also one of the reasons.
Yes.
Mohan, is it that I wanted to know when should one start combining fundoplication with poem? How do you choose which patient you will do?
I think that
And who should, after how many poems one should start venturing into F?
I think Amol is the expert, but I will say that we have almost stopped doing fundoplication with poem because of now the new methods of not going too deep into esophagus, stomach, preserving ceiling fibers, and studying the manual pH metry. So what we do is we do posterior poem, and if the patient has post-operatively more reflux, then we may advise them either surgical fundoplication or endoscopic fundoplication or a device-assisted fundoplication. I think this can be a second procedure, not the first procedure.
There is still a lot of debate on that. And see, we are still, OMF has come in just a few years ago, 2-3 years ago. Just recently, this year, we will be presenting our data on the 3-year follow-up. I think Inno is also developing, they've got some data as well. Thing is, nobody knows yet whether it is required for every patient, and this debate is not just for poem. Let us remember that this debate has raged for the last 60 years, in surgery as well. So in Heller's myotomy also, whether fundoplication should be a norm or not, even after 60 years, nobody is sure. Most laparoscopic surgeons would do it, no doubt about that. But remember that it is not a norm, and there is a very nice editorial in 1987 which was published, which actually shows that very well. So nobody knows about that. Now we are probably coming out with a multi-center study, a prospective study to compare OM versus POMF. Probably Mohan will also be part of the study, meaning we are doing a kind of a this thing. But I think it will be another 3 to 5 years where we can give a guideline as to which patients should go undergo as a primary procedure versus later on, that kind of a thing. Currently in our unit, we are giving this option to the patients because some patients ask upfront. Because nowadays on the internet they can read and they will ask about reflux rates. So we tell them, okay, if you don't want want lesser risk of reflux, we can do a OMF prophylactically for you. So we have about 50% patients who choose that.
The second case, the other case in OT is getting ready. Till then, I think we can ask both the experts. How do you follow this up? When do you allow orally? Do you always do a contrast study next day or when?
So it is not mandatory, but majority of our patients come from, say for example, northeast or traveling from thousands of kilometers. So they want to go home, catch the flight. So that's like a double check for us to do a barium test to see no leak. If the patient is within the vicinity of hospital, we discharge them in 48 hours, but ask them to be in the follow-up. But if the patient is coming from very far away, we definitely do a barium.
Barium or you
We
gastrography?
do barium to see the also the patients, the stasis factor we can compare. We are doing under protocol also, but that cannot be recommended everywhere. But a leak test, whether it's barium or contrast, should be done if patient is not within the, is not within reach of hospital, or is going, it may take 40 to 72 hours for him to reach. Otherwise, not indicated.
Actually, Mohan, we stopped doing, contrast swallows after the first initial 1 or 2 years, and for the last with 1,000 odd cases, we have not done 5,000. We stopped doing a contrast swallow unless we have an intraoperative doubt about the closure.
But that is with experts like you. For beginners, I think one doesn't feel confident start feeding the patient unless we have seen that there is no leak.
No harm.
Hari, any questions from the hall?
Mohan.
Yes,
Manoj.
Yeah, Dr.
How often?
Lavati.
Yeah. How often you encounter hypercapnia, and you have to stop the procedure temporarily?
And many times, that happens because if
So
there is a lot of submucosal fibrosis, or you are taking a sigmoid esophagus, or otherwise also there can be, depending on the body habitus, the pulmonary function test, there can be hypercapnia. The ET tube which we have a CO2 monitoring there. If EtCO2 goes above 50, we stop the procedure for 10 minutes, wait for some time, and then go ahead. That happens, but it's not common. Maybe beginner it may be more, because many things goes in our mind. We are worried about the complication. We are doing procedure very slowly, but that is a part and parcel of the procedure, and one should not get worried about it, but very cautiously. If your anesthesiologists are trained, they will tell you, okay, stop for some time, and as the experience increases, the rate of hyper EtCO2 going high decreases drastically, because you are not worried about many complications, you are well versed with the anatomy, so that is directly proportional to your experience.
I think we all will clap for Mohan and team, and we are moving to roti. That was a wonderful demonstration, and in spite of initial hiccups, because patient was not probably truly fasting, or maybe because of esophageal delayed emptying. So wonderfully done, Mohan. Thank you so much. And we are moving to the other roti. Naveen, you can ask Neha to present the case.
So, am I audible?
Yes.
So, we are presented here. We are
Yeah,
live
time
from
to change
OT2.
our
A 56-year female presented with us a moderate
ESG.
obesity, weight
I request
95
Jayant Yadav,
kg,
sir.
and her weight is
I
37.
request Jayant Yadav, sir,
Her
to
BMI
present a
is
memento to our
37.
chairpersons.
He tried a lot dietary modification along with exercises for last 6 months but could not lose the weight. So the planned procedure is ESG, and now we are live to the OT2.
Jayant Yadav, sir, please. Arvind Namde, sir, please. Sunil Kasturi, sir. And for the next case, I request Dr. Rajiv Jain, sir, and Dr. Rajiv, please chair the session.
Dr. Rajiv Jain is a senior surgeon from Vidisha, Madhya Pradesh. Dr. Rajiv Pathak sir is senior surgeon from Satna.
Hello, Mohit. Yeah. Mohit? Can you hear me? Hello.
Can you hear us?
Yeah.
Are you able to hear Dr. Mohit's voice?
No, we are not hearing Mohit.
Okay, you are able to see us?
Yeah, we are.
Okay, are you able to see the endoscopy picture also?
Now.
Yes, you are able to see the endoscopy picture?
Yes, Saransh, yes.
Okay, so we are in the stomach. We are using a double lumen 2T therapeutic scope made by Olympus, and this is like 180 series, 190 series. And this is an Olympus system 190 which we are using. We have loaded the Apollo endosurgery suturing device on this system. And this suturing device, if you can focus on Dr. Mohit's hand, has a handle, a helix, and a needle exchange catheter. So the handle attaches to the tip of to the suction port, and the helix and the needle exchange catheter go in one of the suction port each.
Okay. Now can you hear me?
No. So Dr. Mohit is presently focusing on the incisura angularis, and that is the demarcation between the body and the antrum of the stomach. And we start from the interior wall of the stomach, which is the point of joining of the incisura angularis with the interior wall.
तेरा वाला mic दे दो. Okay, so thank you very much. There was some problem in the voice. The important concept here is that identification of incisura. So the first mistake most people would do is they might start from here. This is not the incisura. That's the pylorus, and we have to pull back. And when we come here, that's the incisura from where the surgery has to start. So we are not going to take sutures onto the antrum. Now, this is a very simple system. You load the needle like that, and then you simply pull it and unload it. So that's the principle. But before loading the needle, the important is that you need to prepare a loop. So I just prepare a loop like that. This is the Apollo overstitch device which we are using. And then once this needle is loaded, now we'll start to suture. So we are going to do exactly like we do in laparoscopic sleeve, make a small, very small tube out of this stomach. So you can see that we have taken the first suture, and this suture is full thickness. I'll demonstrate you that it is full thickness once we take a complete layer. So you see, this is a very thick bite which we are taking. Bindu is assisting me today. Bindu is probably known to train most of the gastroenterologists who are starting to venture into ESG in this country. She is a fantastic assistant, so I have no problem whatsoever in doing this case. You can see that I am preparing a C loop or a U-shaped pattern, and now I am just following the vertical part of the U. So 3 sutures I have taken, and you can actually understand the thickness of these sutures which I am taking. Attention has to be paid on my body movements and my hand movements. So you see that I am trying to pull tissue towards me as much as possible, and so that the bite is thick. And if the tissue is not sufficient, I'll go close, re-angulate myself again here, and then pull the tissue. So now you see this is a much better, just like in general surgery or in laparoscopic surgery, we need to be cautious about the fact that we have to be very nice and gentle with the tissue. If the tissue is not coming to us, it means we are holding on to a wrong place, and that should not be done. So again, as you can see, I will not take tissue which is not coming to me very easily. Now we are at a very important juncture where I would want to explain that we are not going to go towards the tissue which is on the right side of my ear. So this area here, if there is an outside camera, right? So this area here, this is the incisura. when we do sleeve gastrectomy, we do not block this area. So similarly, I'm not going to go onto this area to suture. This would be the area I would spare always. I would remain away from that area. So I go here, take a full thickness bite.
First load.
So now I think you can appreciate the thickness of these bites. So, at this stage I need not go here, but I have to go posteriorly. So I'll just turn back here.
Sarans, what is the thickness of this bite? Sarans?
So
Sarans.
we like to screw in the stomach. So we like to screw in the stomach. So when you look at the next bite, he will be using a special device known as helix. Helix will come out. The assistant will rotate the helix 2 or 3 times till the stomach wraps around the helix. And that means we have taken up the muscle layer because mucosa won't wrap around the helix. So once we taken the muscle layer and take a bite, that would be a full thickness bite.
At the level of muscularis, as Saransh said, the thickness is around 1.5 to 2 centimeters. That is the thickness of stomach tissue. The moment we go to beyond 2 centimeters, we will go beyond muscularis, and that's something which is very dangerous. So that we should avoid. At this point of time, I have already made the vertical part of the U, and then I'll now go up for the. Okay, just relax it. Leave it.
This was a very good example what he did. Initially he tried to take in the muscle, but it was a too thick bite and it was not coming in easily. So he let go of that muscle and then took a bite so that muscle comes in very towards you. So it is very important that the tissue comes in easily. Otherwise what happens is you might have taken something that is beyond the stomach.
You might take vessels, you might take pancreas, even colon, because stomach is hyperinflated. So what I do, I would, if I feel that there is a little bit of to pull the tissue towards me, I would just leave the helix there and there itself and will take another bite. So for example here, this is the area of the greater curvature. Have to be very cautious about transverse colon here because this is a very hyperinflated stomach. And I would not want to continue the procedure under hyperinflation. I always deflate it transiently so that we do not take any tissue which is not advisable to take. So at this stage, I would drop my needle here. You can see we have got a very nice thickness, good vertical U, and I will drop my needle here. So just to drop the needle, you press the blue button and the needle gets dropped. And then I can deflate it completely. And now what I wanted to demonstrate is, you can see that this is a very thick bite which I have taken. Otherwise, I cannot hold it with my hand with the weight of the scope. Can everybody see this? So that's how robust these bites are. If they can bear the weight of the scope, these bites, the food coming through the stomach passing off through this particular tube is not going to break the sutures. These are going to be permanent sutures with fibrosis. Now, what we are trying to do is very simple, trying to cinch and then maybe, clip the suture at that area so that it stays there. Just like taking a knot, we cannot take a knot here, so we are cinching the suture. So this device is known as a cinch, and to be very simple, it just locks the suture in place after I have tightened it completely. So now you can see a very nice one layer is taken, and you would now appreciate how we are going to create this tube. So already the stomach has started to create a sort of a structure, a 3D structure, just like a gastric sleeve. These endoscopic sleeves are tighter than the laparoscopic sleeves we create. In most cases, they cause more nausea post-operatively and they cause more weight loss. It is the technical aspect of these sleeves where if you do it with a nice full thickness bites, they give results equivalent to surgery. So again, now we are taking the second layer. I previously explained that we're going to create a loop, and that's the loop which we have to create. I will start another layer now. So let's go closer. We will not do anything without seeing. So I think that's the area from where we have to start. So let's go here. Okay.
So you can see in the stomach, the folds are still preserved. So you can always know when you have hyperinflated the stomach, you won't be able to see the stomach folds. So whenever you feel there is a position you are not able to see the stomach fold, you suction and remove the excess air.
Also, as you can see, this tissue is very easily coming to me. I don't have to sort of move a lot to bring the tissue in, and just see the way I'm moving my body. I can accommodate the full thickness. So there are two important motions which gastroenterologists should know here if they want to learn full thickness suturing. The first is the position of my body, how flexible I keep my body here. I can take sutures anywhere. So for example, I want to take a suture from here. I pull this here. Now this is not good. So what I do, I go like that, rotate my larger wheel and take this bite. So in the entire process, my body is moving all around. I cannot just stand at one place and expect that the sutures would come. The other way is to twist the helix and bring all of this, towards you. I don't prefer that technique. I prefer that the gastroenterologist or the interventionist should move all around, because that gives a much better apposition of the tissue. It's what we have learned. Again, I have done the vertical part of the U. We're going to go here, load the device. Some more air inside. I think I'm losing some air. I just need a little bit of more air inside so that they can see the structure. I can manage on this, but they need to see the tube. Okay. So now as we see, also one of the very important aspects is till the time we see the area from where we need to take the suture, I don't take the suture. Yeah. Can we have an increased flow, because I don't think there is air inside. Okay. No? It's going, no? Let's continue. Okay, so now as you can see, I'm here. Again, the vertical part, it's very clear that these are very full thickness full thickness sutures. I can go a little bit on this side and take one more, and then I can create a U. Now it's nice. Now it's looking very well. Okay. Take it from here. So when I create a U, I go absolutely on this. This is the posterior part of the stomach. So you can see this is absolute posterior. And we go this way. And I just dip my scope like that to get a nice bite. This is one area one has to be very cautious about getting the pancreas. We have had cases where we have got pancreas in the suture and it bleeds terribly. It's the posterior part of the stomach. Again, now I'm not seeing anything. I would go deep down there with my scope, just like we do with laparoscopy. And once we see where we are going to take these bites, we'll start taking the bite.
So lesser curve is also the site of left gastric vessel. So it is also important to take note of that point. That is why there is a chances of bleed if you go more posteriorly also. And he is stopping just in time to go back and take a U-shaped sutures back to the interior wall.
It can be a little difficult for some of you to understand this anatomy. It takes a little bit of time to orient which is the lesser curvature, which is the greater curvature. uh, which part is the part of the stomach. So the rule is the part of the stomach facing my right ear is the lesser curvature. The part of the stomach which faces my left ear is the greater curvature. The part which faces my forehead is the anterior wall of the stomach. So that's a very simple way to identify where we are headed to. I would go above this suture. So if you can see, I started from here. To create the tube, I'll go above here. You want a little more.
So you can also see that he always keeps the two sutures parallel to each other. They're not crossing any time when he is doing the procedure.
Here is the second layer, and you can see very nice lumen there. It's a small lumen, not a very large lumen. We'll show you on a single lumen scope. Again, these are full thickness bites. You can see I'm holding my scope with the suture, so which means that the bites are very nicely taken. I have not taken any tissue which is just breaks through or anything like that. Then I'll cinch my suture here and lock it in place. So this white structure you see is the tag which we're going to fire, just like a clip. Okay. So it makes the suture stay there. Again, these are two layers taken. I'm very happy with the thickness we have. I'll take the scope a little bit back so you can now appreciate how the tube is being formed. Now I have to start from this area again. She has a little bit larger stomach. We might end up doing 6 layers in this case. Also, we asked the anesthetist to give Buscopan so it enlarges the stomach. So you have more time to understand how I'm taking these layers. There are some where we have to take just 3 sutures and the whole stomach is narrowed. There are some where you might even require 8 to 10 sutures. The stomach anatomy is so variable between different individuals. No, leave it. Okay, so now you can see when Bindu is pulling it, I feel a little bit of resistance at that place, and I'm not going to take suture from that place. I'll again load my needle. We are supposed to take sutures only from place where we do not have any resistance. Because, yeah, now it's fine. Now it's good. Okay. Good. So you see very nice bite. A little bit of twisting of the greater wheel. Right there. This is the posterior wall. when bleeding starts.
Check, check, check.
The tactile feel of the pull is very important. If you feel that it is coming with pressure or resistance, you should take another bite. Don't force the tissue inside your handle.
Hello. Hello.
Check. Hello. Check one. Check one. Check. Check. Hello.
Go here. Very good. Okay, so here we are at a stage where we can drop the needle again. So nice tube is being formed, as you can see. Nothing demonstrated by a single needle scope, but so we can see that this cinch comes here. And just like a Roder's knot in general surgery, we push the tissue and pull the suture. Okay.
So next time we will show the cinching. The assistant has a good part in it.
Almost at the Z line.
Hello?
Probably one or two sutures and
Am I audible?
nice tube is being seen here.
Hello? लेजर फाइबर बाहर रखें
That's same thing which I did previously. This is going to be a little tricky because usually here the space is limited. There here is. But now I move a little back and you can see, I'll start from here.
Hello.
What you prefer, sir? Buyer guided entrance or
डायरेक्ट इसमें डायरेक्ट खुला हुआ है
लाइव आ रहा है?
हाँ जस्ट पूछ लो
इसको डाल देते हैं ना
नहीं दिखाना पड़ेगा ना इसको Boston Scientific Spyglass DS2 new version with taper tip.
Very
nice view, very nice
excellent
view, excellent view. Hello?
Hello.
Hello? Am I audible? Can
We
you
are
just present
shifting
the
the
history?
case right now.
Yes.
We are in the OT1 and the
Right.
history will be presented.
A 48-year-old male patient presented with the abdominal pain, jaundice, fever for last 1 week. Sonography showed gallstone disease with CBD dilated up to 13 mm and bilateral IHBRD. US showed the choledocholithesis 8.3 mm at mid CBD, lower CBD structures. ERCP was done, showed the distal CBD structure, choledocholithesis, biliary sphincteroplasty was done. Stone could not be retrieved. The biliary stenting was done. This is the picture. Now the planned procedure is spicholangioscopy plus laser lithotripsy.
The procedure will be performed by Dr. Sanjay Rajput sir. Sir, you are live.
Good morning, everybody. I think this is a challenging case because the patient has a stone which was very large and it was pulled down and I think it has stuck to the CBD. We are using, today we are going to demonstrate Spyglass DS2 from Boston Scientific, which is a second version. They are coming up with a DS3 with NBI facility. Now, after this Spyglass, there is lot of changes in the stone management has happened. Because previously we used to use lot of lithotripter, mechanical lithotripter, juggling all around and then putting stent and sending the patient for surgery. But now, as I can say, I am using this for last 4 years and we have not sent a single patient of CBD stone to a surgeon, whatever the size is, because the size doesn't matter in if you have a spyglass. The most important thing in spyglass is you have to save your spyglass also because it is a costly instrument. So the important thing is you should not use your elevator up to this mark because and now Chotu is with me who is my assistant from Ahmedabad. I specially call him because I want to save this spyglass also. So this is the amount which you should take out and I think it is already dilated structure, ampulla is already dilated, so I would directly go with the spyglass and you can see the stone is just above the ampulla. So it is not easy to keep your laser fiber and scope here, so we have to be very careful. And the most important part is you have to keep your scope in your hand. We are using laser. We are using Quanta, a new laser machine, which is very good, 30 watt. See, keeping the scope is the most important thing here. You should keep the scope in center. So you have to keep it in center.
So what laser settings you
Laser
select?
setting, can you just, Sanjay Kumar sir, because I have to focus my hand here and keep it in center.
We are just seeing the Dr. Sanjay.
Yeah, energy being.
Dr. Sanjay.
Hari,
You
we
have
are.
to keep your fiber this much out, always. You have to see the laser all the time. Push karke.
So see how beautifully he has focused the stone right in the center because it is very challenging in the lower CBD. So
Sanjay, we are not seeing the this spy picture. We are
okay.
just seeing the endoscopic picture only.
Okay, just a moment. Please
Just
show
a
the
moment.
spy
Yeah,
picture.
just show the spy picture.
Focus ऊपर वाले को. Actually, there is a challenge with direct transmission from the spy monitor. In the next case, we will be correcting it. He's trying to show you by external camera. Focus करो बीच में.
स्क्रीन पे ही
So,
दिखा दो.
at the moment the setting for laser is at 0.8 joule, frequency of 3 hertz,
पकड़ के स्कोप
and we have basically two modules in this. You can do a dusting or you can use a hard stone. So we will be using a hard stone mode.
So you have to be very careful not to touch the mucosa, and keeping the spyglass is challenging here because the stone is just at ampulla. Yes, Nikal. So you have to always focus. Yeah, it bus.
Dr. Rajput, can we push the stone up and then try?
I think it has impacted there.
Yeah,
so
it
will
is.
not go up.
During our last ERCP,
It will
got
not
impacted.
go up. And the dilatation must have gone because of the stent.
Yeah.
So now you just have to keep it focus here.
Yeah, it is very nicely focused. Yeah. I think we'll have to increase the energy.
Yeah, you can increase. Push.
Increase करो.
छोड़ो, बीच में रख के push करो. बीच में रख. You can see the stone fragmentation coming out. बीच में रख दो. बस, 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 बस. Push करो.
Dr. Sanjay, this is not very tight stricture.
No,
So?
no. The stricture is not tight, but the stone has impacted. Push करके. अंदर बस, बस, बस. Stone has impacted. Here we cannot keep it away. Normally you should keep it 0.5 millimeter away. But here it is just at CBD. So can you change the setting and increase the power?
Yeah.
One कर दो. One कर दो.
Dr. Sanjay,
Yes.
any other option for Sanjay?
Yes.
Sanjay,
Yes, sir.
any other option for taking out this stone? Like, is it feasible to fragment by lithotripsy? With this
Lithotripsy it
stone?
won't help because even the wire was not going. That is what suggested by Dr. Sanjay sir. That it was not even the guide wire was not going above.
Hari, when we tried ERCP in this patient
he could
last
pass
month,
it with difficulty.
yeah,
ऐसे पकड़ो.
the stone came down and got impacted, and with great difficulty we could pass a wire again by the side of the stone. So that was the challenge.
Okay.
So we could not attempt a mechanical lithotripsy as lithotripter will not open in the lower CBD, which was actually a strictured portion. So for lithotripsy, ideal is that you push the stone up and you have to have a dilated part.
So this stone got impacted while removing. By attempting to
Yes.
remove it.
So very nice demonstration. You are exactly in the center. You are trying to create a hole in that, it seems.
Yeah, because here we cannot keep it away. Here with the movement of the patient.
Sir, आपका mic, your mic has. I'll just fix it.
Yeah. हाथ में पकड़ो. See the fragmentation.
Are you able to hear Dr. Rajput? उनकी आवाज आ रही है राजपूत साहब की?
Yes. Yeah. So, if you can show my hand, you have to control the scope with your hand rather than moving the fiber or moving the scope. Because the scope gets broken only when you move too much out, too much inside.
Are you getting the camera image there? His hands?
Yes, we are seeing. Yes, we are seeing.
So here the challenge is you have to keep it focused all over the stone only.
It is still not broken into two.
No, it will broke.
Yeah.
The most important thing is you have to be confident about yourself the spyglass and the laser.
So all is set today.
We have to synchronize with the respiration also, because when it comes out, you have to stop firing. See, like this. Even if the patient is intubated,
See, what the trick is, the assistant is not moving his hands at all, and Dr. Rajput is just rotating the shaft and the up-down knob. Is that right?
yes sir, I have fixed my up knob so that I don't move too much inside. I have fixed my right hand with clockwise rotation, so my scope doesn't move too much. Only the movement is patient's respiration.
Yeah. So this is truly single operator spy and cholangioscopy. That
No,
is
it
what
is,
they recommend. No?
this is double operator, sir.
The other one is silent. He is not doing anything.
Yeah, no.
He's just holding.
Even I am silent, sir. Only the fiber and the patient is moving. So, and this is very hard stone. As you can see, with this much of energy also it is getting broken very slowly. Yeah, it will.
Do you want to increase the energy further?
Maybe little.
Yeah. So it is now delivering 6 watt. Earlier it was working on 5 only. So 1.2 joules.
We can increase, sir, 8 watt.
8
watt. We can 8 or 10 is better because it will break very fast. Yeah, you can change it to 8. See, now it will break. With 8, it will be faster. Push. Push है अंदर ही पानी मार. Continuous irrigation is the wire दिख नहीं रहा. Yeah. Continuous irrigation is the another important part, because if there is too much heat inside, even then the chip of the scope breaks. अभी होगा.
Is it breaking now?
Yes.
We don't see it.
No, it is breaking. It is just
Dr. Sanjay, can
Yes,
you
sir.
ask Dr. Rajput what kind of antibiotic prophylaxis he used to
Usually
prefer
these
for
patients are on
doing such
antibiotic,
procedure?
third generation cephalosporin or imipenem or meropenem, because they have this pseudomonas or high chances of getting post-operative infection. So we always give them pre-op and post-op antibiotics.
Sanjay sir, what are the chances of developing lower CVD stricture after in your experience? After this?
I think they may develop stricture if this stone has been kept too long because of severe inflammation. I think the fiber is not working, sir. We have to change the fiber.
Fiber is not.
Yeah?
Technical.
Yeah, fiber is not working. Can you have, can we change the fiber? Because the fiber, दूसरा fiber है? धीरे धीरे तोड़ो.
8 पे है ना? We can increase up to 10.
हाँ 10 कर दो, fiber
10 कर दो आप.
10 कर दो. 10 कर दो. बस निकाल.
Now, frequencies are 10 and 1.2 joules.
ओके. पुश कर. हाँ वो थोड़ा टूट रहा था. अभी नहीं. हाँ लाइट बढ़ा दो बस. टूट जाएगा. नहीं टूटेगा तो अब तो ऐसे भी निकाल लेंगे. नहीं ऐसे भी निकाल लेगा. चल पुश कर. दिख नहीं रहा. फाइबर नहीं दिख रहा बेटा. निकला?
फाइबर आया नहीं.
हाँ अटक रहा है तो ले लेना. सी वे हाँ यू हैव टू कीप योर फाइबर आउट बिफोर गोइंग इन. चालू रखो. चालू रखो तो पता चल. बस बस.
Dr. Rajput,
Yes.
how long you can perform this procedure? Like 45 minutes or 1 hour or
It
more than
depends
1 hour?
on the condition of the patient and the anesthetist, whatever time permits. Usually we usually prefer to finish the procedure in one setting. But if patient is very sick, we can do this procedure, repeat after 1 or 2 weeks. We usually put 2 stents to prevent cholangitis, and then we repeat it after 1 or 2 weeks. But 90% of the patients,
Now it is getting
yeah,
pulverized.
90% of the patients we usually do in one sitting.
Sandesh sir, can you see ESG picture?
Pardon?
Yes, we can.
Ah, yeah.
Yeah. So, yes. So now we have completed the endoscopic sleeve procedure, and we are now seeing the stomach after the procedure. This is a normal 190 series upper GI scope, and this is the antrum of the stomach. And we will go ahead and give you the picture of the body of the stomach. This is the body which is markedly reduced in the size. There are no gaps that you can see, and the entire body is evenly reduced to a small tunnel.
It doesn't matter.
A
Because
small
anyway
part
we are
of the
putting
fundus
stents. You should
remains,
not
and this is the G
intensely
junction, and
perforate. Because
this is the
amount
small
of
fundus
bleeding
that
is
we
okay
can.
because
We are trying to show, but
we have
it's
increased the joule and
very
sometimes
small.
we touch the mucosa. Yeah, idhar.
So there is no
Yeah,
active
kindly show
bleed.
the length of suturing.
नहीं अभी है ना बड़ा चिपका हुआ है सर ये चिपका हुआ अभी टूट जाएगा इम्पैक्ट हो गया ना वो बलून से खींचा ना बलून से खींचने से क्या होता है वो दोनों तरफ से चिपक जाता है दोनों तरफ चिपक जाता है फाइब्रोसिस भी हो गया उधर थोड़ा सुलाएंगे क्या सर पेशेंट बहुत ज़्यादा मूव कर रहे हैं आप प्रोपोफॉल के नहीं सर बरोबर है सेटिंग मत चेंज करो
Yeah,
टूट रहा
you can show the
थोड़ा
G
push करो।
junction for comparison that
सर
this is the
पैरेलल
stomach and this is
बहुत
the G
ज़्यादा मूव हो
junction.
रहा है
This is
मैं
the
एक
body
जगह
of the
खड़े होकर
stomach,
टिकने नहीं दे रहा
markedly
दोनों
reduced in
तोड़ने नहीं दे
size, and the
रहा
antrum which is
निकल
really big. And I think Dr. Bhandari has done a fantastic job in doing this procedure without any glitches, any suture drop, anything, and he has nicely reduced the stomach. And I think we will have a good weight loss for this patient. Thank you.
Thank you.
पेशेंट को पूरा सर हाँ हाँ क्योंकि पेशेंट का देखो बहुत ज़्यादा मूव हो रहा है थोड़ा सा कम करो नहीं बरोबर है रहने दो। थोड़ा पुश कर दे नहीं फाइबर रहने दे, तो टूट जाएगा फाइबर नहीं दिख रहा बस 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 हाँ वो उसमें चिपका हुआ हिस्सा है ना क्योंकि विजन नहीं आ रहा है ना बरोबर पेशेंट का मुंह इतना हो रहा है तो उसमें विजन खराब हो रहा है हाँ मेरे को उसके साथ सिंक्रोनाइज करके जब वो पास आ रहा है जब तोड़ना पड़ता है हाँ बहुत ज़्यादा मूवमेंट मेरे को इसको धक्का मार देता
That inflammatory infection यहाँ होता है ना that surrounding mucosa will get
ये हो गए
done है
हाँ
What are the chances of cholecystitis in this patient?
very less very less very less it happens but very less निकलता है इसको मैंने ऊपर पुश कर दिया अभी थोड़ा
हाँ
Yes, sir.
now better position
मैं बाहर ही हूँ हाँ बाहर ही लेकिन क्या पेशेंट का इतना ज़्यादा बस बस सब उतना थोड़ा सा ट्रॉमा होता है
ठीक है
उसको थोड़ा पुश कर दीजिए क्योंकि थोड़ा टूटा था ना तो उससे मूव हो गया
How much fluid should we irrigate so that we should avoid hyponatremia? Any guidelines in this aspect?
Nice. See the impacted stone. See the amount of impaction was so much that it has almost fibrosed.
Yeah.
I think now this will come out. दो तीन टुकड़े हो गए इसको तोड़ना है
इसको तोड़ना है
इसको तोड़ना है इसको अच्छे
This
से
is the
तोड़
better
या दिस इज द बेटर निकल।
Now it is visible. Yeah.
उसको धक्का मार दिया ना।
हाँ सर।
थोड़ा ऊपर रख, थोड़ा ऊपर रख, मेरे को जाए, नीचे मेरे को जाए, बीच में रखो बस, उसको बीच में रखो, मेरे को ही करना पड़ेगा। चलो ओके, राइट, बस 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 बस।
Now it is.
अभी टूट जाएगा सर, अब टूट जाएगा, अब अच्छे से टूट,
अच्छा टूट
यही सब ट्रिक होती है स्पाई ग्लास में, यही सब ट्रिक होती है, कब आपको ऊपर ले जाना, कब नीचे लाना।
For your hand movement is very important.
यस,
Soft movement.
थोड़ा राइट, बस बस बस, आगे रख।
Any questions from the house?
थोड़ा पोस्ट कर।
Hello.
Yes, Sandesh.
Colonoscopy pictures are.
Would you like to combine balloon infiltroplasty with this procedure?
Yes, I think so, because it is almost half now, and I think if we break more 2 or 3 pieces, this in 2 or 3 more pieces, we can do that. थोड़ा पीछे, ऐसा पीछे, दिख नहीं रहा, थोड़ा पीछे। The bleeding which we are seeing is because of fibrosis. We were hitting at some places to the CBD also, and
Sanjay sir,
yes sir,
I am Dr. Lavkush Tiwari speaking here.
हाँ बोलिए तिवारी।
Actually, I want to ask a very practical question, sir.
Yes.
Since this procedure is already a very costly procedure, sir.
Yes.
And if we are dealing with a stone of 3 centimeter or 4 centimeter and the hard stone, sir,
Yes.
then sometimes it happens that we have to use the 3 or 4 electrodes.
No, no.
In
Laser
that
fiber only
condition,
one.
how will we explain the patient regarding the price? Or so how we have to counsel the patient before starting the procedure,
I
sir?
think at our center cost does not matter. At our center we have a policy that even if patient don't have a single pie and patient is needing this therapy, we can do it free of charge. So cost is not a problem. Problem is whether you have another spy scope or another therapeutic scope with you. See, the bleeding is there from the ampulla. So we will do a CRE, we'll stop this bleeding.
But Sanjay sir, I think multiple fibers are not needed. We
No,
can
no,
do one.
no. Only single fiber will do.
So cost.
If you use EHL, then multiple fibers may be needed because EHL is costlier. Here in laser, you can use only one fiber and you can cut it once it gets broken from tip.
CRE in this case also.
इसके बाद आपके पास मेटल स्टैंड है क्या छोटा? 10 से
कवर मेटल स्टैंड।
हाँ, इसके अंदर डाल के उससे लेजर दिखाएंगे। हाँ सर, छोटा मेटल स्टैंड है 10-4 या 10-6। हाँ तो उसको लाए तो उसके साथ इसको डाल के अंदर से लेजर करेंगे। देख लो, हाँ वायर दिखा दो, IIT लगा दो।
बता दो। So CRE fulfill two purpose.
Few of these patients where the CBD stricture is very tight lower down, we have a policy of putting a metal stand, covered metal stand lower down, and through the metal stand we can do the ERCP.
From where the bleeding is?
Yes sir, ampulla में से।
How come from ampulla?
वो बंद हो जाएगा, trauma।
नहीं, I mean we were working inside, no? So
नहीं,
we have not done sphincterotomy today.
नहीं नहीं,
sphincteroplasty,
it
nothing.
will stop। CRE ले, वायर गया, वायर बता दो, वायर दिखा दो, इधर इधर, पीछे लो, वो CRE बलून भी दे दो और वो भी लेके आओ, स्टैंड, कवर्ड मेटल स्टैंड भी लेके आओ। So 10-11 बार। 10, 11, 12, 10, 6 का
Try to
स्टेंट
inject adrenaline, sir? No.
आप मेरे को खाली मेटल का स्टेंट ला दो तो ये बड़ा करो एंडोस्कोपी पिक्चर देयर इज सम ब्लीडिंग अराउंड एम्पुला so I think we will do a balloon compression and if it does not stop we will put a metal stent and it will stop and then we can do the laser lithotripsy through the metal stent.
वायर के ऊपर
हाँ वायर ऊपर हाँ सीआर हाँ स्कोप के थ्रू मेटल के थ्रू हाँ इजीली
Shall we wait for some time after doing the CRE if the bleeding stops?
Yes. We'll wait for 2-3 minutes. And mostly I think with balloon shape the stone also might come with the CRE. Yeah, because it has been broken in 2-3 pieces. We'll do a cholangiogram with the same balloon while putting this CRE. We can do the cholangiogram through the CRE. Yeah, so we will use this adapter. We'll use this spy scope adapter and put the balloon, put the contrast through the this CRE balloon only. You can put it through the wire, with the wire inside also.
We'll do that.
First we will see CRE, we'll see the bleeding and then...
It seems the bleeding is already stopped.
Yeah,
There is a clot there.
Yeah. खींचो वायर छोटो वायर खींचो नहीं वो वायर उधर ठीक उधर तो ठीक अपने को इधर देखो छोटो वायर खींचो नहीं चलेगा सीआरई चलेगा so during putting this CRE balloon you have to be careful not to lose the wire because once you lose the wire you will not be able to go again in the cloth. So you have to very carefully push it. You have to see it all the time, the balloon. And balloon may not go all the way because the stone has still stuck in the midway. So you have to put it, then push it little bit. See, the CRE balloon is not going. Now it has gone. And it will stop the bleeding, that is for sure. Because it is at the lower end. Okay, pull up. Pull up? Pull up? Pull up? No, pull up. See, the bleeding is just at the apex.
Yeah, we can see that. Do you want to use some cautery there or use a coax
I
grasper?
think we will use the balloon. Let us see with the balloon. If it doesn't stop, we will do the co-grasper or the hot biopsy forceps guided.
So how long you wish to
I think
inflate?
3 minutes. Usually in bleeding it takes 3 minutes according to the bleeding and clotting time of the patient. We should wait up till that time. It is not mandatory that you do it within 1 minute or only 2
Yeah,
minutes.
even longer. They say that you can keep it even for 5 minutes.
Because patient may have subclinical coagulopathy which we may not have been measuring. So we have to be very calm, relax, because most of this bleeding they stops either by themselves or by any intervention.
I think the most important thing is that you don't lose access.
Yes.
Then the problems are worse.
Yes, you don't have to lose the wire.
Is there a chance that with CRE the bleeding may get aggravated because
You
you
can
are...
see here. If it is aggravating, then you can see over the CRE there will be gush of blood.
Yeah.
Here there is no gush of blood.
Yeah.
We will just remove the CRE and put the metal stent without thinking anything. We will compress. Yeah, we will not do anything. We will just put the stent because stent is the most important thing which you should keep in your setup. Covered metal stent is the most important thing which is a rescue thing. So So here you can see the bleeding has stopped.
Is somebody looking at the watch? Often it happens that we forget when we started.
You have to see here. अभी देख लो है ना 3 3 3.5 मिनट 4 मिनट मिनिमम 3 मिनट और 4 मिनट. So bleeding happens in all procedures, all poem, even colonic balloon dilatation, colonic ESD. But you have to keep your calm. Whenever we see patient Mohan and Amol sir doing poem and bleeding, we just see their face. They never lose their hope. So since last 10 15 years, we are seeing them doing all these procedures.
I think that is a very important message.
And we are नहीं रे फुला के रखा क्या बोला था मैंने फुला के रखा 2 मिनट और फुला नहीं डिफ्लेक्ट नहीं अभी तो 2 मिनट और क्या 8 से 2. So active bleeding, you have to keep all your measures ready. Saline adrenaline, clips. Here in ERCP, clips are not very important because they don't get as easily to the point where you want to. But now they are coming with the clips, newer clips. You can use in duodenoscope also.
When it is a post-sphincterotomy bleed, we know from where it is bleeding.
Yes.
It is at the site of cut.
Most of the time it is apex.
So why it happened in this patient? We have not done a sphincterotomy.
Yeah, maybe because of the pushing, there was lot of inflammation previously. So that might have touched some vessels. Because we have not done CRE also. Or might be, maybe some fiber, the laser fiber while coming out, might have touched the vessel.
And how much we have inflated? To what size at the moment?
It's 12. 12 किया? 10 12 कर 10 11 12 है तो 12 कर पूरा 12. Because this will help in removing balloon also. If you do less, then again you have to go with the spy scope and again you have to I think the stone has gone up because your balloon is inflated very well.
Fragments
so now
have gone up.
Yeah, fragments have gone up.
In fact, it went up when you were pushing the CRE.
We can
It's
put
pushed
the
it up.
contrast to this and we can see the size of the stone. इसमें से डाल दे triple lumen लगा के. We can use the spy scope two-way. Yeah. As a three-way, and then you can use this. This is very important accessory. This comes with each and every spy scope, but you can use it in day-to-day routine when you don't have the triple lumen accessories. You can make double lumen accessories into triple lumen with this help of this.
So it will be loaded, back loaded now.
Yeah, back loaded over the wire. Yeah, and then you can fix it, fix the upper end of the wire, and then push the contrast through this. So we use it all the time.
That's very nice.
Sir, one question from here, sir.
Yes.
Hello.
Yeah.
Yes, Lavkush.
Sir, if we have identified the proper site of bleeding, if it is occurring from the 11 o'clock, suppose, so instead of waiting for a 5 minute, can we use a co-grasper and just stop the bleeding and proceed it?
Here the vessel will go inside. If you try to cauterize it more and more, it will go inside deep. So if you see the vessel and try to do less coagulation, because there are chances of pancreatitis also later.
Lavkush, in case of a post-sphincterotomy bleed, that option is still there.
Yeah, it is there.
But here we were not sure whether, because we haven't done a cut. So maybe it is little inside also. The balloon will do a tamponade wherever it is. That's the idea, I think.
Okay.
बराबर बनाओ, थोड़ा contrast और डालो. You have to dilute it less. 50-50 नहीं, 70-30. Stone has broken in two parts. हाँ उधर आइलम पे पड़ा है.
Fluoro दिखाओ.
It has gone up. Yeah. No, I don't think so. No, I don't think so. 12 हो गया ना? आ जाएगा. We will try. Yeah, we will try.
दिखाना भैया.
Right. I think it has become less in size, and we may try to remove it with the balloon.
4 minutes have elapsed. Shall
Yeah.
we deflate it so that the contrast comes down and
We have to deflate it very slowly. Don't try to pull this. Just release it and let it deflate by itself, because otherwise the bleeding will again recur. So you just have to wait. Do it very slowly. नहीं खींचो मत.
So the plan A is that if there is no bleeding, we will remove the stone by using an extraction.
If there is bleeding, we will put metal stain.
If there is bleeding, then
Mostly it will be. No.
it is controlled.
Yeah, it is. Yeah, we can go for balloon.
I think if you want short length, fully covered metal stent onto.
Yeah, short length. Yeah. It's not needed. क्या सर? अभी निकल जाएगा ना. नहीं अभी देखते हैं ना.
The bleeding has stopped, so we may not need. We are just watching.
लगेगा तो बाद में डाल देंगे. अगर लग रहा है नहीं आ रहा है तो फिर डाल देंगे.
Screen ones so that we have to look for distance.
Yeah.
Fluoro?
It is almost 12 millimeter. Stone अपने आप नीचे आ गया.
Now cholangiogram does not show any large stone. Maybe it is broken.
Yeah, let us see. If it's not coming, then we will put a metal stent, and then later we can do the laser lithotripsy.
Do you think that once you try pulling out with a balloon, the bleeding might reoccur or aggravate?
It can. That is why we have kept the metal stent ready. You can do cauterization over the metal stent also.
So where would you start your balloon from?
Above.
But then that will bring all the stone fragments together.
I think there are only 2 or 3.
So isn't it better that we pick the smaller fragment
I
lower
think there
down
is
first?
only one piece left. Yeah, we can see.
If we remove the distal fragment first, then maybe it will be easier.
Let us see. Because I don't think there are more fragments. There is only one piece left. वही बड़ा होके पूछ हो गया.
Meanwhile, we are doing this. The other case is ready in OT1, OT2. So you can shift and we'll come back.
आ गया ना. नीचे से ही ले रहे.
हेलो
नीचे ही साफ. या नीचे ही बोला.
हेलो Sir, can we see the fluoro image? Hello? Are we audible, sir, from the house?
Yes.
Sir, can we see the fluoro image?
You have to pull it very gently.
I think you are in the other room. Lavkuch, can you hear me?
Yes, sir. Sir, we are not getting the fluoro image here, sir.
Okay. Show the fluoro.
अभी सर ऊपर से ले. अब और ऊपर. हाँ सर. क्रसर है आपके पास 3 सेंटीमीटर वाला. लेजर ही कर देंगे सर. अभी तो ऊपर चला गया लेजर. हाँ लेजर से ही कर.
check.
So
Hello,
fluoro.
hello, check.
हाँ ये तो आ जाएगा.
So in this case, what I generally would do is that once you are coming from hilum and you are getting stuck, so again no stone, huh?
Yeah. इसको लेजर ही कर.
No, but you have not.
एक बार
Fluoro
बलून से
images,
डाई
please,
डाल
sir.
दो. एक बार बलून से डाई डाल के देखो. खुला खुला. अगर है तो
Hello,
सीधा
sir.
लेजर डाल देना. दो टुकड़े कर.
Yes, Lokush.
Sir, fluoro images, sir.
बता दीजिए.
Actually, the entire die has gone out, so you won't see much. Yeah, now you can see. So stone has moved
Sir,
up into mid CBD and looks elongated, not.
Now we are demonstrating a case in OT2. We have a case.
नहीं आएगा नहीं. ये एंगल पे है ना.
A
इसे narrowing है ना
44-year-old male complaining of alternate diarrhea and constipation for
Actually,
last
we
3
can
months. There is no
metal डाल
weight
देते हैं
loss, no
prophylactic.
blood in
हाँ
the
सर.
stool. Colonoscopy was
Prophylactic
done,
metal रख
showed
देते
a
हैं.
large broad-based
Prophylactic एक
polypoidal
metal रख
lesion
देते हैं इसमें.
of 5
और उसी
into
के
3
हाँ.
centimeter at the sigmoid colon. Histopathology showed the hyperplastic polyp.
ठीक है.
CT abdomen was done, showed the pouching from the outer wall of descending colon containing the fecal matter, query large colonic diverticula with the diverticular
नहीं नहीं
adhesions.
ऐसे ही जाएंगे. क्या वायर में क्यों लेंगे?
So happy.
वायर निकाल.
This is a picture. This is
ये इधर से bleeding.
and the
ये
planned procedure is polyp characterization and processed for ESD if feasible.
I request Dr. Pranav Raghuvanshi sir to present a memento to our chairpersons.
We are now in OT2. Dr. Amul Popai sir is
And for
doing
the
the case.
next
Dr.
session,
Amul sir, you are live.
हेलो सर. हरी सर. हरी सर आवाज आ रही है.
for next case, I like to invite Dr. Anirudh Tiwari and Dr. Mitesh Mahajan.
Dr. Mitesh Mahajan is a surgeon from Dhar, and Dr. Anirudh Tiwari is a consultologist from Bhopal.
You are audible, sir. You are audible.
Can you hear us? OT2.
Yes, sir. Yes, sir.
सुनाई दे रहा है. हेलो.
हाँ सर, आवाज आ रही है
हाँ
सर.
अभी आवाज आ रही है.
एक बार वायर ले ले.
हाँ yes sir.
Put in the scope.
Sir.
30 centimeters. I think I can see something. I'm just cleaning up this area so that I can visualize a little bit more carefully. There is a
Sir,
large
which scope we are
globular
using?
swelling.
पहले से ही तो है abnormal. इसी में तो जा रहा हूँ मैं.
Am I audible, sir?
Yes.
ऐसा नहीं
Sir,
मैं पहले से
which
आया
scope we are using, sir?
We are using the 190 scope. HQ 190 scope from Olympus.
2 मिनट रुक जाओ. देख लेते ऊपर चढ़ गया ये.
So there is this globular swelling, but this is a subepithelial lesion actually. That is what I feel, and I think it is a lipoma, if I'm not mistaken.
60 तक में चला गया क्या? वायर डाल दे.
Sir, before the procedure, can we do endoscopic ultrasound?
We can do an EUS. Only thing is it is around 30 centimeters. Getting your EUS scope up to 30 centimeters in the sigmoid can become difficult. But if it is a lipoma, it will show up very clearly on a CT scan. So you may not need an EUS because CT scan will give you a very classical appearance of a lipoma. So here you can see the lesion is starting over here, and I think it is intussuscepting partially. This is the lesion. The differential would be a gist, but gist usually are more common in the rectum, if at all. I have never seen a colonic gist so far. I don't know if anybody else has seen. But this is the lesion. Now you can see at around 6 o'clock to 9 o'clock. This is a large globular swelling. We have it is also intussuscepting over here. This is what I feel. So This is the intussusceptum.
रुक जा हाँ सर
So ideally this will need to be reduced completely, but mind you, if this is a lipoma, this can be resected by ESD, but this is a pretty large lesion. We will need a CT scan before planning the procedure. And the second thing is, the head of the intussusceptum over here, there will be significant fibrosis. So here you can see that there is a large mass, and it is entirely a subepithelial lesion. The mucosa is edematous and little bit erythematous, but there is no ulceration or there is no polyp over here. So this is a normal mucosa, just congested and inflamed and edematous because of the sheer intussusception that is happening. So this is a classical, probably a descending colon into lipoma, which is intussuscepting into the sigmoid, and that is the reason the patient may be obstructing and getting parisha, subacute obstruction kind of a thing. So this can be treated by ESD, but probably not just now because we don't have a scan also. This kind of a lesion will have, we will take a very long time. So in the workshop setting, probably when there are so many other cases to be done in out of 2 rooms, that Dr. Sanjay would not probably want to demonstrate one case. Otherwise, this is amenable for ESD, definitely.
Actually, we have done the scan, sir. Report of the scan is there is outpouching noted arising from the outer wall of the descending colon. The outpouching contains fecal contents and measures 7 into 4 centimeter. Cranial part of the lesion is adherent to the wall of the colon.
Oh, but how is the lesion described?
It is outpouching.
This is not at all. I think it is a lipoma. If you have a biopsy versus, I can just demonstrate the pillow side. If at all.
This is the only description. Possibility of
it may be a gist, but gist so high in the colon, a little bit less likely, but the scan would probably show that. Maybe if we can see the image of the scan.
See the OT1 picture there?
Not yet, sir.
Straight to go for surgery with this size of the lesion. If it is lipoma, we can probably do an endoscopic attempt.
OS
This
is
is the
pedal
lesion. No, I think.
OS is pedal
We can see it now, sir.
So just we are in the OT1. So Dr. Sanjay.
Yes, I gist. This is a gist.
yes so we have done a full cholangioscopy, and from IHPR onwards we are coming down, and whole stone has been cleared. Whole CBD is very clear picture. So the stone fragments all have been removed.
Sanjay, sir, your voice is on.
Yeah, so all fragments have been removed. There is lot of fibrosis due to old impacted stone here. And then we are coming out, and there is no stone. So there are some fragments here lower down, here. But they are impacted in the wall. So they will come out with the stent inside, and there is no bleeding. So we will put a stent and then come out. So fully completed ERCP with stone clearance. There was some bleeding. And this cholangioscopy is very important to see the clearance also. Because if you are in doubt, anytime you are in doubt, you can put this scope in the CBD, go up to the hilum, and then you can
Sanjay,
check whether the CBD is completely cleared or not. And you can see there is no bleeding at all.
Great job, Sanjay sir.
Hello, sir.
Wonderful clearance, sir. The stone
Thank you
is
so much.
completely
Thank you.
cleared. Now probably
Sir,
you are putting
nicely
a stent,
demonstrated.
sir.
Yeah, always put a stand, because sometimes 1 or 2 fragment might have not come out with the balloon sweep, and that can cause cholangitis. So there is no harm in putting a stand and removing after 2 weeks.
Any role of antibiotics afterwards, sir?
Yes, always give antibiotics, because we know the sterility of our OT. Everybody is touching everything. So always give them higher antibiotics for at least 3 to 5 days. We have a tendency to give 1 day IV and then oral, if patient is not having fever next day.
Sir, since this case was having a distal CBD stricture also, and
Yeah, it
while
is
looking
already
at
cured.
colonoscope,
It is already cured.
uh,
You
the
can
unhealthy
actually
tissue, that fibrous tissue, which we were seeing it, sir, during the
no.
colonoscopy, are
Now
you
you can
suspicious
see.
about some malignancy or not at all?
No, there is no
Oh, it
malignancy.
is
It
here
was due
only.
to impacted stone, and now you can see 12 dilated lower end. You can even walk
Ah,
in.
yes, sir. Hmm.
So no need to do any surgery for this later. So the CRE has done trick. Once it has stopped the bleeding, and it has removed the fragments, and now it has dilated the CBD lower end to prevent the further stones later on.
Dr. Sanjay, where do you prefer this spy versus balloon dilatation?
I think it depends on the size of the lower CBD, the diameter of the stone, the character of the stone. If the stone is seen on X-ray, it is very hard. So it will not come out with a routine balloon, and it will not break with the routine lithotripsy also. It will break your lithotripsy basket also. So at that time, spyglass is needed to remove. We are putting 10-7 double pigtail stent.
Can we shift to other room?
Yeah,
I think
sure.
Dr. Rajput is putting a 10 French stent, and which can be removed later. We need to hear some claps for Dr. Rajput from the hall. It was a bit challenging because the stone was stuck in lower part. It's not easy to do a spy. During the procedure, patient got bleeding also. That was very coolly controlled by him. He was very confident that balloon will do the trick, and it did. So it was a wonderful demonstration. Though we kept
मतलब कुछ वॉइस आ रहा है यहाँ सर
we
42 से
kept the covered stent ready, but it was not required at the end. So thank you,
sir,
Dr.
voice is
Rajput.
clear.
Thank you very much.
We are moving to the other room.
Thank you.
Hello.
Yes. Dr.
Sunay
Amit, you are
Dharai.
audible.
Yeah, so I just put in
Sir.
the
Yes, sir.
forceps, and the lesion does look quite compressible like a pillow sign, but I'm still trying to get a good view of it so that we can probably demonstrate it a little bit better. There's a lot of fluid because of that. Vision is becoming a little
Sir,
bit
applying
complicated.
NBI in these type of cases, would it like be helpful for us?
NBI will not help in this because there is nothing mucosal in this.
Okay, sir.
Yeah, the NBI will not help.
This is a mucosal lesion, so there is no role of NBI in this. Classical compressive.
It is quite compressible. It is quite compressible, not as much compressible as, but that is probably because the head is a little bit fibrotic. But here you can see, probably, let me just give air and see if I can show that.
Sir, does EUS will help in making the diagnosis in these type of
EUS
cases?
will help. Only challenge will be to get the EUS up to the 35 centimeters because that is going to be a challenge. But if we can get a EUS scope up here, EUS will definitely help. Quite compressible. I still feel this is a lipoma. So if this can be reduced, then probably it will need a resection definitely. It can be done endoscopically, but it is going to be a very time consuming procedure. I don't think we can, hydro reduction, put the patient completely paralyzed, head down, and then without air, just with this, saline insufflation, we go in with the scope, and over a period of time, with just the insufflation, this will gradually reduce. Then we will see the distal margin of the lesion much more better. Able to see.
So have we done NBI also in this?
NBI we have not done because it is not going to help much.
It is
because
submucosal, so we are not going to see any changes.
Yeah.
And do you think patient has got some vague symptoms? In fact, he does not have.
There is still a little bit of stool. And this is
Yeah. Yeah. So, so we recommend a surgery right away, I think. Thank you, Dr. Amol. Thank you very much. Sandesh, Dr.
Yes, sir.
What I am suggesting
Yes.
is that we are not going to have a formal break, lunch break. So you can, I mean, if the lunch is ready there, you can start lunch and people can bring their plates in and continue to watch. Meanwhile, the
Okay.
faculty will get lunch here itself in between whenever they get time, because we have a lot of cases. So we don't want to take a formal break.
Okay.
And
So both the
if
tables
any
are
of
being exchanged for new patients. So shortly we'll get the new cases.
if any of the consultant want to register for the hands-on training on ERCP, USF, NAC, POEM, so please contact registration counter. Thank you.
इसको बंद कैसे करना है?
Check one, check one.
Hello.
Yes.
Who is there in the hall? We are starting the fresh case. Dr. Sandesh, Dr. Yadav, Dr. Devinder.
संजय अजय बोल रहा हूँ अभी
Yes.
there is nobody inside all we are only 3-4 people
I can see
so
Dr.
I'll
Sunil
take
Jain
care.
and Dr. Jha.
Yeah,
Welcome both
we
of
are
you.
3 here.
So people have
You can
started
start,
lunch.
yeah people are in the lunch house
So we can request
can you
them to.
wait for a minute or two.
Yeah.
Yeah, I'll request them just
So,
give me
so
2 minutes.
after
Yeah,
few people are there, we will start with the history.
just wait for 5 minutes Sanjay.
Okay. Okay.
Just wait for 5 minutes.
Yeah.
But it was possible with the scope. The patient did not have any dysphagia. And that is what set Professor Inouye thinking that why can we not use this kind of a procedure of mucosal ablation to create a very soft stricture at the G junction which will prevent reflux. So that is how it has evolved. So there are two variants of this procedure. One is ARMS, which is anti-reflux mucosectomy, where we resect the mucosa in a semicircular fashion, or nowadays sometimes some people also advocate a butterfly shaped fashion resection. And the other modality is the ARMA procedure, which is anti-reflux mucosal ablation, where you don't actually resect but you just ablate the mucosa using either spray coagulation or argon plasma coagulation. And that once the mucosa is completely ablated, then regeneration will occur. And similarly, when you do a resection also, regeneration will occur, and that will lead to fibrosis, scarring and remodeling of the G junction. That is basically the principle. That is how it is.
So how far from the cardia we make this
So
coagulation?
actually we take the Z line, but we go up to the Z line, but we do not cross the Z line onto the squamous mucosa, because the minute you cross into the squamous mucosa, chances of true stricturing are higher. That is the problem. So we go up to the Z line, but we do not cross the Z line. And we take about a 1 to 1.5 centimeter distance, length of the area, so that it forms a good scar over there. So that is how it is. And we use a spray coagulation if we are doing an ARMA. The ARMA procedure actually looks a little bit dirty to look at, but it is very effective. And it is very simple also, because there is no chance of bleeding or perforation, something of that sort. So it's a very simple procedure to
So
take.
Is a hiatus
So Amol, I
hernia
have a question.
Yeah.
Amol,
yeah.
I have a question. If you have a little hiatus hernia, maybe 1 or 2 centimeter, you still will go ahead with that ARMA?
See, a hiatus hernia, if there is a physical hiatus hernia all mucosal resection procedures are going to have a little bit of a compromised outcome. What is most important to remember is a loose LES, but we go by the Hill's valve. Hill's flap valve is what we usually consider as an indication. So Hill's flap valve 1, 2 are indications. Flap valve 4 is a bad indication to do these procedures. 3 is a plus minus, patient may not get good relief, that kind of a thing. So the minute you say it is a hiatus, there is a hiatus hernia associated, that becomes a flap valve 4, which is not a good indication.
But majority of these patient of GERD, majority of the patient of the GERD, they usually have associated hiatus hernia. So the chances of patients getting for the arms are little limited.
See,
in
many of
clinical
these
practice.
patients have a lot of volume reflux and lax LES we see quite often in lean, thin individuals, lean, thin females, young females also. That is, it is quite a common occurrence that we see a lax LES without a hiatus hernia, and these patients are quite troubled by their symptoms of reflux. And majority of them have volume reflux than pure acid reflux. Some of them may have LPR associated and nighttime reflux as well. So that is how it is.
What about a patient who does not have a lax LES, but you have demonstrated that he has got reflux disease by way of PH or symptomatic reflux? Esophagitis is there, but the lax LES is not there.
Right. So in these patients also, I think if there is intractable reflux which is not getting controlled with PPIs, or there is complete PPI dependence, these patients would be good candidates. But here we would be a little bit more careful about how much of the circumference to ablate, because these patients are a little bit at a higher risk of developing a stricture, because the LES is, to begin with, it is not lax. So there we have to be a little bit more careful. So I would ablate about 60-70%. Scope ही नहीं लगा. He's not got the scope yet. HQ, if H नहीं है तो HQ ले लो. Okay, then bring whichever is available, boss.
Amol sir, you have told that.
Yeah.
Sir, you have told that we can use both of the mode. Either we can go with the APC or we can go ahead spray coagulation. Is there any head-to-head trial, or which is the better one, sir?
I am not aware of a head-to-head. Actually, both modalities, there are proponents and opponents of both, but both modalities give good response. But at the same time, my personal preference is a little bit more towards spray coagulation than APC, because I believe spray coagulation gives a little bit deeper coagulation, which leads to better scarring. Here we are looking at creating a coagulation which will give good scarring. So, but APC gives you, the simplicity of control. Spray coagulation using a triangular tip knife, there is a hypothetical risk that you might go deeper, you may cause a full thickness perforation if you have not injected too much. So technically it might be, one has to be a little bit more careful, but I think if it is, that can be managed well. I think spray coagulation has a little bit of a depth, more depth of penetration. So that is how it is. I'll need a cap. जली दे देना, सक्शन चालू कर देना, यहाँ पे है जली. CO2 कोई है क्या? चालू कर दे CO2. नहीं, इधर नहीं आ रहा है. इसका ये वाल्व भी है.
So you have already heard the history. Till Amol goes in and prepares for spray coagulation, we are moving to second OT. And Neha, you can read the history of that patient.
Patient plate भी लगा दीजिए, इधर का वाल्व भी चाहिए, because otherwise this will not proceed.
Uh, a 42-year-old male patient recently diagnosed for chronic calcific pancreatitis, query cause, presented with us for abdominal fullness, loss of weight for last 1 year. He's a known case of diabetes too under medicine. CCT abdomen was done, showed the atrophic pancreas with intra and extra ductal calcific foci, MPT dilated up to the 11 mm. Planned procedure is ERCP pancreatogram, if feasible, spy pancreatoscopy and lithotripsy. Now we are live from OT2.
कौन आ रहा है असिस्ट करने आप ही आ रहा इरिगेशन है
Hi. Hi, good afternoon. I am Dr. Saurabh Mukhevar. Dr. C.C. Chaubal is here.
Hello. Hi. Hi, Saurabh. Sir, good afternoon.
Good afternoon, sir.
Good afternoon.
We will be,
Have you had your lunch?
the idea actually is to demonstrate a basic, actually selective cannulation, pancreatic duct. A part of it I'll also tell about selective biliary cannulation. I'll try to cannulate the pancreatic duct. If it is possible to pass a guide wire, it's okay. If it fails, then probably Saurabh is going to demonstrate the spy on this particular thing, the pancreatoscopy.
Yeah, I think, I don't know if it's possible to show the CT scans because this is a patient with chronic calcific pancreatitis. And typically, options for treatment include endoscopic therapies with ESWL and pancreatoscopy and laser, which is something that we may consider in this case here, or surgery, right? Now, we would like you to see the CT scan and then we'll also show you the fluoroscopy to see exactly how the stones are located. Patient selection is of importance when you're dealing with these patients and trying to do an endotherapy. Typically for patients with, which I'm selecting for laser therapy with pancreatoscopy, the good candidates are the patients who have a limited stone burden, typically limited to the head of pancreas. And then yes. So now, typically, I would not do it more than 2 centimeters generally, because it gets challenging. And head burden is good, but if you have something in the neck and the body and the stone burden is high, then pancreatoscopy and laser is not a great option. In such instances, ESWL, if it's a radiopaque stone, or surgical intervention with lateral pancreaticojejunostomy is a better option.
So, Saurabh, most of the
So
time when
we'll
you do
try to
these,
show you the scans, if that's possible, maybe over there on that screen. And I think
So, Saurabh,
as we start here, something's too important to note, and you saw a very nice demonstration by Dr. Rajput on cholangioscopy. The same scope, of course, is being used inside the pancreatic duct. The scope diameter for all of you who are not very familiar with it is 10 French. Okay, so we are looking at a 3.3 millimeter diameter scope, which is a blunt instrument. So if you are putting that inside the bile duct, which typically is certainly much more dilated, in the pancreatic duct, the duct may not be dilated to that extent in the head. So pre-procedure dilation and accomplishing a diameter of more than 4 millimeters is absolutely important for your spy scope to go in smoothly without any intervention, without any problems. So what we are going to do is, let me focus on the CT scan. Sorry, excuse me. One second. Yes. Yeah, sure, please. You can go to the other room and then we'll come back here. Yes, thank you.
We are in room number
So I think we'll be going to the other room where they're doing, I think, ARMA. So
We are in room number
cool.
1, demonstrating the ARMA. Dr. Laukush, can you see the OT1 pictures?
Yes, sir, you are live also. Amol sir is live.
Ah, other room.
Hello, Dr. Ajay?
Yes.
Yeah. Are you getting the endoscopy
Live,
view?
yeah. Yes, we are
Yeah.
getting.
So I am already in the fundus and I am retroflexed and you can see the G junction, the Z line very clearly around, but it is gripping well. So this is a type
Yes.
1 valve actually. So this is good for an ARMA procedure. Type 1, type 2 are the good ones. Now what I am going to do is I am going to use a TT knife and mark the area which I am going to leave behind, because that is important before I inject. Because once I inject, then the
So you leave.
orientation and the anatomy changes and then it becomes difficult. So I'll just straighten my
So you leave.
scope a little bit so that I can push my knife out. And one important thing which one should do is one should try and use a scope which has been tested for a good tight retroflexion, because and also one has to use a scope which has a good you have to over insufflate the stomach. So what happens is the patient has to be well under, otherwise what is going to happen is patient is going to keep retching and then that will become a problem. So what I am going to do is I am going to use a little bit of a mark using quite patient is moving too much. Back ले लो. दे दो थोड़ा सा दे दो. CO2 रहेगा तो ज़्यादा बढ़ेगा. This is the area which I will on one side back ले ले.
So you would like to leave 1/3 of the area knife.
More than less than 1/3. It is usually 1.5 to 2 times the scope diameter that you see on retroflexion. दे दो थोड़ा दे दो. And these are just reference points. दे दो. Back. दे दो.
So
Back. So between these two marks, I definitely don't want to go. Now I will probably actually end up ablating even less than this, but that we will see now. Give me the needle.
the other OT is live. Here.
Saline ले ले.
Take the scope out, I'll do that.
Yeah, can you get me a gown? Procedure, gown and gloves.
Needle. Okay. So where do you inject? You inject as close to the Z line as possible. Inject. करते रहो, करते रहो, करते रहो.
जरा सर क्या पे था? हाँ, साथ में है?
अरे ब्लू मैथिलिन ब्लू नहीं थी क्या? नहीं नहीं मैथिलिन ब्लू वाला चाहिए ना भैया. ऐसे क्या कर रहे हो? पहले बार कर रहे हो क्या? ऐसे नहीं तो फिर निशान को दे दो. ऐसे करो ना, क्योंकि आप आए भी लेट तो मैं आई कुड नॉट टेल यू ना क्या क्या करना है क्या नहीं करना है, क्योंकि अभी ऑलरेडी इंजेक्ट हो चुका है तो और होगा भी नहीं इंजेक्ट. मजा नहीं आएगा. और पूछ के करो, अगर पता नहीं है तो पूछो, करने के पहले पूछो.
I mean, gown.
प्रोसीजर खराब नहीं होना चाहिए. नीडल पैक ले लो. आप आ जाओ प्लीज, क्योंकि स्कोप गए, स्कोप गए, स्कोप गए. 100% लीक टेस्ट करो इसका, क्योंकि नीडल बाहर था उसका.
Amol sir, you're live.
Thank you. Thank you. रेडी तो है कैनुलेट करने को. स्फिंक्टोटोम चाहिए, बस स्फिंक्टोटोम आ जाए फिर चालू कर देंगे कैनुलेशन. Oh yes, thank you so much.
See, you need this color. So this light blue color, I don't know whether you can see this. So this is the light blue color of methylene blue, similar to what we are using in POEM or in ESD, so that the submucosa becomes very easily visible. Of course, we are not going to go into the submucosa, but it gives a kind of a hue. So you know.
This one also, no? Thank you. Color mic.
Okay, bas.
Excuse me, sorry.
Shini आ गया? आ जाओ ना Shini.
Thank you. Thank you. Burden. ठीक है, not bad. Scope जाएगा. ऐसे एकदम ही हेड पे नहीं. Actually not bad. हाँ सर, क्या म्हणता? हाँ नाही बरोबर आहे. तुमचं स्फिंक्टोटोम रेडी ठेवा. I think they're almost ready. बरं, बाहेर रेडी कर दो सर के लिए बाहेर रेडी. Yeah.
इरिगेशन मेरे हाथ में. मेरे को दोनों पैर से करने की आदत है.
Mix and सगळं
इंजेक्शन I will not do the entire thing just now because
बाकी बेसिक ERCPs हमारी टीम करती है.
if you do the entire injection then
मैं करता हूँ.
anyways the injection तो कम होते रहेगा. Patient is moving too much.
बाकी है.
Otherwise we can intubate the patient. That might be better because otherwise
सब
what
rounds
happens
मी
is
सर rounds घेतो.
we always usually intubate the patient. निकाल दो उसको मैं.
OPD सगळं split होतं सर.
Intubate करतो.
Hello.
You will keep aspirating. You will keep coughing.
Basically we decide OPD we decided proportionately between everyone. IPD rounds are split.
If you can give me the H scope, that is better.
Procedures मध्ये काय की हे अजून कोणी करत नाही ना, तर म्हणून मीच करतो मग. माझा एक दुसरा आहे भूषण, तोही लागला आता.
While we are intubating the patient in the OT1, as the procedure is taking a little longer time, so we are shifting the case to OT2.
Yeah, OT2.
Hello.
So,
yeah, hi, we are back.
You like him.
So, Chobal sir is now we need to cannulate the duct. So, yeah, we are live, sir. I think, yeah, we're giving some
can you see
Buscopan
the
and we'll get the microphone.
We are able to hear
this
you,
patient, I think in the meanwhile, we should scan and the fluoro. We'll, you can see what this patient has and on this fluoro as well. As the Buscopan is
कोई
being
था ही नहीं
given.
ना यहाँ पे. कोई था ही नहीं ना यहाँ पे.
I don't
Scope
know
भी
if you
नहीं था,
can zoom in on
technician भी
this
नहीं
here.
था.
Can you zoom
कुछ
in?
भी नहीं था. कल ही कैमरा चालू हो गया.
So,
actually we
so
are
you can
getting
see the
from
scan.
OT1.
Now, it's very important to have a cross-sectional imaging before you do these PANC patients, because this has a lot of calcification and stones in the body and the tail. The duct is very dilated. It's about 8 millimeters in the body. And the next film here, you can see there's a fair amount of calcification in the head of pancreas. Now, this is sometimes parenchymal, but definitely intraductal in this case. And you can see on the fluoroscopy screen, can we show fluoro? I don't know if it's being transmitted. So you can see there's a good stone burden. Part of the stone burden would be intraductal and part would be parenchymal or say side branches or whatever. So that's the fluoroscopy view. And Dr. Chobal, I think if you're ready, I think we can start with the transmission for the cannulation. So we can switch back to the endoscopy view. Can you show the endoscopy view? Endoscopy.
Yeah.
Yeah. So Dr. Chaubal is using a Olympus clever cut sphincterotome with a 0.032 inch thermo guide. And this is a, so you can give him the mic, I think. Dr. Chaubal sir, we are live, so if you want to make any comments, we'll get you the mic.
See, actually, we are trying to demonstrate actually selective cannulation. If you look at the papilla, normally you have four kinds of papillas if you see. The usual one, the normal one that we see easier to cannulate. One is a small papilla, third is sometimes the hanging papilla is the fourth is this one. Type 1 to type 4. Whenever you have this, see, look at the papilla and just look at it like a clock. If you look at this particular papilla, as you can see here, at this particular clock, usually the biliary orifice comes between 9 and 12 o'clock position, and usually it is around 11 o'clock. And as far as pancreatic orifice is concerned, it is diagonally downwards around 5 o'clock, usually somewhere again between 2 to 5. Usually it is at 5 o'clock position. So whenever you are doing it, for biliary cannulation, you require to have proper access with the intraduodenal portion of bile duct. And if you are going to have a selective pancreatic cannulation, usually a more horizontal position is required so that the wire goes just perpendicular to the papilla. So we are trying to right now to cannulate actually the pancreatic duct.
So I think, is the audio visible? Yeah. So, Dr. Chaubal, any preference of the type of sphincterotome, or you are flexible with either of these?
Usually, sometimes you require a tapered sphincterotome also, especially if you are cannulating pancreatic duct. And sometimes even the catheters can do because you require a more horizontal position in these situations, unlike what you have in a biliary sphincter cannulation where you require actually a bowing and
I think in some instances, I think as you're talking about, if the stone is very distal, then I think it can sometimes be a problem in terms of getting the across the duct. Fluoroscopy. You see, fluoroscopy, I think the guide wire is going in, but I think the stone is preventing the guide wire from going deeper inside the pancreatic duct. Yeah.
Sir, can we get a fluoro image also?
Yeah. एक बार वो दिखाओ. Can you? We'll show the fluoroscopy image, please. Yeah. Oh, it's going. Very good. Very good. Yeah. Live fluoro. Yeah. So this can be a challenge in patients with chronic pancreatitis because the wound's burden can be so extreme that it's completely occluding the lumen, which is what we are seeing in this case. So sir is going to put some contrast. Yeah. Yeah, I think the new, so certainly I think what's more important in these patients is to go ahead, try different wires, try different ways to get across. The The new thing we have done in certain select patients is transgastric drainage of the pancreatic duct. Now, of course, that's highly debatable because people would then suggest upfront surgical intervention or EWL if you have it in your center or city. So those options. Yeah. Or 20.
Go ahead with TRC.
I can do it here. You get access, why not? You get access. Yeah, I think on fluoroscopy, we need to show the fluoroscopy images. The pancreatic duct is grossly dilated, and it's quite beautifully evident with the stones in the head, dilated pancreatic duct. Tail, you can see some filling defects as well. Yeah, I think but the problem is, of course, the wire is going, so this can be a challenge. So, sir, would you be concerned if you cannot get the stent in and you have contrast in the proximal dilated duct? Not, right, more in the. Would you be at a risk of pancreatitis because of the contrast pooling in and not draining? Right. So the correct. So go karne do. You can hold the mic. So you can. Yes, yes, sir. So I think we should try with different wires. You want to try a smaller wire, maybe that can be a consideration. Maybe a VisiGlide because it's, yeah. 0.8, yeah. The problem with the 0.8 wire is it's a very floppy wire and no stiffness. Yeah, no, true. Can we try VisiGlide maybe now? Is this? Yeah. Because see, thermoguide wire is 0.032 inch. Yeah. Correct. There's no stiffness. Yeah. VisiGlide. Yeah. Now what we can ask Dr. Sanjay Kumar if we can't get in, should we try US approach? But then we'll first try this approach. You feel this is actually a good one. Yeah, this is one you can consider.
Dr. Saurav?
So we are entertaining the idea
Hello.
of transgastric or transmural drainage of the pancreatic duct if it is not able to cross. But sir is trying, and with his experience, I'm sure he'll get in. This is, but these things you encounter. So the question is whether an attempt to be made in 24, 48 hours or another alternative treatment is the other alternative option can be considered.
Dr. Saurav?
Yeah, true, exactly, yeah.
See here, actually we can make out a long segment non-opacified area. Is it a long segment stricture also along with the stone, or
Yeah,
is it
so
a stone only?
you see this patient has, if you look at the scan, there's a significant stone burden in the head, which you can easily see is about 2 to 3 centimeters. And it is intraductal. That's the wire going across. So that's primarily the reason why you have the obstruction. It's the stone burden. Now the stricture is formed secondary to the calcifications. You can see the neck, and then beyond that, it's all dilated, right? Yeah, okay. So these patients, sometimes the wire may loop and find its way. Now this is looping here. But we'll try to see what happens now. So do you think a sphincterotomy make a difference or no, sir? What do you think, Dr. Chaubal? Yeah. Yeah. No, true. I think I think it's not the papilla. You've got a nice axis, but clearly the stone burden is preventing passage.
Saurabh,
Yeah, sir.
so looking at this burden of stones, don't you think ESWL will be better than going through spyglass and
Sorry, can we increase the
this
volume
one?
here? Yeah. Sorry, we'll just try to increase the volume in the room. You can repeat that question,
Yeah.
please. 1 second. Yeah, please go ahead.
Looking at the burden of stones we have in this pancreatic duct, don't you think ESWL will be better
Yeah, no,
than
I
going
think you
through
have a point.
spyglass?
No, you're right. I think the stone burden is the key because the large burden is better served with ESWL all surgical intervention. So that is totally a valid point. Now the question is, what do you do about the body-tailed stones? Probably not contributing much to the disease and not disease, but the symptoms. So what we are exploring is whether addressing the stones in the head successfully, if you can do with a pancreatoscopy, will perhaps give you the ability to duct and allow it to drain. Again,
Saurabh, if you have to choose between the ESWL and surgery
Yeah.
in this case, because stones are also in the tail, so don't you think surgery will be in fact much better option and one-time procedure for such patients?
Yeah, I think that's a classic age-old debate was ESWL versus surgery, and there are schools of way. But yeah, but you see, if you look at you see most of the data, yes, there's data favoring surgical intervention early, which we agree, but then there have been flaws in the studies criticized, and even the recent Lancet study for chronic pancreatitis, I think the selection criteria of the patients was, I wouldn't say incorrect, but not the kind of patients that we deal with here in India. So overall experience of ESWL is better than what the data has said. Yeah, I think we can try.
I am
See.
Sanjay
Yes, sir.
here in
Yes,
the
sir. We
hall.
can see you. Yes.
Yeah. So I joined late. Have you been able to pass a wire across?
No, the wire is not going. We have been able to cannulate the pancreatic duct and put contrast in, but the wire is not going. We are trying different wires here. Dr. Chaubal has tried thermo wire, VisiGlide. Are you trying some other wire?
We can see a lot of calcification in head, so
Yeah.
obviously it is going to be difficult.
Yes, yes.
If we
Idea of
leave at this point,
pancreatic drainage. If
Yeah.
with your suggestions, what do you feel about it? You can see.
but is it going to be good for this patient, because that alone will not solve his problem, no?
Yeah, true. So we are that will address the temporary problem of ductal hypertension and will relieve the symptoms it is having. Now, oftentimes we've
If we
seen
do
patients. Yeah. Please go ahead. Yes.
if you do EUS guided
Yeah.
put a stent, then how long it is going to last?
So the one thing you could do it now, assuming that we are looking purely at an endoscopic approach, which pancreatoscopy. The other thing that can be done is a transgastric antegrade pancreatoscopy and laser. We are going from the opposite side from the stomach, but that's obviously after 6 weeks when a fistula is formed.
Yeah.
Then you can go transgastric through the pancreas, antegrade towards the head, and then blast the stomach, open it. So that's the other, if you had to do it that way.
So I think in this patient, since we
Yeah.
have not discussed with the family,
Yes.
can
True.
we just stop here? Would that lead to some infection because of the
Yeah.
dye which has gone in?
So that was our little concern, that the contrast is there, and if we can't drain it, would we be at risk of infection or pancreatitis, whether a drainage would be reasonable to perform in this procedure.
Yeah.
So, so I think the
So in
problem,
that
sir,
case
I
we
don't
can
think
do-
pancreatoscope is going to go and do anything here. Not from this way.
Yeah.
So no point of sphincterotomy. We are also discussing whether pancreatoscopy can be just done up front. Problem is, if your guide wire is not going across, getting the pancreatoscope there, we can try with the sphincterotomy to see, but I think there's not going to be much support for the pancreatoscope to be there and then for us to do any therapeutic lithotripsy for this patient. Uh, One before we have attempted this in my experience. The problem is you cannot really get the pancreatoscope there, but I've not done it many times when the guide wire is not going. Typically, the guide wire goes and then you have a stent in there and then you get the pancreatoscope in. So I would not advise considering this right now in this patient. Yeah.
So, what is the opinion of all experts? Shall we stop here or shall we try EUS guided drainage at least?
Yes.
Yeah.
Right.
Yeah. Wonderful.
We can explore the safety of this, of course. And that's very important. So feasibility can be determined. We can put the eoscope to see if you want, but we can decide whether it has to be done or not to see what you see
Yeah,
here.
you can do that. I think meanwhile, if there's a other room, Dr. Amul is doing Arma. Naveen, can we go there? Yeah.
It's okay. Make another. Scope down.
Amol sir, you're live now.
You can put the scope. Hello, hello. Can you off kar diya?
Hello.
Am I live?
Okay. Hello.
Yes, sir.
So
You're live now.
the challenge that we are facing just now, we changed 3 endoscopes. See, for to be able to do a good arms or an arma, you need a scope with a very tight upturn. And if that upturn is not good, you cannot see the G junction very properly. And then in that case, you cannot do it. So although we started, yeah, this is the one. This is the one. This is perfect. Yeah, change. So this is the first scope that we are changing now. Because what happens is, over a period of time with use of the scope, the up knob, up down wheels become a little bit loose and there is a little bit of
problem in these chronic pain.
play in the wheels. And then if that 210 degree is not achieved, then one cannot reach up to the G junction. And that becomes a problem. So although we started with the first scope, we realized that we are falling away and so we stopped, we changed 3 scopes. I think this scope, the 4th scope will work. So I will come back with that now. I think they finished in that room also. No? So we can have a discussion on scope design. I think the Olympus people are also over here, so they can help us with some of the question answers if needed. Okay. Good.
Angle on camera. What is this angle?
Yeah. So maybe I will just show you the angle on camera. Are you getting this? So this is a complete 210 degree angle. The scope tip has to bend inwards towards the scope. That much is important, and that unless you have that, you will not be able to achieve and be able to see the G junction from close. So hopefully now this scope will work. Yeah. So this is the X1 EZ scope from Olympus. Cap actually doesn't make it stiff, but the instrument accessory in the channel, it becomes stiffer. This is better. Much better. Now we can see the G junction from close. And that is what is important. Okay? The injection. And Niklav?
Can we get a full endoscopy image?
Okay, inject.
Full
Yeah.
endoscopy image.
Okay, very good. Inject. Okay. Nice. Inject. Okay, थोड़ा कर दे. Okay. Nice. बस हो गया. थोड़ा सा इधर कर. Yeah, methylene blue is saline. थोड़ा कर दे. Okay, enough. बस. मैं कर दे चलो. हाँ कर दो. तो बायोमैक फंक्शन मेरे को पता नहीं था. आज मेरे को पता चला. So this is a special function in the X1 scope where the biomac function, where it actually improves the vision in the fundus because the light is more. Because we've all faced this problem that you cannot visualize well in the fundus.
This much of oozing in gastric mucosa is normal, sir?
This is, gastric mucosa is always very vascular, so this is quite normal. See, ARMA as a procedure is quite dirty to look at.
Full endoscopy image, please. Endoscopy image full.
Now, can you see how I am ablating the entire this thing?
Yes, sir.
Dr. Laukush, can you see?
Yeah, so little bit of
Yes,
oozing
sir.
will occur, that is a mucosal ooze, but most of it will stop. We will also keep coagulating. So, because of that, and the margin is the Z line. So, you try not to go on top of the Z line, because if you go on the squamous mucosa, the chances of stricturing is much more. So,
And what should be the width of this?
approximately a 1 to 1.5 centimeters is what is.
Japanese also do it with the APC, sir. So what is the difference with APC and this?
So APC gives you a little bit more superficial coagulation. Professor Inouye actually does it more with spray only.
What complication can occur if we increase the size?
Increase the?
1.5 to 2.
Amol sir, can we do it with hot biopsy forceps?
Yeah?
Can we do it with hot biopsy forceps?
I can't hear you very well.
Yeah, can we do it with hot biopsy forceps? Because last 3 patients we did it with a hot biopsy
Hot
forceps
biopsy
and
forceps.
saved the
Well, you can do it.
Yeah,
Probably
TTT
I
time
think
we
it will
can,
take
yeah.
a little bit more time. That is all. It will
No,
become a little bit more
I think
painstaking because you will have to pick up and coagulate every spot. So here
not by
we are
touching,
doing a spray kind
not
of a
by
thing.
capturing, just no, it's not by capturing, it is only by spraying like this. It saves your TT knife.
Yeah, but probably it will burn your hot biopsy forceps. So it depends on what you have that kind of a
Hot
thing.
biopsy forceps is much cheaper.
Yeah, but this is the old TT knife. This is not the way. We actually should use the bigger TT knife because that gives, TT knife, not the J function. We are using the TTJ, but the coagulation is much
Check
better
one.
with
Check.
the
Hello.
regular TT
Hello.
knife
Hello. Hello.
because it has a wider tip, no? So it cuts less and it causes more of coagulation. So that is how it is.
Can you just try with hot biopsy there and see?
So once the scope is good and you have a good assistant like Srinivas, I think see how simple the procedure becomes. So thanks Srinivas, it's always a pleasure to work with him. This side is done. Now let's go on this side. थोड़ा दे दो यहाँ से चालू कर देते This is a good case. Yeah, because
Sir, have you done pH battery?
flap valve
Amol
is
sir?
grade 1, 2. Yeah?
Amol sir, have you done pH battery before?
This patient has undergone, I believe, manometry and pH metry, and reflux has been documented.
Okay.
Yeah. Because if there is any dysmotility or impaired esophageal,
Dr. Amol, what is your selection criteria for this procedure?
I didn't get you. Can you speak a little bit louder? I can't hear you very well.
So what is your selection criteria for this procedure in your institute?
Refractory GERD or PPI dependent GERD in patients who are refusing to take PPIs on a long-term basis. That is the most common indication. And obviously, you have documented GERD on either esophagitis or on pH metry and a normal manometry finding. Normal in the sense, acid, esophageal clearance has to be optimal.
So how much time it takes for the patient to have response?
Yes, you said something?
So how much time it takes the response to be seen in the patient?
See, so it will take about 4 to 6 weeks for all this area to heal. So the response is not immediate. That is what you have to explain to the patient. The patient will need to take PPIs for about 6 to 8 weeks, and then you can gradually taper them off. So in about 4 to 6 weeks time, as this healing occurs, and typically we call these patients back for follow-up every 2 weekly or so, and we also do endoscopies because some of them can develop a little bit of stricture formation. Usually most of it will get dilated with the scope itself, or just a little bit of a small CRE dilatation may be required in an occasional patient. No, that's what I'm just saying. I think we are done. Most likely we are done, but I'm just trying to get a good view. I'm just sucking out all the smoke from the fundus, and then again, maybe एक बार knife निकाल के suck करके. मतलब क्या target किस level पे आप मतलब इतना ये procedure? See, so we saw the scope on the retroflexion. So we have to leave 1.5 to 2 times the diameter of the scope. That much mucosal margin we have to leave, and remaining circumference we have to ablate. So that typically comes to around 70 to 80% of the circumference. But that we have to check now. Most likely we have completed it, but I need to clean up the area, suck out the smoke, because with coagulation there is a lot of smoke and the stomach was completely full. So I was not able. Post-procedure, sir? Post-procedure, these PPI patients will be on PPI. And during hospitalization, how much? Usually this may not require hospitalization at all. But it can be a daycare procedure. If you are sure that there is no active bleeding that is going on. These patients can go home after 2 to 4 hours after the effect of anesthesia is worn off. So the lens is a little bit dirty, and I think now it is much better. But here we can see that we have done this much. Now this part of the glucose is still remaining. Maybe a little bit more on this side we might do. Maybe a little bit here. Yeah, it's about another. Yeah.
Amol sir, how much circumference need to be covered, because it seems to be a bit less than what is recommended?
Yeah, I am going to do a little bit more. I'm going to extend it a little bit more. But it's always better to, check before you overdo it. You should not overdo it because you can't rectify if you've already coagulated the area. About 1.5 centimeter. The beauty of this procedure is it can also be repeated. So now we have completed this much, around 70% of the circumference. You can see this. Now we have done practically, the complete. Now it is completed. And now what we can do is we can leave this over here, make sure that there is no bleeding, and in case this patient has some symptoms, you can even come back for a second session later on after about 6-8 weeks. Once some remodeling has occurred, we can see how the patient's response is, and then we can even come back and do the procedure, the second time. So there is no mandatory this thing that we have to complete the procedure in one go. Here you can see this. So we are now nearly 75 to 80% circumference, I would say. And I think that is the max I would want to go, because otherwise this patient can land up with a stricture. So I would not want that to happen. Thank you, Srinivas, once again. And,
Very nice demonstration, sir.
So that is.
Thank you, sir, for the nice demonstration of the tooth, sir. Thank you.
Thank you.
Sir, usually patient responded in a single session, or they need 2 or 3 sessions also, sir?
Usually they will respond in the single session if we have estimated it well. मेरे को नाइफ दे दो एक बार थोड़ा सा coagulate करने के लिए. Just थोड़ा सा oozing है. I just want to coagulate that. Let me see.
Chances of little bit delayed bleeding, maybe 2 or 3 hours later.
Yeah, if there is some bleed which continuing, then it's better to arrest it, because this is a vascular area. Sometimes the bleed can continue. Now, particularly in patients who are elderly, who may be on DAPT, there you have to be careful, because you don't want unnecessarily, the patient to come back for a bleed. That is how it is.
Do you recommend like prior checkscopy prior to discharge 4 hours later? Or?
Not really needed. See, whatever is on table, that is going to continue. A delayed bleed will not occur because you just fulgurated. You have not resected anything. So actually, what I thought as a bleed is not a bleed there. So that's fine. Thank you.
Sir, if by chance we ablate more than 80% of the area, suppose 90% of the area, sir, and apart from the stricture, any other complication supposed to happen?
No, just by the circumference, if you ablate 90% of the circumference, there is a little bit of stricture may form, which if you should call the patient back at 2-week interval and dilate with the scope itself. And if the scope does not go, then probably with a 10 millimeter CRE balloon. Make sure you don't overdilate by to 12 or 15, because otherwise all the effect that you have tried to achieve with the ARMA will go away, because then the LES will again open up. So then you have to strike a balance. That is what it is. Okay? So thank you so much.
Yes, sir.
Thank you.
Thank you, sir. Thanks a lot, sir.
Check.
I would like to call Pradhav sir to facilitate Okay, meanwhile, we can start with the next session. I request Dr. Pranav sir to facilitate Mitlesh Mahajan sir. Now is the time for the post-lunch session. I request to call our moderator for the session, Dr. Jayant Yadav sir. He's coming. He's actually downwards. Only. He's coming. I request Dr. Devendra Singh sir. He is a senior consultant, gastroenterologist, Apollo Hospital, Bilaspur, as a moderator for the session. Now I call the chairpersons for the session. Dr. Sandeep Pandey sir. He is a consultant gastroenterologist, Ram Krishna Care Hospital, Raipur. I request Dr. Ashmeet Chaudhary sir. He is a senior consultant gastroenterologist, Apollo Hospital, Indore, to chair the session.
Good afternoon, everyone, for the post-lunch session. So we have two very interesting lectures lined up for afternoon session. Mohan is coming later on, I think. So Rajput, you will be speaking first. Mohan is not around. Mohan. He's always there on time, right, Mohan? Yes. He doesn't miss anything. I request our chairperson to introduce the speaker.
Our next topic will be exploring the small bowel. Has MSc come to stay? Dr. Mohan Ram Chandani will be speaking on it. He's a renowned endoscopist and don't think he needs any introduction to this audience. Dr. Mohan, please.
The audio-visual team, would you please switch off the live transmission from the OT? We need to be having slides from here.
So good afternoon. So we saw a lot of live cases. We'll be showing one of the small bowel endoscopy also. And small bowel endoscopy is totally different from what we were seeing here, because doing small bowel endoscopy means you're doing endoscopy in a noodle, because that's a freely hanging structure in the peritoneum. It's not fixed like esophagus, where you push and your tip of the scope is transmitted to the tip and scope moves forward. If you are supposed to do an endoscopy in a noodle, you will push full noodle. You will never go inside because it's not fixed. So it's like our grandmother used to put thread into the pajama. She will not push. She will pull the pajama on the thread. So that is the analogy which we can draw, that if you want to do an endoscopy with bare endoscope in a small bowel, it will never be beyond ligament of Treats. It will always be. So that is why small bowel endoscopy is always device assisted endoscopy. It is, you have to use a pleating device. So the pleating device, the first pleating device was introduced was double balloon enteroscopy. This was in 2000. So that happened because you can see it is always device assisted. There is a device like a balloon over tube, and inside that there is an endoscope. And this endoscope is having a fixing device, again a balloon, and then over tube comes. Then it fixes. Then again a scope will go through that over tube. It's like now pleating, like what we were doing with that cloth, redundant cloth. We were just pull and push, pull and push. Every time you do, when you pull back, it pleats behind, and then it goes forward. So this was a single double balloon when there was a balloon at the tip of the endoscope. And then came single balloon enteroscope, where the tip of the enteroscope was not having any balloon, but it has an ability to bend to maximum so that it holds there, and over tube comes. And then there is a balloon over there and it pulls back. So this was push and pull enteroscope. Then this was also, only problem is you have a 200 centimeter scope which requires dedicated accessories, 200 centimeter long. So some people thought, why not to use balloon on a normal colonoscope? So this was a company from Israel known as Navy Aid company, which had a demand enteroscopy. Means you can use a balloon through the therapeutic channel, and a balloon was fixed onto the colonoscope. And this was used as balloon assisted enteroscopy. Again, this was not very much popularized because of the colonoscope being used and enteroscope. Then there is a guy known as Paul Eckermann. He saw a curtain on the wall. You can rotate the shaft and curtain moves. That means the rotation energy was converted into a linear energy. And he used this technology to devise an overtube. Again, overtube. Without overtube, no enteroscopy. So overtube was having a spiral at the distal end, and the existing enteroscope, again 200 centimeter long, could be railroaded onto this overtube, and this overtube was used as an propelling device. Again, you can see this is an overtube which was manually rotated, and the bowel started pleating onto the enteroscope, and enteroscope moved forward. Again, this technology was very good because it was, unless you derotate, you will not slip back, which was a problem with balloon assisted enteroscopy. As soon as you deflate the balloon, it falls back. You can see this was around 12 years back when me and Sandeep are doing. I am rotating the overtube, and there is another guy required to direct the enteroscope. So again, this was a two operative system. Only thing was that it was very quick as compared to balloon assisted enteroscopy. This was very quick. And second good thing was, as I said, was stable. Once you reach to a lesion, it will never slip back. So that was the good thing. Within 20 to 30 minutes, you can reach to the maximum depth of insertion. So as of now, we saw all the technologies of enteroscopy. They are cumbersome, requiring 2 to 3 hours, time consuming, traumatic to endoscopist. I developed tennis elbow while I was doing these procedures. But thanks to Olympus, they came up with an idea. They bought the technology from Paul Ackerman and modified this spiral technology and attached a motor onto the proximal end of the scope, which can rotate this over tube. And this over tube was attached to this enteroscope. You can see this scope is 160 centimeter long. This is not like 200 centimeter. So advantage of short scope is you can use all the accessories which are available in our day-to-day clinical practice. Second, this motor will rotate the over tube. You have not to do manual rotation. The third thing was the therapeutic channel. The therapeutic channel is 3.2 as opposed to 2.8 in enteroscopy. So that makes passage of accessory very easy. And then there is an disposable over tube. This over tube can be easily attached onto the distal end of the scope, and then it becomes a part of this scope. And this scope is rotated by a pedal. That pedal is foot pedal, and this will allow this scope to go in. The beauty of this scope is the panenteroscopy rate. You can go from esophagus to the cecum in properly selected patient in 40 minutes. So you can see this is an example. You are going through the G junction, then you go into the stomach, pylorus. And good thing about this scope is having a dedicated water channel, which allows you to do underwater enteroscopy. As happens in ultrasound, if you inflate too much of air, they are enemy of ultrasound and enteroscopy. So as soon as you come into the D2, we deflate everything and put a lot of water or normal saline, and then you just push forward pedal, and the over tube will rotate, and then this whole intestine can be pleated onto the enteroscope gradually, but surely. It will keep on going. The only problem is you may have to rotate the patient, keep on changing the position. You have to do intubation because this is a technology which requires derotation for the intestine to come back, for the scope to come back. So you may lose 2 to 3 minutes if the patient is having some desaturation. That's why I always use endotracheal intubation while doing. And you can see once we have come to the ileum, we can inject contrast to see where we are. Now we are in the terminal ileum, and cecum is just millimeters away. You can keep on seeing your line of finishing by doing this type of third empire. I say that fluoroscopy will keep on telling you a third eye. And you can see this is the IC valve from behind, from the intestinal part. And you can go into the cecum very, very quickly. You can see within 40 minutes, this is the cecum. And this has been confirmed by, and you can see how many loops, 1 loop and 2 loops, and you are into the cecum. So that technology is that it draws the intestine. It does not push. If you use the push and pull enteroscopy, you will see 3 or 4 loops if you ever reach to the cecum. First of all, it is very difficult to reach, but by the time, suppose there is an angiodysplasia here, and you want to fix, you don't want to lose this. If you are having a fixed intestine like spiral, you will never slip out. Not only this, you can do a retrograde enteroscopy. Suppose there is a problem at DJ flexure or esophagus. You can go from behind, from the anal canal, and reach up to the DJ flexure like this. It's also quite easy. And in fact, gradually we are going towards retrograde route because you do not require general anesthesia. And the 2 bottlenecks of enteroscopy during spiral is esophagus. Sometimes we get stuck in esophagus, or sometime at DJ flexure, which we will not find once you are doing a retrograde enteroscopy. You can see still very smoothly you can travel into the small intestine. The therapeutic procedure has become very easy because of the shorter length of the scope. This is a case where I'll skip this, but the therapeutic enteroscopy is around 25% in all of our cases. But the problem with this scope is that those patients who have prior surgery and have intestinal adhesions, now you are using an enteroscope which has no tactile feedback. Because if you are using balloon assisted enteroscopy, you have a tactile feedback. Okay, there is a stricture, we cannot go beyond, I am feeling tough. But here everything is done by machine. So machine has been given a more power to stop whenever there is undue resistance. So if there are adhesions, the machine will not go. It will stop going because it will be too risky for to go. And those patients who have high ASA class, anesthesiologists say, I won't give anesthesia. Chronic liver disease with large esophageal varices, difficult airway. These are some of the cases where spiral is not recommended, or even if you want to do, you have to do after 50 cases once you are very, very experienced on that. Till that time, we saw that can the spiral burst the balloon? This was our topic of the paper which was published in GI endoscopy. And we compared balloon versus spiral and saw that balloon require lot of assistance, like help of capsule to say where is the lesion, or help of CT scan, this is in proximal intestine, go by retrograde route. If this is in proximal jejunum, go by oral route. Spiral does not require any help because of the panenteroscopy rate of 80%. So spiral standalone can beat balloon, but there are certain situations where balloon also is a complementary technology, especially in children, patient with multiple post-op adhesions, large esophageal varices, high ASA class, where balloon is complementary. So both are equal, complementary to each other, but the panenteroscopy rate of spiral is much, much better, and the quickness, that is depth per minute, is much better with spiral as compared to balloon. And the therapeutic capabilities are much better. And you can see this is a case of Peutz-Jeghers syndrome, where you need to do complete enteroscopy examination, otherwise it's waste. Because if their whole small intestine is filled with these polyps, you can see this big polyp in the terminal ileum or distal ileum, there will be, these patients will keep on coming to you with obscure GI bleed or having intussusceptions, recurrent admission to hospital. And now you have a scope which will allow you to do complete examination of the intestine and is stable. If you see these big polyps, you will be scared that if I garland the scope, the polyp with the snare, and I deflate the balloon slips off, there will be mechanical crushing of this polyp, there will be bleeding. But this won't happen with such type of scope. And you can do EMRs. You see, this is the Peutz-Jeghers syndrome in a patient who has a proximal jejunal big polyp. You can do EMR and get rid of complete polyp. And these patients are really symptomatic, and these may require multiple surgeries. If you really want to do surgeries, you have to do, once polyp is gone, again new polyp will develop and patient will come back with so you need to avoid surgeries in this. And if you have such scope which does not slip out, which allows you to do a stable platform and underwater enteroscopy with therapeutic, you can see this is the cecum which has come. And once you have completely removed the polyp, gradually you can come back and remove all those polyps which are left behind. So that gives a complete eradication of polyp. You can also do ERCP with this, especially those patients who have Roux-en-Y hepaticojejunostomy. You can see there. This is the Roux-en-Y hepaticojejunostomy. These patients are really sick. They want, because if you don't treat this stricture, they develop secondary biliary cirrhosis. Redo surgery is very difficult. Percutaneous approach also is an option where you need to do continuous dilatation, but this scope provides us to go right up till to the hepaticojejunostomy side, but it's slightly difficult to reach. But once you reach this stricturous area, you have a short scope, you have a good therapeutic channel, you can do good balloon dilatation and put multiple plastic stent. Every 3 to 4 monthly, you may have to do that till the stricture is remodeled. So this is how we treat these strictures. So in the end, I will say that we have now many studies available, and this is our latest study of 220 cases, but we have done almost 500 cases now. And we have learned which patient has to be referred for spiral enteroscopy. And if you properly select your patient, you can achieve 80% pan enteroscopy, complete examination of the enteroscopy with this scope, which was 60% when we started. So gradually we are learning how to exclude patient. So that's it. I think there is no race. There is no question of race, but double balloon enteroscopy was to start with. It has got maximum pan enteroscopy reported previously. There is extensive supportive literature, but unfortunately it's a long scope, time consuming. Disinfection is very difficult. Single balloon enteroscopy, if you have a lesion, say for example, proximal jejunum in very distal ileum, based on your imaging or capsule, you can do very quick procedure by single balloon. While spiral enteroscopy is one procedure where if you exclude 4 cases like children, post-operative cases, large esophageal varices, very sick patient, you can achieve almost 80-90% pan enteroscopy rate. So small bowel is not so much enigma now. Many advanced scopies have come. These small scopes, shorter scopes, larger verging channel, water jet function, these have improved a lot. And more motorized spiral enteroscopy may be a game changer, making the enteroscopy mainstream due to its ease and significant time saving. Thank you very much.
Now, if there are any questions from the audience, please. Fine.
Okay. Okay.
Thanks, Mohan.
Thank
Thanks
you.
for the wonderful talk.
Thank you.
I think soon we are going to redefine obscure GI bleed, right?
Yes, yes.
You are seeing everything.
Yes, everything. Yes, you are absolutely right.
The next lecture will be by Dr. Rajput.
Dr. Sanjay Rajput from Ahmedabad. He is a senior consultant gastroenterologist at Anshaw Clinic, Ahmedabad, and is an expert in therapeutic endoscopy procedures, including third space. We already seen him today perform one of the difficult cases and how cleverly he stopped bleeding from this patient. And now I invite Dr. Sanjay Rajput for his talk on pancreatoscopy, the new horizon.
Good afternoon, friends, seniors. I would like to thank Dr. Sanjay Kumar for inviting me for this lecture. And it's a very fruitful and very nice cases we are seeing. And we are learning every day. Dr. Mohan was telling कि मेरी हाइट कम है तो मैं दिखूंगा नहीं, लेकिन मोहन सर को ये बोलना है कि आपको हाइट की जरूरत नहीं है. आपके बारे में लोग सोच के अपने आप आपको देख लेते हैं. आपका शरीर की ऊंचाई जरूरी नहीं है, मन की ऊंचाई और काम बहुत बड़ा जरूरी है. तो आपको हाइट की जरूरत ही नहीं है, आपको पूरी दुनिया में लोग जानते हैं. So cholangiopancreaticoscopy has changed the management of CBD and pancreatic duct in last 10 years. Why do we need? Because as we know, ERCP guided brush and ERCP guided biopsies has less result than the what we needed. It is around 50 to 60, even if we take biopsy, brush and all together. Evaluation of pancreatic duct is as challenging due to its altered anatomy and limitation of cross-sectional views. But nowadays we are getting more and more pancreatic CT scan, which are very good in qualities. Relative inaccessibility to available endoscopy devices only for pancreatic duct. It has unique obstructive disease entity, and these limit the diagnostic and fluoroscopic guided therapy in pancreas. And stone extraction from pancreatic duct may be limited by stone impaction in the side branches or a narrow proximal pancreatic duct, which may limit the balloon extraction. Non-endoscopic intervention of pancreas is not as developed as non-endoscopic intervention of the common bile duct. Technique, as we have already demonstrated, you have to take the cholangioscope, you have to cannulate the CBD or PD, and then you have to irrigate the channel
continuously to see the channel, and you have to pass something to do the therapeutic procedure, either a guide wire, either a laser fiber, or snare, or a basket. All these are available with the cholangioscope. This and how it is helpful in our clinical practice. Previously, we were thinking that normally when a common bile duct stricture patient comes to you, normally when common इसको बड़ा करो ना, इसको बड़ा करो left side. Whenever you are getting a patient of common bile duct stricture, there are dilemma whether this is benign, whether this is malignant, whether there is something else which is hiding behind the stricture. So now with the help of cholangiopancreaticoscopy, with the help of cholangiopancreaticoscopy, we can definitely say in 80 to 90% of the cases whether we are dealing with benign stricture, whether we are dealing with malignant stricture, or there is something else like IgG4 stricture. We can take biopsy. So delineating a benign or malignant stricture is much more easier with the help of cholangioscope rather than any other imaging modality. You can take biopsies. Diagnosis and staging of bile duct cancer, removing larger stone as we saw today, finding cause of recurrent bile duct stones, and selective stenting of intrahepatic duct. Sometimes what happens, you are going into right hepatic duct, but you are not able to go into the left hepatic duct selectively. Then you can guide with the help of cholangioscope, and you can enter the left or right hepatic duct selectively. You can remove foreign bodies like bile duct stone, bile duct stents, or some foreign bodies which has migrated into the common bile duct, or removing a metal stent with the help of this. Indications are diagnostic as well as therapeutic. Pancreaticoscopy for IPMN, for indeterminate stricture of common bile duct and pancreatic duct, or sampling of the tissue from the pancreas, or pancreaticoscopy guided lithotripsy, stent retrieval, or nowadays we are getting more and more photodynamic therapy and RFA available for treating palliative malignant strictures of the common bile duct and the pancreatic duct. New scopes are coming with now. Today we have seen the spy scope. Now this is a direct cholangioscope from Olympus, which has NVI facility, and you don't require double operation. The same scope will go inside the duodenum, and same scope will go into the common bile duct. It has a different angulation than the normal upper GI scope, so you can directly go into the CBD and take good pictures like high definition images with this. You can find out the cause of recurrent stone. This is a suture inside the common bile duct. Patient was coming with recurrent stones, and when cholangioscopy was done, we have find out a suture inside the common bile duct, which could be a cause of, which could be a nidus for the stone formation. This is how balloon assisted. When you do not have cholangioscope, you can directly put a balloon in the common bile duct, and over that you can pass a small caliber endoscope like nasal endoscope, and you can do the cholangioscopy also. This is difference between the normal spyglass scope, and the image quality is much better in the direct cholangioscope. The image quality is much better in direct cholangioscopy. It is very important in evaluating stricture, where you can see directly whether this stricture is benign or malignant, and you can take direct under vision biopsy, which is much superior than the blind biopsy. This is how cholangioscopy normal image looks in direct cholangioscope vision. I will show. This is another picture of cholangiocarcinoma with the normal cholangioscope, direct cholangioscope. And this is how you look. Picture you can directly see, and you can judge from the image only. The visualization itself has a 90% sensitivity of the malignancy, and you can directly say that without biopsy also this is malignancy. So per oral cholangioscopy plus biopsy has almost 100% yield for ruling out benign as well as malignant stricture. What you can see in cholangioscopy, I have different, this video will show. This is a very good video taken from ASG, where this is a benign stricture, inflammatory stricture. This is how CBD stone looks inside the CBD. You can do lithotripsy. These are all direct cholangioscopic pictures. So how good the image is, you can see. This is pulverization of the stone with EHL. You can use laser or EHL. In Europe, most of the time they are using EHL, and mainly in pancreatic duct. While here, this is a worm inside the CBD, live worm. Very recently, we have published this case. Cholangioscopic picture of, beautiful picture of, and this is liver fluke. So you can see how beautiful images you can get with all these rare pictures. Cystic duct stone post-lap chole is a burden for a surgeon. Nobody wants to operate again for a cystic duct stone. With cholangioscope, you can directly go into the cystic duct, and very recently we have published 30 cases of only cystic duct stone post-lap chole, which have been dealt with cholangioscopy, and you can see the how easily you can pulverize the cystic duct stone. You can see the cystic duct. It was impacted, and with pus, patient was having recurrent cholangitis. And you can surely and 100% effectively cure this patient without surgery. So this is a boon for cystic duct stone patient. Again, pancreatic duct stone, which are big dilated ducts, you can easily pulverize these pancreatic duct stones with the laser, which we used to send the patient for surgery for larger stones. Those who do not have the facility of extracorporeal lithotripsy, we used to send the patient for stone surgery. Here we can easily use the laser and remove any size of the stone. Stone size doesn't matter in pancreatic duct as well as CBD. It may require 1 or 2 sessions, but you can easily do the lithotripsy and remove the stone. See how hard the stone is, but still you can manage with the help of this laser very easily, and it will break. This was fully impacted stone, even the guide wire was not going above. So we dilated the lower pancreatic duct, and with the help of spy scope, we went in and then broken the stone, and patient has been saved from big surgery. You can see the stone has broken. This is what I was telling about, that once patient has lower CBD stricture and you are not able to go in, here you can put a metal stent inside the CBD and call the patient after 2 weeks. You can go in with the stent. You can go in with the stent, and if you see that stone has been impacted above the stent. So then we could remove this impacted large stone with the help of metal stenting and then doing laser lithotripsy. So metal stenting is boon for this type of single stricture patient, where you can go in with the put the metal stent, do the laser lithotripsy and remove the stone burden and cure the stricture also. Foreign body is a very difficult thing to remove from CBD or pancreatic duct. Today we have a case of CBD stent migrated. Dr. Mohan, I think, is going to show. This was a migrated pancreatic duct stent deep inside the pancreatic duct, which was removed with the help of pancreaticoscopy. This requires minimal dilatation of 3 to 4 millimeter of pancreatic duct to pass the spyglass inside. And with the help of basket or snare, you can catch hold the stent, or you can pass a guide wire through the stent. If you can see the end on view, you pass it and then cannulate it with the help of Sohendra lithotripter. And then with the Sohendra lithotripter itself, you can engage it inside the Sohendra lithotripter into the stent, and then you can remove the stent in toto. Sometimes there are broken fragments also, which you can remove with the help of this. IPMN, it looks very beautiful on pancreaticoscopy. You can see. And this IPMN SpiceScope guided therapy is now available because in IPMN, surgeon want to remove only the part which is affected. So IPMN guided surgical therapy is now taken all over the world, where you have to remove only those portions which are affected, and you can see those portions which are not affected, you can save those much pancreas. Pancreaticoscopy guided therapy. Intraoperative and peroperative pancreaticoscopy is also taken for surgical cases. Intraductal ultrasound and intraductal confocal microscopy is coming in big way to have the therapeutic effect. So if you save your SpiceScope, it will be cost effective. This is how we can save our SpiceScope, and we can use this many times single scope.
So now with direct cholangioscopy, we are seeing beautiful, clear, crisp images, and
Hello,
the
hello.
look
Devinder,
is also
Dr. Yadav.
very comfortable.
Dr. Yadav, am I audible from OT? Ria?
I request Dr. Sandeep Pandey sir to present momentum to Dr. Sanjay Rajput sir.
Hello. Am I audible there in the hall?
Check one. Check.
Hello.
Hello.
Hello. Shall we start with two cases we are ready with?
So now we are moving towards live sessions. For this, I would like to call our chairpersons, Dr. M.H. Usmani sir, Dr. Piyush Pathak sir, Dr. Vikas Regwar sir, to chair the session.
And I request Dr. Ajit Sekhwani sir to present a momentum
Hello.
to chairperson Dr. Sandeep Pandey and Dr. Ashmit Chaudhary.
Sanjay sir, we are audible?
Yes, you are audible. Who's there?
Am I audible there?
Hello.
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 I am audible from OT2.
Dr. Yadav?
Usmani sir, I am audible from OT2.
Yes, you are on.
Okay.
Okay.
Rajesh, what are you going to do?
Yeah, Dr. Devinder.
There is no audio input.
So we are live under OT2. This case is a patient of a pancreatic uncinate process mass. As per the CT, there is a contact of the mass with the portal vein more than 90 degree. He was in the cholangitis, so already stent has been placed. So the idea of here is the US demonstration of the uncinate process mass and its relation to vascular structure and the FNB. Dr. Rajesh sir, you are live.
Okay.
Can you have an endosono view on big screen? Endosono view on big screen?
Am I audible there?
Yes, Rajesh, very
So,
much.
Dr. Devendra, this gentleman has
check.
obstructive jaundice with cholangitis, underwent metal stent placement with the head of the mass pancreas. And the duty assigned is to me to look for the operability, look for the spinoportal confluence, and to give the tissue diagnosis because brush was negative. So just to give the glimpses of EUS normal and not me, I'm in the mediastinum and you can see the anechoic longitudinal structure, that is the aorta, and I'm pushing my scope down and you can see a hypoechoic lining just above the aorta is the left crush of the diaphragm. And where the left crush of the diaphragm will finish, you will see the most likely the origin of the celiac. Can you appreciate the origin of the celiac here?
Yes.
Is that clear? Can you see the celiac? And just below the celiac, there is a SMA. So we can see the celiac artery, and this is a SMA. If I push my scope little further down, you can see the pancreatic parenchyma. This is the pancreatic parenchyma, and you can see a mildly prominent pancreatic duct. Is that right? And if I rotate my scope clockwise and making the big knob up, you can see the left kidney, and further clockwise rotation, you can see the spleen. Okay? And this is the splenic hilum. I will further do anti-clockwise. You can see the left kidney, you can see the left adrenal here, and anti-clockwise further rotation is aorta, and this is the left lobe of the liver. Once I am in the liver, this is the way you see the pancreatic parenchyma in the body and tail. I am rotating clockwise and you can see the portal vein. So this is the portal vein. If I follow, and you can see some pneumobilia just distal to the portal vein. So there is a CBD here and you can see the pneumobilia hyperechoic structure in the liver parenchyma. If I follow the portal vein deep, I am following the portal vein deep inside. I am pushing my scope. In. I'm pushing my scope, and this is the splenoportal confluence. Okay? This is the splenoportal confluence here. Yeah. This is the portal vein, this is the splenic vein, and just above is a pancreatic parenchyma. Is that right? And we can visualize, this is also important to look for the liver. There is any metastasis. So you see I'm rotating the liver over my scope by pulling and pushing. So I'm rotating my scope, I'm rotating and looking. There is no evidence of liver metastasis. So I'm scanning the entire liver parenchyma. Can you appreciate trace amount of ascites here? Can you appreciate here trace amount of ascites? This is the very small amount of ascites. And you can see the patchy pneumobilia we can see, but the liver parenchyma shows no evidence of metastasis. Okay? Now, once I did my examination from the OG junction, my next junction is the first part of the duodenum. So, what I am going to do, I will take my scope. Can we sit a little bit? So, what I am going to do, I will take my scope to the first part of the duodenum. Can we sit it? So I will introduce my scope to the first part of the duodenum. This is the pylorus. Okay, I am in the first part of the duodenum. Now here what I am going to do is, my intention is, can you see the stent here? Can you see the stent artifact? And this is the head of the pancreas. This is the portal vein. Now, this is the Doppler. Can you see the portal vein here?
Yes, clear.
And this is the mass. So I will remove this. So the mass is enfaced with the portal vein. You can appreciate these are the stent artifacts which you are seeing, but this is the portal vein where my cursor is. This is the air which is producing the artifact. So that's why it is important whenever you are planning to do the stitching, it is important you should always do. So can you appreciate a mass in the head of the pancreas with the portal vein? And below is the splenic vein here and the SMV vein here. Okay? So this appears that the mass is involved in the portal vein. Can you see here? This is the portal vein and this is the mass. So this is the one way. Second, I can go deep into the second part of the duodenum, shortening the scope and focus the mass in the short loop position. So I have reduced my scope to the second part of the duodenum. You can see the evidence of pancreatitis which might happen after a ERCP. You see the periduodenal edema? Now what I am going to do, can you appreciate the periduodenal edema here? So this is most likely a post-ERCP pancreatitis. I am rotating my scope clockwise. You can see the small lymph nodes. Can you appreciate a small lymph nodes? And further clockwise rotation, I am doing further clockwise rotation here. This is the pancreatic head. This is the pancreatic head. You can appreciate a mass lesion here. Can you appreciate the mass lesion? Is that right? And soon, because this is an uncinate process, soon you are going to see the metal stent. So that is one of the. Can you appreciate the metal stent here? Can you appreciate here? So this is the side effect, artifacts of the stent which you are seeing here. Can you appreciate? Yes, sir. Okay. This is the metal stent with the air artifact, and most likely this is the pancreatic duct. I will put a Doppler. So this is the pancreatic duct. Okay. So the CBD, my intention is not to look for the CBD. My entire intention is to take the FNA. And can you assess this large mass here? Can you appreciate a hypoechoic mass? So this is the large hypoechoic mass, and you can see the PD is getting cut off here. Have you noticed? So that's why we say double duct sign. The pancreatic duct in the first 2 centimeter appears to be normal, and here the pancreatic duct is blocked by the mass. Here the changes of the pancreatitis which happened either because of the mass or because of the stenting. And this is the large mass. Can you appreciate, Dr. Devinder, here large mass?
Yes, Rajesh, very much.
Can you appreciate the large mass? And as I said, it is abutting the portal vein. Can you see the portal vein is coming here and pushed back by the large mass? So what I am going to do, I am going to take the FNA. Now, please.
So what will be your site of preference for the FNB? Either D1 or from this side?
So this is a very good question. This is in the uncinate process of the pancreas. This is the challenging case where the FNA is difficult, and what you do is you just go away from the gastroduodenal artery. I will show you where is the problem. Can you see my my sheath has come here? Sheath is here. If I lock it here and I want to bring my needle out, if my needle, can you appreciate my needle here? Can you appreciate the needle here? But the mass is here. So I have to pull back my scope further. I am pulling back my scope. I will pull back my scope. I will further pull back. I will further pull back. There is a possibility I might fall back. Can you appreciate here now? This is the portal vein going across the mass. I will use the elevator to bring it down. Still, can you appreciate my needle is coming here, and the mass is here.
Yes, sir.
I have to pull back. There is a
Can we have the room
possibility.
view to see the movement of hands?
You require to avoid the stent. This is the gastroduodenal artery here. This is the gastroduodenal artery. You know, this is the GDA. And I will puncture from here. So I will further withdraw. I will withdraw this area. This is the area which I am going to
And this
target.
is one of the most difficult locations for the
Yeah, but it's not a problem. We'll do it. I will show you. Can you put the Doppler one?
Doppler. Second, what is your preference of needle for this?
So we discussed during our lecture that 25G is the best needle in this. Dr. Sanjay wants a core tissue to demonstrate. And can you see the blood vessel coming here? And somebody has asked me how to avoid. So what I am going to do is, this is the mass. I will remove first Doppler. Is that okay? Now I will use the elevator. So I will avoid, is that right? Is that, can you see the mass now? Can you put the Doppler, please? Yes. Yes, so these are the two blood vessels, is that right? This is the portal vein here, and this is the GDA above. And the entire intention is to avoid this. So if I do a like this, is that okay? I will do the, my needle will further come down. Can you see the Doppler once? Can you see the metal stand now? Yes. Can you appreciate the metal stand? Show the Doppler please again. Show the Doppler please. Okay? Is that window is okay? Yeah. You see the between the two vessels, what I am going to do, I will withdraw further. Okay. I think that is okay. So, Dr. Devinder, can you see this?
Yes, very much, Rajesh.
And again Doppler. Okay, so there is no blood vessel in between. What I am going to do is, here I rotate little bit clockwise. I did anti-clockwise rotation, and I'm in. Okay. So you can appreciate my needle is here. Can you appreciate my needle? This. So what I can demonstrate a little better position. I'm just withdrawing because I will further withdraw. I will further withdraw. I will further withdraw, and this must be a better position. Will somebody will put the Doppler please once? Put the Doppler. Okay. Is that okay?
Rajesh, with two such vessels nearby.
Yeah, Dr.
Scanning will
Devinder,
be
you can
possible.
appreciate. Can you appreciate my needle is between the two blood vessels.
Very
There's a
clear.
two blood vessel, and I am inside the lesion. You can appreciate the needle also. Can you appreciate needle
How
here?
many passes you are intending to do? How
So,
many passes, Rajesh?
so I will like 1, yes, and I will do slow pull, 2, 3, 4 on the one side. I will pull my scope little bit more. I will pull my scope little bit more. 1, 2, 3. I make my big knob away from me, and 1, 2, 3. So I think that is more than sufficient. If required, I will do one more pass. I will remove and will demonstrate what has come out. Just hold it down, please. So on the slide, take out the, take out the needle.
Show us your yield,
Hello.
Rajesh.
We are ready with the Z poem. So Rajesh will come back to you. Meanwhile, Neha, can you tell the history of this patient?
Yeah, place it.
We have almost got the sufficient sample.
Okay,
I
fine.
think
Can we show once?
Can you see?
Can we focus?
Yeah, we don't have the room view. Please show us.
एक बार और लेंगे पास.
Anyway, we are moving on to the other OT. AV team, please. Yeah, they are played. Looks nice.
So you can see the whitish core. You can appreciate the whitish core. Here is the whitish core. Here is the whitish core. So we'll take one more pass. and then we can send for the cell block if they wanted. You want for cell block?
So we are shifting to the OT1.
Did in
The history goes like this.
This is a 76-year female presented with us regurgitation of food, even with the tablets for last 3 months. Barium solo was done, showed the blind pouch arising from the lateral wall of upper esophagus. Evidence of Zenker's diverticulum. Endoscopy was also done, showed the large blind pouch seen just below the cricopharynx. Rest endoscopy is normal. This is the image. Now the procedure is performing Z poem and we are live to OT1.
Yeah, Mohan, you are on.
Yeah, good afternoon. And I have with me Dr. Amol, the master of third space, and Dr. Sanjay Kumar, and rest of the team, Srinivas from AIG. So you can see now we are doing the endoscopy, and I am just hitting every time. You see that that's the diverticulum which we are going in, and then there is a septum there, and then we go very difficulty. It goes into the esophagus. So that's the anatomy. Is it clear there?
Yes, yes, very much.
So that's the
What is
septum.
your plan, Mohan? What do you have to do?
Yes, can you? Yes, please tell me.
Mohan, what is your plan on this?
So plan is to do third space endoscopy. You can see this is the esophagus, and this is the septum which is dividing this diverticulum. So this whole of the food is getting deposited here. This septum. So we have to remove this septum. Now the septum can be cut directly or under the mucosa. Amol, what are the pros and cons?
So, conventional flexible septotomy, which we used to do earlier, there we used to divide the septum in its full thickness, mucosa, submucosa, and the muscle layer, and connect the diverticulum to the esophagus so that the septum empties into the esophagus. But the problem is that there is a 11% recurrence rate and there is also a 11% complication rate. So what that means is, if the septotomy is too deep, that can lead to complications, and if it is too shallow, then it gives rise to recurrence.
Yes.
Now, using the Z poem technique, the third space endoscopy technique, what Mohan is going to demonstrate to us is, he will go under the mucosa using the mucosal flap valve technique, and he will divide the entire septum in its complete length, even up to the upper esophageal sphincter and beyond the UES, so that he gets a complete septotomy. And then he will close the mucosa on top, so that the risk of perforation is minimized, and at the same time a complete myotomy can be obtained. So that is the advantage. So Mohan, there are two ways have been described. One is the lateral approach and one is the central approach, which you are doing just now on the septum. So is there any preference when to use what?
We are not hearing Mohan.
Okay, just a minute. Let me see if this is on. Yeah, otherwise I'll give Mohan this mic. Mohan, you can speak here.
Yeah, so this is the technique where we are dividing the mucosa onto the septum. And then we have to create a tunnel like we did. So that's the esophageal side of the tunnel.
Are you able to hear Mohan? Is Mohan audible in the auditorium?
Yes.
Okay.
He's audible now.
Okay.
So I'm just deepening this tunnel.
And mind you, this is a very vascular area, so sometimes there can be very brisk bleeding. So what Mohan is doing is Mohan is using the hybrid knife from Irby, and Mohan, this is the I type knife that I can see.
Yes.
Yeah. Okay. So Mohan, Rajesh wants to show the sample that they have taken.
Okay.
Maybe we can just go to the room and then come back over here.
Okay. Meanwhile, I'll try to
Yeah,
get into
we'll
the...
try and make the entry over here. Mohan, do you prefer going on the diverticular dissection first, or do you prefer the esophageal dissection?
Esophagus. You?
Because even I prefer the esophageal, because once you do on the diverticular side, entry onto the esophageal side becomes very tricky. That flap just keeps...
David, can you switch off OT1 audio? Yes,
Dr.
Rajesh,
Devan?
you are there.
Yeah, so this is the first I have focused in the short loop, and now I have focused the lesion in the long loop position. And you can appreciate this is the large mass. You can appreciate large mass here, and the end. Yeah, and my scope is in the long loop position. Now I am going to puncture from here. Okay, I am inside the mass. Can you see here? Yes. So I will do the, withdraw slowly. I will do the technique. My big knob is away. I puncture 1, 2, 3, 4. I make the big knob here. 1, 2, 3, 4. I make here. I use the elevator and 1, 2, 3, 4. That's all. This much you require to, and that is. So my interpretation in this, there's a large mass with the metal stent in C2 and is abutting the portal vein for more than 2.5 centimeter or 3 centimeter with the evidence of acute pancreatitis with the peripancreatic lymph nodes. And please make it spread. We have to put it in the form, otherwise, please put it. Yeah, keep on doing. Keep on doing. Keep on doing. Yeah. Now, is the slides are visible? We can demonstrate this slide.
We don't have the room to.
Can you see here?
Yes.
Yeah, and this also. And this also. So I think that is sufficient tissue. You can appreciate the white core inside, and that is sufficient.
Round of applause from the room for you, Rajesh. Wonderfully done.
We can put it in the formalin. Which is formalin?
Can we move to the other room, OT1?
एक मिनट रुक जाओ, पे पेशेंट है यार, ये फॉर्म एक मिनट रुक जाओ.
We change the audio also. Yes, Mohan, you are on.
Yeah. So you can see now we are doing the same dissection what we did in poem. As I said, learn poem and you will be able to do everything. So you see that this is the tunnel which we have made on the esophagus side. This is the tunnel and this is the top of the septum. And as you come out, you will go into this is the diverticular side. So we'll now make a tunnel on the diverticular side. So keep injecting, Shino. Make a good cushion. So that's the tunnel. Can you appreciate? So that's the septum. That's the submucosa on the diverticular side. This one.
Excellent demonstration, Mohan. So here you can see that there is mucosa on both sides. On one side is the diverticular mucosa and one side there is the esophageal mucosa.
So there is some submucosal fibrosis there.
Yeah, usually you will encounter some submucosal fibrosis on the diverticular side because of food stasis over there.
You can inject and cut at the same time.
See that I did not inject here, but its tunnel is already made.
Tunnel is already made.
So that's happened with submucosal fibrosis, and we have not injured any mucosa. See that tunnel is right up till to the bottom of the diverticulum. That tunnel on this side, and on this side, we know that it has gone beyond. So now it's time to cut the muscle. Okay? What do you think, Amol?
Yeah, I think so. I think we can start the myotomy.
Right up to the bottom.
Excellent.
So it's time to cut this muscle. So we can.
And you can see that this muscle is twitching as Mohan is cutting it because it is somatic muscle. So it will twitch.
So that's the muscle. You can see from the top. So I have to preserve this. So I'll bring this muscle here. And you can
see how Mohan is preserving the muscle on both the mucosa on both sides. And as the diverticulum becomes shallower and shallower, you can see that the diverticular muscle and the esophageal wall musculature, they are splaying separately. So you are now seeing two layers. This is the esophageal side layer, and on this side is the diverticulum side layer. See, this is the one. And now he can do a myotomy right till the base of the diverticulum. That is the beauty of this procedure.
So that towards the esophagus, we'll cut that. So that's the area where the food is getting stuck. See, this is very safe. You are cutting the septum, but you are under the mucosa.
Mohan, how do you judge the adequacy of the procedure?
Yeah, that's a very important. So this is the beauty of this. You need not, even if you overdo, it's okay. Because usually in that direct procedure, adequacy is important to assess, but not here. You can see that we have almost gone beyond that.
He's reached the base of the septum of the diverticulum on the diverticular side, and on the esophageal side, it is now recommended that you should extend the myotomy for about 8 to 10 millimeters distal to the base of the diverticulum to get a complete UES myotomy.
See that now this is the V shape which we see. That's complete septum division, and then this is the diverticulum, and now you can see it's easy to get in the esophagus side. The good thing is that there is no mucosal injury, and then whole septum is gone like this. If you want, we can cut more. Inject. That's the muscle. So done. So that's the muscle which is cut completely.
Excellent.
There was some submucosal fibrosis on your left side, and right side, see the how good healthy submucosa is there. And that's the muscle end.
Can you see that?
Yes, Amol, we can.
Now that's the end of procedure, and we'll just clip and see what Amol was asking. Previously, we used to start from here, make a tunnel, and reach here. But that's not required. And that saves a lot of procedure time, and also
Also the clips which used to come higher up in the pharynx, that is now minimized because these clips will remain under the cricopharynx now, and because of that there is no irritation.
Yeah.
That also is advantage.
So only drawback of this procedure is this mucosal flap, which may cause some dysphagia. But once if it has caused some dysphagia, we can also make a small cut between the two clips.
Yes. But usually this mucosal flap will regress now because there is no muscle underlying it. So it will just shrivel and fibrose away, and it will recede so that the base of the diverticulum becomes open and starts draining into the esophagus.
Yeah. There's a clip.
We need usually Boston clips or the larger clip. Of course, we can use Olympus clips also here, but
Okay then. Joy de do.
no, it is below the cricona, so it doesn't. Usually, we prefer to use clips with a short hair, short tail, so that they don't project out of the UES.
Um,
The shortest tail is micro. Nothing shorter than that. Microtech. That is the shortest. I've tried all of them.
So you have to come out slightly, open the clip, fully open. You will hear a nice click sound and then just rotate. Open now full. Okay, no, I'm not happy. I want a bigger clip first. You have? So this clip is okay for a usual closure, but I'll show you the difference between the clip of which are larger caliber and the amount of rotatability.
Yeah, so the Boston clip is very good in this regard because it's a really wide clip and it's a 360-degree rotation, so it gives you complete control over the.
Yeah. So I'm just sucking out everything. Open please, so that both the lips of the cut are rotation. Please show the Srinivas hand.
And you can show Srinivasa's hand, I think.
And then we'll apply this here. Yes. Okay. So that's our first clip. Then we remove this. See that this, if this is short, I am very happy, but this is very long.
This tail is very long. Otherwise, it's a very good clip, but just that the tail is a little bit too long. So makes the applying the second clip a little bit challenging.
But once your first clip is applied nicely, it approximates both the walls together, and then the application of subsequent clips become very easy. Open. Yeah. Okay. Yes. Apply. So you have to just push the first clip with the cap, make a space for second clip, and you are ready for the second clip. See that how I am pushing? It's like a retractor. The cap acts as a retractor. I would retract this also, both away from my vision. Pull the scope till it retracts. It hides behind the cap. It's easy saying than to do. And then come back, and you have only this.
Excellent, I must say, Johnny.
Excellent dexterity, Mohan. That looked slightly difficult to begin with, but then you have done it.
Yeah. Yeah.
Usually it will require 3 or 4 clips for closure of this incision because the incision is not very wide. Now this Boston clip has this small ball which falls off.
Correct.
And that you have to be careful when you are closing tunnels in third space. You don't want one of those balls to go inside the tunnel. Because that can cause a foreign body and it will, it will stay with the patient till his grave or whatever.
So that's it, I think.
That is.
So you can see now our esophagus opening has opened up a lot, and we are going right into the esophagus very easily.
Excellent.
Big round of applause, Mohan, for you.
And this diverticular septum is almost gone. You can see.
And with the clips, long clips, the mucosa will further shrivel away.
Yeah. So now we have a big opening of the esophagus and almost no height of the diverticula. So that's the end point which we have to achieve.
So, Mohan, what will be your post-procedure feeding plan?
Pardon?
What was your feeding plan? Like what
So we
food?
can
What will you
start
allow?
after
What time?
24 hours. We can start. Yeah.
What if the mucosal flaps give trouble or sensation, or if the food gets stuck, then it has to be cut? Or
Mucosal flap, I think we should wait for fibrosis to happen for at least next 2 to 3 months. Once everything gets stuck, then you can make a small incision on the mucosa.
that's all.
That's all. But that won't be required in this. That happens if the diverticulum are more than 5 centimeter in depth. So that form a big curtain. So in that case, what we do is we clip first on two sides and then cut the mucosa before applying the clip in the middle. So that makes a V-shape incision in the mucosa. That is during procedure.
So that was an excellent demonstration by Dr. Mohan and Dr. Amol. I'm sure you would have liked it. And I'm sure not many people have seen live demonstrations of ZPOM because the disease itself is not that common.
Unfortunately, in India, we don't get much.
And many remain undiagnosed also, perhaps.
Yes.
So any other questions from House, Devender?
No, well, they are so impressed that they're spellbound, actually, most of them.
Thank you.
Thank you.
Thank you. So we'll move on to other OT where we have a patient of alcoholic hepatitis, and since the liver enzymes were very high, all the viral markers were negative. So we were planning to demonstrate a US guided liver biopsy. The biopsy was indicated anyway, and we thought we can perhaps do it with US, and we can discuss with Dr. Saurabh what are the advantages of doing liver biopsy through US.
I request Dr. Arvind Namdev sir to please give a memento to our chairpersons, Dr. M.H. Kani and Dr. Vikas Raikwar.
नहीं तो नहीं खुल पा रहा है तो मसल काट दो. मसल तो अल्टीमेटली मसल काटनी तो है ही. That makes lot of space.
मायोटोमी थोड़ा सा करना ही पड़े, नहीं तो इधर नहीं घुस पाओगे. घुसता ही नहीं है. और कोई रिस्क नहीं है.
Audio team, can you switch on the other OT's audio, please?
And for the next session, I like to invite Dr. Ajay Nanme sir and Dr. Laukush Tiwari. Dr. Ajay Nanme sir is a consultant gastroenterologist at KMC Bhopal, and Dr. Laukush Tiwari is gastroenterologist.
ठीक है भैया. एक्टिवेट कर दिया नहीं. ठीक है.
Sanjay, you are on with the next OT. What is the case?
So now we are shifting to the OT2. The case is we have a male patient, 50 years old, alcohol use disorder, cirrhotic dose, last intake 1 week ago, having complaint of progressive jaundice for last 2 weeks, loss of appetite and low grade fever. Initially there is no cholestatic features, upper GI bleed, abdominal distension and altered sensorium. These are the symptoms. His LFT showed total bilirubin 3.10 and the OTPT is 643 and 345. His INR is normal and CBC is also normal. USG abdomen shows diffuse fatty liver with hepatomegaly, and CECT abdomen showed the diffuse hypodensity PV 16 mm intraluminal fat density lesion with proximal jejunum. UGI endoscopy done showed congestive gastropathy, no varix, duodenal submucosal lesion. Fibroscan E value shows the fibrosis 11.8 and the CAP score is 326. The planned procedure is EUS for evaluation of D2 submucosal lesion, portal hypertension and liver biopsy. Now we are live to OT2.
Saurabh, you are on.
Hi, good afternoon again. I don't know, I'm not sure if I'm on yet. Can you hear
Can you
me?
hear the voice of
Yes,
Dr.
you are.
Saurabh from OT2?
Yes, we can hear you.
Oh, you can? Okay, nice. Yeah, hi, I'm Saurabh Mukhevar. I'm back in action. So we have a patient here with LFTs and suspected cirrhosis. So what we are planning to do is a liver biopsy. This will be done with the help of endoscopic ultrasound. And is this okay? Hello. Oh, okay. Yeah, so the patient is getting sedated. We'll just talk about liver biopsy. Liver biopsy from the help of EUS has certain advantages, and that's why we have shifted to EUS liver biopsy in all the feasible cases at our center, because for patients, it's a painless procedure, and it doesn't take a long time. It does permit evaluation of the liver and structures, and okay, I think that's the patient's getting ready. And it allows you to get access to the left and the right lobe for whatever reason to get biopsies from either of the lobes that can be performed. The choice of needles, Dr. Rajesh Puri did outline the various needles that are available in the market, and we have a good choice of needles out there. So by and large, you don't use a 25 gauge needle. Remember, a biopsy or a sample from the mass, which is done primarily to gain tissue, which is going to determine malignancy or lymphoma or something. But here we are doing parenchymal biopsy, and when you're doing parenchymal biopsy, you require a lot more tissue, and tissue architecture has to be determined. Okay, so I'll just.
Saurabh, your caller mic is a little far away.
Yeah.
Could someone please,
Okay,
put
can
it
you
a little
now?
up?
Okay, actually, you know what? I will move it a little up.
Far away from your mic.
Okay, can you hear me better now?
Yes, but
Yeah,
yeah,
sorry.
yes.
I can repeat. Did you hear what I said, or should I repeat that?
We did, in fact.
Can you raise the
But this
volume
is
in the room,
better.
please? Ready? Okay, I think we are trying to raise the volume in the room so that we are. Okay. Yeah, I need heparin flush, huh? Heparin flush. ठीक है, restart. Yeah, so you just get some technical issues sorted here. So yeah, so I was going back to your biopsy. Now, this is a liver parenchymal biopsy that's being performed. We are not doing a sample LNA from a lesion to determine cancer, right? So when you're doing a liver parenchymal biopsy, per the American Association of Study of Liver Disease, ASLD, the guideline, you want at least 11 portal tracts to be there. That's the minimum required for specimen
You're
adequacy.
losing your voice in between, Saurabh. You're losing your voice in between.
Oh, sorry.
Losing voice in between.
Okay.
Can somebody hold another cordless mic for him?
Yeah. So yeah, I'll say again. Can you hear me better now, or not really?
Devendra sir, this mic is loud enough.
This one is better? Okay.
Yeah, okay. All right, so I will, thank you so much, yes. So we are switching to the other mic. So yes, anyway, I was talking about the fact that you're doing liver parenchymal biopsy, and in such cases, you want at least 11 portal tracts to make a definitive diagnosis of what's going on. And typically, you at least need a 2 centimeter specimen length. So that's the criteria. And therefore, when you're doing the biopsy, the technique is very different from a standard FNA or FNB. So standard FNA, FNB, what we generally do is, okay, I'll switch. Can you see the US views as well, right? Okay. So standard FNA, FNB, we basically use a slow pull stylet technique that gives suction and those cells can be pulled in. But when you're doing a parenchymal liver biopsy, the technique is different. What we use is a heparinase needle, and then that's inserted, and we use that for biopsy. Now what I'll do is I'll show that to you. Meanwhile, our scope is now here inside the gastric lumen. And as we are pulling, we would like to see the structures. What you're seeing on the screen is the pancreas. I'm going to reduce the depth a little bit. Yeah. So in this particular case, we are going to, the objective is to see a couple of things. One is changes of portal hypertension, and two is obtain a liver biopsy. So what I'm going to do is move my scope around.
Dr. Saurav, just once I'm interrupting.
Yes, of
Again,
course.
this convention
I
is
think this
from
is-
left to right.
No.
And
In fact, thank you, because it has to be opposite.
Yeah.
That was
So
Dr. Puri.
most of us are comfortable with right to left.
Yes. So thank you. I think good you pointed out, because things were not making sense to me. Now they are. So this, what you see on the screen here is the liver, and you see it's a fairly hyperechoic liver. So this is suggestive likely of fatty changes in the liver. Now I have to see his risk factors, etc. But this is the liver parenchyma that can be seen. Typically in cirrhosis, you'll see some coarse echo texture. Now I'm not seeing that very significantly here. So portal hypertension cirrhotics tend to have a very coarse echo texture. And what I'm going to do is I'll just show you how you rotate the scope to find the different vessels, okay? So here, let me show you, let's see, yeah.
Is this little hyperechoic?
Yeah, I think
liver?
this is a little hyperechoic liver. And what you're seeing on the screen over here is the left portal vein, which is going towards the IVC, okay?
And how you decide the ideal site for liver biopsy?
So the ideal site is typically considered to be the left lobe of liver, although right lobe of liver is also something people do across the duodenal bulb. You can do either of these two. Left lobe is your standard approach, and studies have consistently shown left or right lobe doesn't matter. As long as you get a good sample, you get the diagnosis right. Now what I have also sort of done is gotten from segment 4, which is somewhere there. But what we'll do is go ahead and show you standard approach to obtaining biopsy from the left lobe of liver today. And I can see a nice, beautiful path here to obtain sample. And apart from this, I think what you'll also be able to see are changes of portal hypertension in these patients, okay? So let's go in a little bit, and I'll pull back, and what you see on the screen over here now, very important for beginners to not confuse spleen and liver. So this is the splenic hilum, and what you can see is it's a little enlarged spleen. So this patient has splenomegaly. I don't see many collaterals, which we oftentimes would see. This is the kidney, and then you can see the left adrenal gland over here, okay? And we can push the scope in slightly. Let's go to the bulb, and then what we'll do in the meanwhile is get the needle ready, and I'll have my assistant here. Hi. Shadab is here, and Shadab, we can show on the screen the needle we are going to use. So what we're using here is a Boston Scientific needle, and this is a 19 gauge FNB needle, okay? This is a Francine type needle, which Dr. Puri showed you in the day earlier. Yeah, this one. So this is a Francine needle. It's a liver biopsy. It's a biopsy needle, 19 gauge by Boston Scientific. Now I'm going to remove the stylet, and what we are going to attach is a is a suction tube here with heparin flushed through. So we have a syringe which is going to be mixed with heparin. So we use the syringe and it allows me to have about 20 milliliters negative suction, which is what I'm going to attach to the hub.
What is the dilution of heparin for this?
1 is to 10,000.
1 is to 10,000.
Can we have the room view?
1 is to 10,000.
Yes, so this is it. And can you show the heparin?
You can show here.
Yes. Arvind, can you explain the details, whatever Saurabh said?
Sir, actually, there is a little difference while doing FNB from liver biopsy. Actually, while doing FNAC, we put stylet, we go within and we remove the stylet, and then we put suction either by removing stylet or either by with the syringe. But here we remove stylet beforehand going for liver biopsy, and we put this needle with heparin, which we are preparing here. We will just show you. So with the syringe, there is loaded with heparin.
Right. So now what, in the meanwhile, okay, thank you. Oh, flush it.
So needle has to be flushed beforehand with heparin.
And the idea to flush it with heparin is to, just leave this much heparin in here. Just flush it and leave this much inside. Okay. Just leave 5 ml inside, and that's it. So the idea is to flush it with heparin. The reason you do that is because when you're putting the needle, if there's a blood clot, then that may impact your yield and the tissue will not come. So that's the thought behind putting a lot of heparin through this needle, and then we leave a little bit inside remaining. So the entire column from the needle tip to the needle hub is basically heparinized. Okay. And then I'll need a negative 20 cc suction. Pull out negative and lock it. Pull. Yeah, pull it. Negative. Yeah, pull it. Okay. So we can show the audience again. So for those who are considering doing this is how it should look. So we have a negative 20 cc of suction, and the heparin is here inside the syringe all the way to the tip. Okay. All right. And in the meanwhile, what we were also looking at on the screen, and I'll show you in a moment here. So we are now into the duodenal bulb, we are looking at the gallbladder, and with the help of EUS, you can see the portal vein as well. So we are so this is the portal vein. You can see the diameter is a little. Let's see, we can. All right, so we have some issue with this thing. So leave. Okay, so I think I'm just going to go ahead and show you the biopsy as it's performed. Okay, thank you. So the loading is standard, nothing unusual, or the way you load the needle. Okay. A little bit more outside. This is okay. All right. Okay, so we are going to pull back. So air is your enemy, as we've always discussed. So here, air is removed. Come back. So let's see. Okay, I'll have my assistant hold the scope here. But yeah, please up. So the first thing to do when you're taking biopsy is to make sure there's no vessel.
Free to ask.
Okay, so the first thing to make sure is there's no vessel, and I'm using Doppler here. So what you see here is one little vessel in the wall up on top, but nothing concerning there on the top. And what you see is the gastric wall and the liver capsule. So first thing I'm going to do is, now remember, the suction is off on the needle. Okay, so I get my needle out gradually. So you should see on the top right of the screen, that's the needle coming out. Okay, and we can freeze for a moment. And what we will do is try to, let's see, yeah, lost this thing. Okay, I think we have some issue with the cursor, but anyway, I think the point is you want to check that in your path of needle, there's no large vessel. Small vessels you can get away with, but you prefer that there is no large vessel along the path. And because we are using a relatively larger needle, we are using a 19 gauge needle. So it gives me a nice sample, but in theory, it's a bigger needle, so you have to be careful. Okay? So I'm going to push the needle out slightly, and as you can see there, I'll have my assistant hold the scope in place. Yeah, that's it, Pakrovi. All right, and then I'm going to go ahead and advance the needle. So now the needle is inside. Let's make sure that we see it properly. Okay. So right there. And then we'll turn on the tap, as I say. We pull the needle out. Okay. So the needle tip is not very much visible here, but I think it should be okay here. Okay, so we'll go ahead. I don't see any big vessels, so I think we should be fine. Why is it not visible? So I'm doing 4 actuations. So once the needle is inside the body, it's called a pass. And every time you move it, it's called an actuation. And you can see there's some blood in the needle, which can happen as the liver is a very vascular organ. That should be okay. And I'm going to do my 4th actuation, and then I'm going to stop. Okay. And now we stop. So the tap or the negative suction is closed, and already what I can see is a nice core inside the syringe. I don't know if that somebody can show, but we have a pretty impressive core here. And now I'm going to pull the needle out. Now, Kenneth Chang, who's a... Yes. Sorry, please go ahead. So what we are going to do is, I'm going to pull the needle out very slowly. Yeah, we are going to show you the sample in a second, okay? So I'm going to pull out the needle very slowly. Now as the needle is pulled out, typically you want to make sure there's no bleeding. So you want to evaluate within 5 minutes. Now as of now, actively, it looks fine. There's no active oozing or bleeding right now, so we are in good shape. And what I'll show is, so someone, if you can zoom in on the camera. Yeah, I think this is obscured. Well, we'll take out the sample, and then we will get back to you and show you how the sample is. So let's flush it out. We got at least to my eyes, it was right inside the needle. So we got a good sample there.
Can you focus on this?
Yeah. So, yeah, there's a long core. Say at least a 4 or 5 centimeter. I would expect at least a 3-4 centimeter core in this case. So yeah, you got it. Sure. No, not same solution. It's fine. You can do it. Can you take out the solid part? You need a strainer usually. So by the way, if you are ever doing it, you need a strainer, ideally. If we don't have, then we can put it inside the heparin and then pull out the solid tissue. That's fine. You can use a strainer, something, you can use whatever you use for making tea, and the channi that is used is something you can use here and let it filter out the liquid and the solid stuff comes out. That's what. You can remove the syringe, flush the syringe out separately. Yes. And then the remainder of the needle can be flushed also. Okay. Yeah. So as that's being done, will take us a few seconds to get the tissue out, but we will be able to show you when it's all removed. So any questions on the technique, I'm happy to answer. Indication-wise, all hepatologists would be the right people. As a hepatologist, you have to be judicious when you want to do it. But in terms of technical stuff, happy to answer.
Saurabh,
Yeah.
Saurabh, this guy had an perfectly normal. So even a transabdominal biopsy would have been all right. But I think for the sake of demonstration, you did this, right?
Yeah, so INR, I honestly speaking, with all the new age understanding of coagulopathy and liver disease, I'm not sure if INR and platelet count is truly reflective of the coagulation. Although our age-old dogma and what we are used to is INR of 1.6 and platelets of 150,000. So I think ideally you should be doing rotum in patients to determine coagulation status. But yes, going by traditional measures, I'm okay with a 100,000 platelet count. Below that, or 75,000. Below that, I would be worried. INR of 1.6 is my threshold. And ideally, if you can do rotum, that's the right coagulation parameter and coagulation status. That you will get an idea from that.
Dr. Ajay wants to ask something.
Yes, yes, please, yeah.
As the radiologists do the blocking, or they put some gel before taking out the needle. All the radiologists, while doing their biopsies, they put a gel foam through the to block the needle track. Can we do it here while you have removed the needle, the sheath? You can put some of these gel foam so that there is no chance of bleeding. Is it feasible, or will it cause some problems also?
No, actually, it's a very good thought, and I think good you reminded me. I have to try it next time with my radiologist because nobody's done it, and nobody has done it with the US as best as I know. But if it can be done, why not? It'll increase our therapeutic spectrum, and we'll gain access to things and vascular structures which we would be otherwise worried of. I've done about 50 or 60 biopsies in the last year or two. Touch wood, but so far I did not have any bleed. So I think my confidence has grown. So I've not felt the need for embolization of gel foam. But yes, if you are apprehensive, certainly if it can be done. Maybe next time I see you, I'll have tried it in next case. Yes.
And the next question is, how many portal track do you get in these
can you take out the
biopsies
liquid
as
also?
compared to the transabdominal?
How many portal tracts? You need at least 11 portal tracts. At least 11?
No, so do you get all?
Yeah, so of course the pathologist will tell us, can we remove a little more liquid? Yeah. Oh, okay. So I think what we'll do is remove the scope as the patient is a little uncomfortable. He's slightly awake.
I'm asking from your experience.
Yes.
So in your experience, in your biopsies, how many portal tracks do you get routinely?
Oh, yes. So honestly, so the first 5 biopsies which I did, I tried different techniques and different needles. But once I got to the 19 gauge Francine with my heparinized solution technique, we are looking at average of 25 to 40 portal tracts in our specimens on an average. That's typically what we end up seeing. Now, what I'll show you, I don't know if somebody can zoom in here. Yes. So this is at least a 4 or 5 centimeter specimen that you see here. Can that be zoomed in, boss? Please zoom in. Please let us know if you can see it or not. Because I think we need to do it this way then. Sorry.
You can put it on a petri dish or something so that when it's very good. Excellent, Saurabh. Very nice.
Yeah, I think I hope that you can appreciate the specimen quality there. You see, that's. Yeah, I mean, why not? If the coagulopathy is not a problem, you can ACL well. So yes.
Saurabh.
Yeah.
Saurabh, Dr. Manoj here.
Yes, sir.
A nice demonstration.
Thank you.
Liver disease is usually diffuse disease, so biopsy from either of the lobe should suffice. So when would you like to take biopsy from both the lobes?
By and large, as you correctly pointed out, you do need biopsies from different areas. The only theoretical indication would be in patients undergoing transplant, where you are, say, obtaining biopsy and you're considering whether you want to transplant the left lobe or the right lobe. Those instances may want a specific biopsy for the living donor to determine which lobe needs to be transplanted. So there are just very specific indications for specific biopsies. By and large, as you can see, most of the disease is presumed to be uniformly affecting the entire parenchyma, and therefore any biopsy is fine. And there's data and studies suggesting the equal sort of yield in right or left lobe. Left lobe is fine, frankly, because it's a straight scope position, and you get the yield. You have to go in D2 and D1 and go into the duodenum, unless there's absolute reason to do it. Yes. Okay.
In view of time, we are.
Yeah, well, thank you so much. Thank you. We can proceed
Next
to the
case,
next room. Yes.
we are going to OT1.
A 74-year male complaining of global sensation, epigastric burning for last 2 months. Endoscopy showed varicose sessile polypoidal lesion of size 7 mm at lower esophagus, 30 cm from central incisor. Histopathology showed active esophagitis with squamous epithelial hyperplasia, negative for any dysplasia and malignancy. This is the picture. And the planned procedure is NBI characterization and EMR. Now you are live to OT1.
Hello.
Yeah,
Am I
Naval,
audible?
you are on? Yes.
Yeah,
very
so
much.
Devinder, you will have to watch very carefully because otherwise you may miss the polyp. That's very important. So we are in the esophagus. Now,
There is a large endoscopy view. Can we have it?
are you getting the endoscopy view?
Now we are getting it.
Yeah. So basically, I've gone up to the G junction and I'm first examining using white light. I'm using the easy 1500 X1 scope from Olympus. That's the G junction. And as I pull back, there is a tiny polyp over here which you can see about 3 to 4 centimeters above the G junction. Now obviously this polyp probably does not require removal, but I'm going to tell you why. And I'm also going to tell you how we should examine and how we can examine using the zoom scope also, because this scope has a near focus vision. So I am going to use the zoom function. Now I'm going to apply the NBI. And you see on the right hand side, you see the arrow which shows that this is the zoom function. So this is 1.5 times. And now I am also putting water so that you get a good underwater image. Are you getting an underwater image now?
Yeah.
Now this actually shows the IPCL pattern very clearly. So in the mucosa, in the normal underlying esophageal mucosa, you are seeing the dots over there which are called the IPCL patterns. Probably if you can give the external image, I can show them that. And on the polyp, you can see that the pattern is slightly looped, and you can see plenty of loops over there, the capillary loops. But the capillary loops are also quite uniform. So that means that this is a hyperplastic polyp and it is not a malignant polyp or dysplastic polyp. So that is what is very important. So this is how it is. So there is a technique of how we should examine the IPCL pattern and this thing. And the purpose of doing this case and to demonstrate this was how we can carefully examine these polyps and these lesions, because most of your early esophageal lesions are going to be like this. It will be a subtle difference. So it is very important to examine these lesions. Now, obviously, since this is an hyperplastic polyp, it does not require removal. So I don't think we should remove it. What do you think, Dr. Sanjay? You think it? I don't think it requires removal.
No, not at all.
Because it has already regressed, shrunken in size from the earlier image which I saw.
Yeah.
But I think we have demonstrated the IPCL pattern very clearly.
Yeah.
So
And
that should be enough, I think.
It must be an inflammatory polyp which has regressed over time. Previous image, actually, if you see, it was reasonably big, about a centimeter in size.
About a centimeter in size. But in a month's time, if it is regressed, then there is definitely no need to remove it. We should not be touching it at that time.
So good for patient.
That is good.
So I think.
And a very good take-home message that you should always be thinking dynamically, not that once you have committed to do something, you'll do it.
Yeah. And also the fact that in inflammatory polyp, you should never be in a hurry. You can keep the patient under follow-up. There may not be a need to resect at all.
That is true. I mean, inflammatory polyps need not
Excellent,
be removed
Amol.
unless they are bleeding
Very
and
nice
there's no
observation. Demonstration of NBI demonstration was very good, actually. Very well appreciated.
Thank you so much. Thank you.
Somewhere in G junction or stomach, looks like inflammatory. Do you want to still wait or you want to remove? Big size. Most common. Okay. Fine, thank you.
If it is on the gastric side, invariably these patients will have spallery gastritis due to spallery lesion at the polyp.
Well, how many of us are actually have started using spiral? You have some experience, Manoj? Yeah. Okay. It was motorized, right? So, Dr. Sanjay, which next case are you demonstrating? Dr. Sanjay, are you there?
Hello. Yes, Devinder.
Yeah. What is the next thing lined up?
Next thing is a procedure of ESD, a duodenal polyp. Then we have another poem, which will be done, and a very interesting case of inward migrated biliary stent, which has actually gone in, and seemingly it is somewhere in the upper CBD. The lower end of the stent is in upper CBD, and the upper end it's somewhere in the left hepatic duct. Then of course Pyrus enteroscopy are there, but there is some challenge with the foot switch. They are working on it.
Meanwhile, we have some time. May I request Dr. Ajay Jain, who is going to have Endocon next 1.5 months' time, to throw some light about what are his plans and how is he organizing it.
Good afternoon, friends. As you know, all the gastroenterologists of Chhattisgarh. All the gastroenterologists of Madhya Pradesh and Chhattisgarh, we are hosting the 23rd annual conference of Society of Gastrointestinal Endoscopy of India at Indore. This will be from 7th July to 9th July. It will be about 3 days event. We are starting at around 11 o'clock on 7th July and will be finishing by 4 o'clock on 9th of July. So during these 3 days, we tend to demonstrate live about 35 advanced endoscopic procedures, starting from ERCPs, EUS, third space endoscopy, ESD, FTDR, all complex as well as simple procedure, and some of the advanced diagnostic procedures like endocytoscopy, the narrowband imaging, FICE. It will be, because it's a national conference, there will be some orations, Dr. B.J. Vakil oration, Dr. S.C. Shah oration, presidential oration, then there will be keynote address. For this conference, there are 9 international faculties, 3 from USA, 3 from Europe, 2 from Australia, and 1 from Japan. About 300 national faculties. There will be live session workshops. There we have created 6 endoscopy gurukul for different kind of hands-on training, which include the training on ERCPs, EUS, third space endoscopy, and demonstration on how to use electrosurgical units. There will be an exhibition with all the endoscopic companies exhibiting all the latest equipment and accessories. We will have a video session, and this will be a plenary video session where the videos submitted by all over India will be selected. 6 videos will be selected for plenary session. Then there will be a poster session, and 6 posters will be selected for the plenary session. Interesting thing will be a unique kind of a thing that we this time intend to invite the senior endoscopists to submit their videos. Where did I go wrong? So where did I go wrong means the complications which they encountered during an endoscopic procedure. How did they recognize that complication, and how did they rescue themselves, and what were the lessons learned from those complications so as to avoid in future. So these will be about 6 to 8 endoscopic video session on the complications of advanced as well as simple endoscopic procedures. On social front, we have 2 nights. On the first night, on the social evening, we have interstate singing and dancing competition. So the gastroenterologists of various states, they can join together and come with either a group song with a group dance, something like we don't want to invite somebody from outside, but we want to encourage the talent of our endoscopy friends. On the second day, that is a Saturday night, we will have a ramp show by the Babas and Dadas of GI endoscopists. All those senior endoscopists who have reached in their 60s, they will do a ramp walk with their traditional attire and fancy dress. So these are the 2 social evening programs. On the front of the state Congress, because ISG MP State Congress have been merged with the SGI. So on the Sunday afternoon, starting from 2 p.m. to 5 p.m., we'll have a short program on the sidelines of SGI program, which will be the second state conference of Indian Society of Gastroenterology of MP chapter, where we will have a presidential oration, we'll have Dr. Girish Naik oration, and we'll have some plenary session. And for this session, we have decided that the invited speakers will be all the gastroenterologists who are below 40 years as a guest speaker to showcase their talent and present their some original work or their reviews during the Congress. I request all the gastroenterologists of MP and Chhattisgarh to join hands and make it a big event, because this is the first time that SGI is happening in central India in the state of Madhya Pradesh and Chhattisgarh. And any suggestions, any criticism, anything which you want to be included during this Congress, please write to me, Dr. Sunil Jain, who is the organizing chairman, or anybody can approach me, Dr. Ashmit, Dr. Devinder Singh, or anybody, and please do forward your suggestions to make it a memorable event. Last time we did in 2015 as National Congress of Indian Society of Gastroenterology, which was very well appreciated because we all joined hand together at that time also. So once again, I request all of you to come to Indore, join hands, and all the gastroenterologists must reach by 6th evening rather than coming on the 7th morning. So this will be a big event, and please, please do come. Awaiting to welcome you all at Indore. Thank you.
Thanks, Dr. Ajay. We are all with you, and we wish you great luck.
Thank you. You don't wish me great luck. You have to come
and our cooperation, it's something which is already there.
Yeah.
So you don't have to ask for it; it is there.
So you have to be there before 7th. You have to be there on 6th.
Certainly. We all will be. Sanjay, are you ready with the case?
We are just ready with the case. Just 2 minutes. This is one interesting case of migrated stent. Just give us 2 minutes.
By
We
the
are just
time
setting
they
up.
are getting ready, we request if you want that some of your patients to be shown, or you want some of the procedures to be done by these international. And I want to tell you the names of the international faculties. So Dr. Shyam Vardrajulu, who is a pioneer and authority in the field of endoscopic ultrasound, he will be there. Professor Irving Waxman, he again is a very senior professor and head of the department, distinguished professor at the University of Chicago, and he is a great therapeutic endoscopist. Then Nayantara is doing interventional endoscopic work in inflammatory bowel disease. So she is going to demonstrate how to use endoscopic procedures to alleviate the problems of inflammatory bowel disease. We have two guys coming from Australia, Dr. Vipul Agrawal and Dr. Saurabh Gupta, and they are into the third space endoscopy and narrowband imaging and the chromoendoscopy. Dr. Ogura Takeshi, who has pioneered many new procedures in endoscopy from Japan, and he will be coming from Japan with two of his assistants. Then we have Dr. Lismana, who has recently published novel therapeutic approach in post-ERCP GI bleeding. His paper was just published in GI endoscopy about a month back. So he's coming from Indonesia. Then we have three guys coming from Europe. Dr. Antonio from Italy. He is a researcher and he's a big name in the field of meta-analysis and research in the GI endoscopy. Then another guy who's coming is Dr. Dipres from Belgium. Again, he is a guy who is doing a lot of work in endoscopic ultrasound and third space endoscopy. So these are the 9 people who will be coming from across the globe, and then obviously all the big names in the field of GI endoscopy are coming. So I request all of you, if you feel that there are any procedures which you want to be demonstrated during, please do refer them. We'll take care of them, and we'll make sure that their procedure is done to their best of satisfaction and it is demonstrated to all the audience. Thank you.
Yes, we can have the case details, please. Yeah, Dr. Naveen, you can brief the
Yeah,
case.
I can hear you. We are in OT2. This is one interesting case actually. Dr. Rohan is going to demonstrate the history.
So here we have a 60-year female. She had a choledocholitis in 2017. Was was done, stone was removed, followed by she had undergone lab chole, and then she lost to follow-up. The stent was forgotten. After around 1 year back, she had abdominal pain on and off. So on X-ray abdomen, a stent was seen in the CBD. So this was done session. So MRCP was done, which was showing CBD was related, and it was migrated stent at around upper end of the CBD. So someone lab CBD exploration with tritium cholangiogram to remove the CBD stent. Then they did a lab cholangiogram, lab tritium cholangiogram, but they could not locate the stent. So again, patient went to some another gastro physician. They did US, and they could locate the stent on the hepatic duct. So now patient has come to us for spy cholangioscopy and stent removal. This is what image. This is image which we have got, which is X-ray during the T-tube cholangiogram, which is clearly showing the stent. And you can see the cholangiogram view, there is no stent. So this is really where the stent has gone. So we have all the India's best faculty. Now we are in OT2 live. Sir.
Rajesh, Rajesh, we can see you, but we can't hear you.
I think now I get the case of my choice actually since morning. So
Yes, yes. But Rajesh, how do you react to, stent not being visible in one modality, being visible in another modality? How it's happening?
I don't know the history.
See, this is very interesting. I'll just revise it for you, Rajesh. So somebody had done a lab CBD exploration to remove an inward migrated stent. They could not find it inside. And later, after some time, they did even T-tube cholangiogram. Later on, when the stent was still there. And we have seen it on X-ray also.
So my gut feeling say when this is the final, the stent might be the intraparenchymal, or it is intrahepatic, because even they took a cholangiogram during lab choledochol thought at that time there is a possibility the stent might not be in the ducts. That's one possibility, or they have not taken the proper cholangiogram. Stent might be in the intrahepatic ducts. These are the only possibilities, because otherwise they should have seen if it's in the ductal system. So we will demonstrate if it is intrahepatic duct. If it is in the
Could it be because of undiluted contrast obscuring the visibility of the stent? Is it possible?
yeah, there is a undiluted. I absolutely agree with you.
I think Rajesh should get a different mic. This one is not working well. This mic doesn't seem to be working well.
Yeah, I think in this room there is some problem with the little bit mic actually. Caller mic. And who is going to assist me? यहाँ पे लगा देना. यहाँ लगा दो. उसको बोलो. Am I audible now?
Yes,
Can you show the fluoro here also? Somebody show the fluoro.
प्रोन में भी फिर भी अच्छा रहता है क्यों कर दो 1 मिनट लगेगा कर दो यार तैयारी तो थी आपकी
आप क्या ले रहे हो? मुझे है ना एक तो बास्केट चाहिए, एक मुझे रिट्रीवेबल बैलून चाहिए हो सकता है, हरिकेन बैलून आप तैयार, उसको बुला सकते हो एक बार. मुझे करवाना है पेशेंट. डॉक्टर योगी, Dr. Devinder. So meanwhile, any discussion we want to do it? Am I audible?
Yes, you are audible. Very much audible.
Suction on. Prone करना है. अगर spy है, we can keep the spy also. So the spy ready. The spy ready.
Rajesh, some stents, we see very infrequently migration of stent. But what do you feel that which are the factors which are promoting upward migration of the stent?
Which are the
What could
stricture?
be the reasons?
Which are the stricture which promote upward migration of the stent?
Not stricture. What are the factors which are
Factors. I think
responsible
Dr.
for
Devendra
upward migration?
again a very valid question. Actually, what happened is number one, the morphology of the stand generally is S-shaped or they are little bit deviated. So when you are planting these stands, rather than put the system, you put in is number one. The
Rajesh, your
stricture
voice
and the
is very
part of the
pale.
stent is significantly up. This is the second reason that chances of migration of the stent is very high.
The mic seems to be, not very friendly with you. It's missing your voice many a times.
Am I audible now?
Yes, now it's better.
Okay, and we give the Buscopan to the patient. Okay? Yeah. Left. Fluoro we can focus. Can somebody will? Yeah, and can you raise the little bit this? थोड़ा सा इसको भी ओके थोड़ा सा कम माउथ गैप
भैया स्नेयर भी रखो स्नेयर रखो एक बास्केट ले लो हाँ रूटीन वाला ओलंपस का होगा तो
ये वाइट गार्ड लगाओगे
लाओ सर
थोड़ा सा लेफ्ट लिटिल कर दो Okay. So can we raise the shoulder, little bit of shoulder? Shoulder up कर दो. ये shoulder को ऊपर कर दो. Okay. Am I visible? Can we give Buscopan to the patient? Is the endoscopy image is visible?
Yes, visible. Rajesh, you are on.
Can you see the ampullary adenoma?
Very well.
Is my voice is audible?
Yes, you become very clearly audible, but in between you go away.
Can you give the Buscopan, please? Is it an ampullary adenoma?
Yes. Is there any change in plan, Rajesh?
Stent has
Are you
to be
planning to do
removed.
something else also?
Can we show the
Along with
fluoro, please?
removal of
Where is it? This is the stent. I think we'll be able
not
to do
too
it.
far away.
Can you give me the dye first? Coronary.
It's not too far away, Rajesh. What do you feel?
So we can see the stand. Can you show the stand above? The stand above. Can you show the fluoro, please? Yes, sir. एंडोस्कोपी की भी बड़ी करोगे? एक बार उसको भी बुलाओगे क्या? क्या नाम है? एक बार जो मोहन का जो असिस्टेंट है, एक बार
सर हो जाएगा हो जाएगा सर
हाँ हाँ वो प्रॉब्लम Okay. Can you show the fluoro, please? Can this fluoro come little near so we can see at least? Yeah. Please. Will you place the guide wire? Is inside in the bicep? My cannula? Yeah, place the guide wire. You don't have a thermo guide wire? You don't have a thermo? Yeah. Okay. Wait. Okay. Can you put the dye please?
Can we have the
Little bit?
fluoro view as well?
Can somebody focus the fluoro? Just wait. Yeah. Put the dye.
So what is your plan, Rajesh? What are you trying to do?
So my plan is to put the dye. First I am taking the angiogram. Then I might take the. Can you show me the dye? Remove from here. Fluoro. Yeah. Dilute it. With whom you want to remove? With endoscope or basket or red tooth, whatever you will say, I am going to use it. Balloon? Yeah, put the dye. So can you see here? The stent appears is okay.
Check, check.
Okay. So give me the Dormia basket once. I'm removing this. Okay. Give me the Dormia basket once. No. So I will track the accessory which I can use is I can use the Dormia basket, I can use the red tooth, or if unsuccessful, I can take the balloon also up, bring the stent down. That is also one of the tactics. So I will try one by one. First, I'm going to use the Dormia basket, and I will tell my technician to arrange the biliary balloon also, or the hurricane balloon is more useful. The reason is that hurricane balloon has a length of 4 centimeter. So the between the there is a cohesion of force will be more down when you are using the balloon rather than the biliary retrieval
Rajesh, don't
balloon.
you feel the distal end of the stent is stuck to the wall of CBD? Like when you will be pulling, it might be hitting against the wall. Because the way the location of the stent is such that it
Show
seems
me
to be, hitting the wall of the CBD.
can you
Check,
open the
check,
basket?
check, check. Hold.
Yeah, open the basket. Yes. Can you see, Dr. Dev? And
Yes,
show me
now
the
it seems
basket.
disengaged
Can
from
you show
there.
the fluoro?
Yes, yes.
Gradually close, slowly close, slowly. Slowly close, slowly close, slowly close. Just open, open, open. Show me the fluoro. Yeah. Close, slowly, open. Yeah. Yeah, close,
Now I would like to invite
slowly,
Dr. Piyush Manoj
slowly.
sir, consultant
Is closed.
gastroenterologist from Bhopal,
So now you see the
and
stand has
Dr.
been hold.
Swen sir.
Can you see the
He is a
fluoro?
consultant gastroenterologist from
Yes,
Indore
Rajesh.
as
Dr.
a
Devendra, the
chairperson
most
for the next 1
important,
hour.
Excellent,
rather than
excellent.
pulling
We
my
can see it. Yeah.
basket, I'm using the force of the scope. Okay? Further, I will further pull here. Okay? I think the stand must have come out. Is that okay? Can you see
Now I would
the
like to
stand?
call Dr. Pranav Ragvanshi
Can you
sir
see the stand has
to
break?
present the momentum
So now
to
I'm going to
Dr.
use. Just
Broken.
wait for a minute. No, I will using
It has got broken,
this.
but then it has come
You
down
know what is the
significantly.
reason?
Yes.
Because it might have been hold very firmly. And don't try to pull the basket. Try to use the shaft of the scope to push it down. So what I'm going to do is
Very important. Important trick you have told Rajesh.
open. Yeah, I might use snare. Give me the snare. So I'm changing now my accessories because earlier my intention was because on the fluoroscopy you are not getting the three-dimensional view. So that's why I've used the basket. Now I've got an end-to-end view. Rather than Dormia basket, I'm going to use the snare. And I'm going to tell you what is the trick for this. Once I will use the snare, don't bring your snare or your accessory should not be pulled. Try to use your shaft of the scope. So, will you open it? Partially, yeah, partially open it. Just wait. Open more. Yes. Open more. Just wait. Yeah. Close it slowly.
Now I would like to
Slowly.
call Dr.
Yes.
Pranav Raghuvanshi
So,
sir
Dr. Dev,
to
yes.
present the
Close.
memento
Close.
to Dr. Ajay
Closed.
Nagdev sir,
Close.
Nandamer sir.
Close. Little more close. Is that okay? Now, what I'm going to do is I will make my scope on the clockwise direction like this to bring the stand down. Okay? Then what I'm going to do is broken. So now you see that again it has broken. That means the possibility. Now can you have a red tooth forceps? So I'm going to use the red tooth forceps because the stand might be from the longer time and it is from the local company and is breaking again and again. So I will hold the red tooth forceps and will try to bring the stent out. And the another important thing is after removing the stent, always take the cholangiogram because the secondary stone formation is also there. So you ensure that there is no stone in the bile duct. Where? Okay, we'll
This
take
looks
it
a
out.
very old stand. Must have been there for years.
Open.
It seems.
Can you rotate this? Is it possible to rotate? Can you rotate? If you can't rotate, tell me. I will adjust it. Can you do it? Okay. So I have got a fantastic assistant with me and he's helping me to rotate the basket. This red tooth, yeah, open. It's okay. Very good. So what I'm going to do, I'm catching hold from here. Hold it. Now I will push my
What
scope
care you should
down.
take, Rajesh, when you are actually taking out such old stents, which have become very brittle, and the moment you hold them, they
Can you
start
see it's
breaking.
getting brittle
What are
even?
the points of
So
caution that you must exercise?
yes, so I think the entire stent is out. Is that okay? Now give me the balloon along with the dye. So I'm going to take the cholangiogram and make sure that the everything is okay. So now I don't think I need a retriever balloon. Retriever balloon. So I don't think the laparoscopic surgeon has seen the bile duct nicely. I think there's something is somewhere there is some problem because such a big stent in the bile duct cannot be missed by the laparoscopic surgeon.
I think they may not have seen the
While
fluoroscopic
sir
picture.
is preparing for the balloon extraction, so we are now going to the OT1. The history of the patient is like
What
this.
about this ampulla? Are you
A
going to leave it as such or
60-year-old
something
male,
like that?
new onset of
We will
dyspepsia
do the
for around
biopsy.
1 month, no alarming symptom. Endoscopy showed the sessile polypoidal prox 1 centimeter and anterior wall of duodenal bulb. Histopathology shows adenomatous polyp with low-grade dysplasia. Here's the image. And the planned procedure is characterization of lesion with NBI and ESD. Now we are live to OT1.
Dr. Amul sir, you're live.
Hello, am I audible?
Yes, yes, you
Yeah,
are
you
audible.
can see Devinder, I can see Dr. Pandey. So are you getting the endoscopy image?
Yes, yes. But we can have a
Yeah.
bigger one.
Okay. So I have Mohan with me over here, and we are both looking at this polyp. And this is a white
Now
light
the
image.
captain and the vice captain have interchanged their positions, right?
Huh?
Yes.
Yeah. So now I'm just putting near focus on a white light. And Mohan, what do you think this polyp is?
Usually in D1 we see either adenomatous polyp or Brunner's,
But most, this is epithelial polyp. You can see the villous architecture over there.
Yeah.
But majority of our polyps now, which we see is duodenal NET.
NETs,
But they are
yes.
mostly subepithelial. So the
Yeah.
mucosa looks absolutely normal. And here we can see slightly, the adenomatous polyp. Which
Adenomatous polyp. So, see, there are certain characters in between. Now I put NBI. So here, few of the characteristics look like adenomatous, no doubt. Although there is some Brenner's gland hyperplasia also probably underlying, that also could be a possibility. That is how it looks like.
Biopsy has shown some
Adenomatous,
so it's best to remove this
Remove
polyp.
this polyp, yes.
But the polyp can be removed in toto by ESD, and to do ESD in duodenum is extremely difficult because the duodenal muscle is paper thin, and only champion like Dr. Amol can do this because we have to be of utmost, we have to take utmost precautions not to perforate, and we should be ready with mucosal closure devices like OTSC clips or even hemoclips or even the King's closure, what we call as loop and
Yes.
clip technique.
Right. So I am thankful that I have Mohan with me in case something goes wrong over here, because he is the master of closure. I can probably resect, but it's better that to have him as a closure. But now I am also showing you this other function of this X1 scope. This is the TXI mode, and here you see that the margins become so clear. Now this is how it looks, and when we go to the margin is very crystal clear. So that can sometimes help, particularly in the colon, if or in the rectum, if the margins are not very clear. However, for regular ESD and while dissecting, the regular white light is much better. So what I am going to, I have shifted back to the white light, and we will start with injection, submucosal injection now. And I have Srinivas, probably the best endoscopy technician in the country, to assist me over here. I can only say country because I have not worked outside of India. So it might be that he is better than
He is
most
best
people.
in world.
Exactly, that's what even I
Yeah,
thought as much.
exactly.
Okay, so inject Srinivas.
Yes.
Yes, it could be done with an underwater EMR. Okay.
So in duodenum, we try to do with underwater EMR. Yes, duodenum is the place where it has been described along with the colon. But here, since dysplasia was there, and we want to be very sure about the margins, and to submit this whole specimen in toto to the pathologist so that they can comment on the margins and curative resection, it's always better to do ESD. However, EMR can also be done on this.
Yes.
But that will, there will be crush artifacts, there will be more coagulation, more post-perforation, post-polypectomy syndromes, many things comes in.
Yes, there's always a challenge with EMR. Now, we will use the dual knife, and actually I would have preferred to use the colonic dual knife in this situation because the duodenal wall is very thin. But
Dr. Amol,
yeah,
I wanted to just ask if we could apply OSCO clip with the new device which cuts also.
Yes, the
FTRD.
FTRD device, yes.
So that is a possibility.
Because it's a 1 centimeter polyp.
But remember, this is a mucosal lesion. Now, why do we want a full thickness resection for a mucosal lesion?
Yes.
That is basically the principle. Meaning, if this was fibrotic, if it had been attempted to be resected earlier and it was not possible, then probably it was okay. But otherwise,
I think everybody should concentrate on the procedures. Amol is doing extremely delicate job of cutting the mucosa in duodenum, and he has to be very, very sure about the depth of incision. A millimeter here and there and you will get a perforation. See that he even not cut the mucosa, it's still probing the depth to get into proper depth.
probably now we are
Yeah, now
a little bit inside. So now I am hooking a little bit.
and
Mohan,
technique.
are you satisfied with the elevation after injection?
Back a little.
The elevation is
In duodenum, it never
slight.
remains that much because you have to keep injecting. Either injector.
So after initial injection, the saline dissipates very quickly. That's why to do a quick incision and then keep on expanding that submucosa by constant irrigation. So that's what Amol is doing to create a pocket into submucosa, and then gradually he will keep on expanding. To go into the proper depth is very important, and you can see his very small strokes, which are, you see that now he is exposed the submucosa.
Now the submucosa is exposed. Now I will extend this on the left side as well.
So you saw that the technique where he did not made a deep incision, he made a very careful incision to reach to the submucosal plane, and once he reached there, now he is extending onto the left side. So that's a very important technique. It is always better to do. If you see the mucosa, if you are having a suspicion of depression or loss of vascularity, where there is a chance that there can be a deeper invasion, you can do that to rule out. But in this lesion, where the endoscopic EE, that is image enhanced endoscopy, is not showing any worrisome features, it's not mandatory to do, because it looks like 100% to the mucosa.
It's a mucosal lesion.
But in NETs, subepithelial lesions, we do.
We are live from OT2.
Okay.
Can we hear us?
Yes, we can, but we are getting image from OT1.
Yeah. OT2, sir.
Now you can make a switch over.
Yeah. So we are live from OT2. We have removed the stent.
Can you show the?
We have done the cholangiogram. We have some suspicions. We are doing spy cholangioscopy. So now we are live.
So Dr. Devendra, can you see the
Yes,
cholangioscopy
Rajesh,
image?
we are able to see. Yeah.
Can you see the cholangioscopy image?
Suspicious lesion there inside CBD. Tell us, what do you feel?
Such a beautiful image. You have second?
We are not getting spyglass view.
Yeah, sir. It will take some time. Can we switch over to OT1?
No, it's visible now. Can you see?
It is back. It is back.
Yes, sir. We are live from OT2.
So make it on the right side. I think there's a problem in the spy scope. Can you see the intra? Can you make it on the right side?
Dental plus है तो medical में मिलेगा क्या?
Put the water. Can you see the intrahepatic ducts and the? My scope is in the right anterior intrahepatic ducts. I'm withdrawing. Put the water, please. This is the right and the left hepatic ducts.
Conical cap भी नहीं है और clip and line नहीं
Can you see right duct and the left duct?
Back ले लो, back ले लो.
Yes, Rajesh, we can see that.
Put the water.
Well, Dr. Manoj wishes to see the cystic duct opening also. Is it possible?
So we are just changing the spy scope. We are just changing the spy scope. Give me 30 seconds.
Meanwhile, we can move to the other OT if they are still working there.
We can shift over to OT1.
Yes.
Yeah.
So we are making
Yes,
a circumferential
John?
incision. Yes. Dr. Devendra, we are making a circumferential incision around that polyp.
Yeah, meaning I would
rather prefer to go from the oral side and gradually make the incision, because the minute we make a complete circumferential incision, the fluid starts dissipating very rapidly. But just now we are still unable to get under the lesion. And we actually, in this situation, we would prefer to use a clip and line kind of a technique where we can apply a clip with a thread. नहीं तो फिर बैंड होगा तो बैंड लगा देते हैं, rubber band that will be good.
Now this procedure requires some traction. So the traction can be by clip and line, where we attach the mucosal flap to a clip and pull a thread so that this is elevated, and two, either apply a rubber band so that we can go underneath the mucosa. So that's is quite done, as Dr. Devender was pointing out, that the lift is not adequate. Once lift is not adequate, we need to do traction technique.
Rubber band मिले, छोटा वाला, सबसे छोटा वाला जो होगा.
We are back from OT2. We have changed the new scope. We are live, sir.
Yes, we can.
So Dr. Devender, I have taken out the scope. The reason is that we just want to demonstrate you how to take the spice scope in. So I will tell my colleague to make it up. Yes. I am bringing the scope back towards me. I am using the big knob towards me and the right knob on the right side, and I am not using the elevator at all. And you can see I am inside the bile duct. So this is the method. You should avoid injury to your spice scope. The second important thing is your scope, your hand should be on the clockwise direction and a little bit lower. Can you make it? Can you position the bigger? Can you make the spice scope bigger? Yeah. Can you make the big knob up? So can you see the bile duct now?
Yes, Rajesh, we can see that.
रबर बैंड इतना बड़ा तो मुंह से बाहर निकलेगा. सबसे छोटा जो है, हम लोग तो डेंटिस्ट्री डिपार्टमेंट में जो रहता है ना, वो वाला यूज करते हैं.
Can we switch off the audio of OT1?
अरे देवेंद्र.
Hello.
Here are you?
Spioscopy is from OT2 and Hasithata is from OT1.
Can you see the opening of cystic duct?
That was Amol.
Can you see the opening of cystic duct? So I was
Excellent,
inside
Rajesh.
the cystic
Yes,
duct.
we can.
Can you
Yes.
show the fluoro, please? And can you make it straight now? Yeah, so slowly water. Yeah, so I was in cystic duct, and now I am going up. I am going up. You make it on the right side. Yeah, on the right side. Do it with the right side here. Okay. Can you show the fluoro, please? Yeah. Can you make it straight? Yes. Okay, put the water now. Make it like this, yeah. Put the water. So now I am going to the left ductal system. Make it down. Yes. Yes. Put the water. Can you see I am deep inside the left ductal system or the right anterior? Can you show the fluoro, please? So you see I am just at the right anterior ductal system. I have gone deep. So the most important thing is your hand should be on the right side. Yeah, turn on the right side. Little bit, one by one.
Rajesh,
Yes. Can you see now? Put the
Rajesh,
water.
what are you trying to see, Rajesh?
So there was a nodule in the anterior ductal system. And can you see?
Okay.
Yeah, I'm pushing. Can you see that nodule here? Yeah. This is on the right side, little bit. Yeah. Put the water. Yeah, put the
With
water
that
with the
stent in situ for a very long time,
Yeah, this
do you
could be
think
a
that nodule was something to do with that stent?
could be a or to rule out any cholangiocarcinoma. Yes, really? Yeah. Only one direction. Put the water. Yeah. Can you
I
observe
think
this?
this is very, very small hypertrophic
Are you
area.
sure this is
Must be because of
hypertrophic?
stent.
Huh? On the right side. Do you think this is hypertrophic mucosa? So this could be a stent-induced case. My only thought process something else is not there. So we can gradually withdraw. This is a stent. Put the water. Put the water. We can see the. Can you see the other ductal system here? This is all stent related changes. The most important thing there should be water. Can we use the pump? So the main reason of using the cholangioscope was CBD was grossly dilated and we have a worry that any stones was remaining because the 2 centimeter inflated balloon was also freely moving. So that was the reason of taking the cholangioscope to look any remnant stone. So I don't think this patient require now any stent. We just take the biopsy from the ampulla. Okay.
Great.
So we take the biopsy from the ampulla. See about. So I will remove it. Give me the biopsy. Give me the biopsy. So we'll take the biopsy from the ampulla to rule out the ampular adenoma. I think most likely hypertrophic papilla. Open. 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 Open or close there?
I think we have
Just when
moved
I
to
will say close, then you
OT1.
close
Can
it.
we have the audio? Meanwhile, Rajesh, we compliment you for your masterly demonstration. It was great work done.
Okay. Okay. Close करो, तभी close करो.
Can we have audio from OT1?
Yeah. Hello?
Yes. Yes, Mohan.
Yes.
Yeah.
So we are.
Amol,
Yes. Yes. So
you
we
are
are.
on, both of you.
Yes. Absolutely. So we are progressing, and we have made
We made
the.
a full circumferential incision now. I'm just trying to do some hemostasis. Hybrid humor, that's why I'm wondering whether we can do a hybrid humor. That's why I did a circumferential incision. Yeah, because we don't have a loop and clip also. No? We don't. We might need it. We may need it. Small needle, but you have to be careful. Basically, you don't want to. Dual jet.
So we are using dual J knife.
Back.
एक तो उसका ब्लेड जो है, that is very the protrusion of blade is very small, so there is more control and less depth of incision. So where the muscle thickness is less, like in colon and duodenum, this is best. While stomach, there is a different knife which is longer one.
This is actually the gastric one. That they don't have the colonic one. I would have preferred the colonic one over here, but it's a little bit longer.
So Dr. Rajput has a desi tarika.
क्या हो गया?
Apply some putty that will protrude less. We can have one session of tomorrow with Dr. Rajput. How to do innovation in desi style. It's very important.
बाद में देखेंगे. मेरे लगता है I think we might do a hybrid EMR. Yeah. Injection. ये काम करो, needle से करो, needle से करो. Because
so we are planning to do hybrid.
We will do a hybrid EMR because couple of things. It is not lifting well. We will need to ideally use a clip and line technique to lift the mucosa up and then dissect underneath. And उसका हैंडल है क्या? 4 सेंटीमीटर रहता है और उसका हैंडल है क्या? हैंडल मोस्ट इम्पोर्टेंट है. लूप तो ओलंपस भी यूज कर सकते हो, जरूरत पड़े तो. और ऐसा मुझे पीछे से तेरा स्नेर कौन सा है भैया? स्नेर कौन सा है उसके पास? ओलंपस का. रुक शायद वो स्नेर आने तक दोबारा इंजेक्ट करना पड़े इसलिए. 20%.
So we are doing hybrid EMR. For that we have done the circumferential margins, so that now we are sure that margins will be included in the specimen.
See, the reason why we are shifting to a hybrid EMR is because there is hardly any lift, and since it is coming face on, we will need a clip and line technique or a clip and band technique to actually be able to lift it up properly. Open karo. So now what I do is I am asking Srinivas to open the snare completely. Now I am anchoring the snare under the mucosal flap on this side, and then I am pushing the snare and trying to get it on all sides now. It is still a tricky position. We are this, even a 15 millimeter snare may have been adequate. That is what I feel.
वही 15 चाहिए
ठीक है आ जाएगी 15 से भी हो जाएगा क्लोज करो थोड़ा थोड़ा क्लोज करो
ये ओलंपस का है
इसको पकड़ा क्लोज 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 कम ऑन क्या लग रहा है क्या हो गया ठीक है
So we have the loop and
loop and handle is there, no? Okay, so I have grabbed the entire lesion. So it looks as if probably it's en bloc. Do you think so, Mohan? Or is it that corner, left side corner, is it still little bit remaining? Not so sure. थोड़ा सा ओपन कर शीने क्या 15 वाला स्नेयर या लूप धीरे धीरे क्लोज कर नहीं ओपन 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 कर क्लोज कट हो जाएगा तो लफड़ा जाएगा दूसरा स्नेर लेते हैं ओपन कर इंजेक्ट भी कर देंगे वापस इंजेक्शन ले ले एंड देन वी विल पतला है कोई पतला और छोटा दोनों नहीं 15 का है तो चलेगा लेकिन 25 नहीं यार ये तो 20 भी बड़ा था दस में आ सकता है चलो फटाफट काफी ठीक ये अच्छा है खोल दो चलो थोड़ा छोटा है 15 would have been ideal but let's see close आ गया I think it is हटो हाँ टू करो रीड होगा लेकिन
लूप एंड क्लोज वैसे ही
हम लोग ऐसे भी कर रहे हैं। बाहर ही निकालना है, बाहर ही निकाल देते, चलो बाद में मंजन नहीं होगा। छोटा है, गॉस पे ले लो, गॉस पे ऐसे नीचे मत डालो उसको। कैमरे को दिखा दो एक मिनट, उसमें डालने के पहले।
Excellent work, Amol.
आएगा मसल राजेश, चलो अंदर ही दिखेगा। अभी जो कुछ भी है अंदर स्कोप डालने के बाद पता चलेगा क्या महाभारत है वो।
No, we are certain that everything has went well.
अरे नहीं, बहुत बड़े होते हैं वो, जगह नहीं है इधर। अच्छा, डायरेक्ट क्लोजर के लिए, डायरेक्ट क्लोजर के लिए ये नहीं कट गया, पॉलिप कट गया, बाजू का नहीं कटा। क्या इसमें पॉलिप कहाँ है? ये नॉर्मल म्यूकोस है राजेश, ये पूरा नॉर्मल म्यूकोस है।
Amol, do you feel that some part of it is left?
No, some of the mucosa has been left behind, but the polyp has come out completely. So we just almost kind of a semi-pedunculated, that kind of a thing. So we actually went a little bit wider. Let me see if this area can be lifted up, but otherwise I might be inclined to leave this. What do you think? Yeah. What
So
I'm
what
going
do
to
you
do is
plan?
I'm just
You
going to
plan
touch with this snare and
Okay.
see what this thing is and then take a call. I'm not going to immediately grab it. What is the consensus? Yeah.
Well, I think we should wait and watch. Is the consensus from here?
का पोर्शन ये पड़ा है यार, क्या बात कर रहे हो? 6 o'clock पे दिख रहा है, ये दिख रहा है पॉलिप का पोर्शन। अमोल बाबू एग्री विद मी, एब्सोल्युटली at 6 o'clock पे।
Dr. Ajay Jain
थोड़ा ओपन करो, ये कॉर्नर
wishes
लेंगे।
to say that we can try to lift it up, and if it can be, then we should have another go.
धीरे धीरे क्लोज कर, धीरे धीरे छोड़ो इसको। I think that is okay. That is enough.
Now you are happy, Rajesh?
चलो इसको क्लोज कराने लगा। एक्चुअली रीडिंग क्या क्या दे रहा है? स्नेयर टिप सही कर देते। I'll have to leave for my flight now. Mohan, I think you'll be able to take care of the closure.
Amol, at 3 o'clock we can see some oozing and little bit of deeper cut.
Give me the tip.
Is it okay?
Yeah, I didn't get you.
At
This
around
bleeding,
the
right?
tip of your needle, we can see some deeper gash or cut, something like that. Is it
No,
okay?
that is not actually deep. It is right up to the submucosa. Just because of the bleeding, there is a little bit of staining over there, but otherwise it is the same level. It's not too deep. You may not even want to, lose it. Mohan, what you could do is, loop and clip की जरूरत ही नहीं है. What you might do is, the central mucosa, you can probably put 2 or 3 clips like this to cover this base. That much. Good layer of submucosa. Yeah. Actually, the hemostasis is more important. Probably. क्या रेस्पॉन्स इधर ही है क्या वो टच करके नहीं ग्रास्पर से कर देते बंद करो भैया बंद करो बंद करो बंद करो बंद करो थोड़ा मसल में है उधर बंद करो
Meanwhile, we are starting the hands-on session on the ground floor. Another 10 minutes. So whoever has registered for it should go to our endoscopy suites on ground floor.
पकड़ नहीं जा रहा है यहाँ पर ओपन करो थोड़ा सा और इधर रोटेट करने के लिए जगह नहीं है नहीं दबाओ ओपन करो छोड़ो क्या कर रहे हो लोकन क्लिप में खाली लफड़ा ऐसा है कि आपका सेंट्रल म्यूकोजा अंदर घुस जाएगा लफड़ा हुआ है यहाँ पे भी एक क्लिप लगा दो ना यहाँ पे एक क्लिप लगा देते ना बाकी कुछ नहीं लगेगा यहाँ पे 2-3 क्लिप में भी क्लोजर ये फर्स्ट टाइम लगी चलो अभी ये एक लगा दूं मैं बाद में फिर मोहन को दे दूं क्योंकि वो मेरे हाथ से हुआ है फिर उसको फिर वो ये नहीं होता है थोड़ा रोटेट कर उसको
Which clip is this?
लेग स्पिन कर दे थोड़ा
Resolution clip.
ज़्यादा भी ज़्यादा नहीं ज़्यादा हो जाए थोड़ा कम थोड़ा स्पिन कर दे
Any choice of clip, Mamon, in this patient?
Huh?
Any particular clip you would prefer to use?
Open karo.
Since we have to be very sure about proper application, we should choose clip which can open and close, and we have one-to-one rotation. So Boston clip is one of the best.
ऊपर के ऊपर ही है.
Yeah, open it. Like this, Amol was not happy, so he asked him to open, but this cannot be done by Olympus clips. So duodenal mucosal closure is a difficult one, and sometimes we can induce perforation by application of clips also. One has to be very experienced with that.
be one like this and one more after that. करो fire. पता नहीं दूसरा लगा दो, दूसरा दे दो उसके बाजू में। फिर भी मैं वही कर रहा था, लेकिन वो हो नहीं रहा है क्योंकि वो आइलैंड अडियरेंट है, तो वो नाटक हो जाएगा। तो आइलैंड कवर करना हो जाएगा। भैया उसको बंद में डालो, समझ में भी आ जाए तो कोई प्रॉब्लम नहीं। ओपन ओपन ओपन, वही प्लान है।
Meanwhile, Dr. Sanjay is arranging helicopter for.
थैंक यू संजय। प्लस कर दे फाइल। चलो मोहन आ जाओ भैया प्लीज, भागू। हो गया क्लोज तो हो गया, एक और लगा दो आ जाओ। हाँ लगा के जाओ। आप बोलो, मैंने घड़ी नहीं देखी, आप देखो मैंने घड़ी नहीं देखी। हेलीकॉप्टर से पुणे ही छोड़ दो ना। मेरी बैग वहाँ पे है, मैं तो कपड़ा चेंज करने से मैं लेके आया था। तो हाँ पैक है, कोई लेके होटल में है बैग, वो खाली कोई लेके आ सके तो दैट्स अ डिफरेंट मैटर। अभी तो जाने का टाइम, जाने आने में टाइम जाएगा। ओपन थोड़ा सा ऑफ स्पिन कर दे, ऑफ स्पिन कर, ऑफ स्पिन ऐसा। नहीं लेग स्पिन हो गया। नहीं क्रिकेट देखने का टाइम नहीं मिलता है देखो मोहन, उसका क्रिकेट दिखाते यार।
Well, we can hear you, Amol, smiling and laughing. The procedure has been done very nicely, so we are also smiling here.
देखो वेट रहे नहीं, यहाँ पे लेफ्ट पे नहीं आया। ओपन करो, ओपन करो, फट रहा है वहाँ पे। Devinder, the reason why I can laugh is because I have two stalwarts with me, Mohan and Rajesh, who I know will be able to close this defect even if I cannot.
Yes, certainly. They are great help.
Close.
And you have been interchanging the captaincy and vice captaincy between the two of you and making each other comfortable.
चलो भगवान के नाम पे चले आते हैं। चलो हो गया, अभी हो गया।
Great, Amol, excellent work. Very precisely done. Appreciation from here.
Thank you guys. Thank you for your patience and your support, moral support and for your physical support all and guidance.
So we all thank and clap once again for Dr. Amol. He had beautifully demonstrated all the cases which he has done. And in spite of shortage of time, he could manage to come. A big thanks to him. He traveled all night, in fact, to reach here. Started at 2 a.m. from Pune.
Dr. Sanjay, I cannot miss an invitation from you, and thank you so much for the kind invitation and hospitality. And actually, my apologies that I cannot wait in the evening.
No, not at all. Yeah, we would have enjoyed
I would have loved to,
banquet
but
together.
unfortunately, there are certain things which are unavoidable, so I have to go back today. Thank you so much. Bye bye.
Well, Amol, great work.
Chalo. Bye, Devinder. See you.
Bye. Take care.
Hello. Am I audible to all? Pranav sir? Pranav sir? Am I audible to you, sir?
Yes. Yes, you are audible.
So in few minutes, we start another case, poem. Patient is ready. We are calling Mohan sir. In that time, meanwhile, I am briefing the history of the patient. She is a 30-year female, diagnosed for achalasia cardia 1 year ago. Underwent lap-Haller's myotomy with Dior fundoplication 4 months ago. Now again complaining of dysphagia, regurgitation with vomiting for 2 months. Endoscopy done showed dilated non-peristalsis esophagus with liquid residue in the esophagus, spastic ileus, scope passed with resistance. Barium swallow showed the sign of achalasia. These are the picture of manometry and barium. And the planned procedure is poem. We are live to OT1. More.
कोई भी है जो भी उसमें टाइम लगेगा तो टीटी दे दो टीटी टीटी दे दो टाइम लगेगा स्प्रे हाँ एंडो कट 222 नहीं है Looks slow. So this is post-Heller's myotomy. So we have to do posterior poem only. And you can see here that the
No. Water. Water. Bus.
Hello.
Hello? Yes. So
We
we'll.
can't hear you. Mohan, why have you gone silent?
No,
We
no,
want to
no.
hear you.
Actually, I thought everybody is sleeping.
How can we? When you are performing,
Alright.
we have to wait and we are around, very much around. We
Okay,
are keenly
so
observing and we were thinking why
yeah.
you have
No, no.
gone
I thought.
silent.
I thought you gone for some tea or something like
No, no, tea has come to us. We
that.
have
Oh
not gone for
wow.
tea.
So that looks like fibrosed case.
Mohan, how often you encounter post-hellers, those who have failed hellers and have to do poem in them?
Yeah, we do a lot because our being referral center, many of the patients are referred, and that's a quite common scenario. Say, for example, in a year we'll do around 50, 30 to 40 such cases. So now we have injected, and this is post-Heller's myotomy case. So I'll do the first mucosal incision. Srinivas, are you ready? So I'm just, as I described in the morning, first incision has to be properly in depth. You can see now, so I'll enlarge this incision.
Mohan, are there any special difficulties in post-heller situation?
Yes, there is more fibrosis, especially once you do anterior poem. Because Heller's myotomy is done anteriorly, and you are not supposed to do anterior poem once you are dealing with posterior. So always posterior poem. So now we have gone into the muscle layer, and then now we'll start the dissection. Sarinu? See that this case is slightly different from the morning one. There is a lot of submucosal fibrosis and some bleeding, but we should not be bothered about the bleeding at the mucosal entry site. We'll quickly go to our place where we want to work, that is onto the muscle, and clearly we'll dissect the submucosa like this, expose the muscle.
Have we crossed?
And you can see the vascularity, so much vascularity. And I'll keep on going like this, downwards, towards the G junction. So control is important. You can see as we are going down, injection please. So we'll expand this, and then we'll
we are going down towards the G junction. So always better to do the dissection on the sides also, so that you don't cause any mechanical crushing. So now we are going to reach to the G junction. Inject please. Stop. So here you can see there will be lot of, the clarity of the planes won't be there like it was there in the morning case. You can see lot of muscle being, the muscle layer and submucosal layer are sometimes indistinguishable. And you can see this is the muscle layer. We'll do superficially like this and keep going down. Now I'll inject here and then there is a big vessel there. Will not see to on that side. So I'll try to do this dissection on the right. And I think I have entered the G junction. As you can see, the palisading vessels, sorry, the spindle vessels there. So we'll go to the right. We'll keep on dissecting onto the right side. So that's 100% stomach, because you cannot see all these vessels in the esophagus. Sometimes post-Heller, it's difficult to distinguish between the esophagus. The landmark is not that demarcated. Injection, please. So we'll inject on the right corner. So there's a big vessel which I have punctured, and you can see the very nice spurting bleeding. So you can now give me a quick grasper. So there is a function known as RDI. So what I do is I just push the scope and turn to RDI. Is there anybody from custom function close, custom function? No, function list, RDI. Okay. Now I am red dichromatic imaging. So red dichromatic imaging is help us to pinpoint the bleeding point. So I have stopped the bleeder with the cap, and you have done soft coagulation. I bring the catheter out and gradually pull out, and you can see that's a bleeder. Can you see that? See that bleeder? That's the beauty of red dichromatic imaging.
Mohan,
Yes.
we have been hearing some yellow enhancement thing. Can you hear me, Mohan?
Yeah, this is a red dichromatic imaging to pinpoint the
Yeah,
bleeding
that's
point.
fine, but we are hearing some yellow enhancement in surgical circles. Does it have any role in
No.
endoscopic procedures?
See that the pinpoint bleeders immediately stop. The spurting vessels was seen by RDI, and I'll come to the white light, and you will see the red gives lot of stress, and the RDI, the stress is gone. So that has been, there are a lot of studies on this, that if you are doing a control of bleeding in RDI, there is a mental stress to the doctors. See that this looks very dangerous. This looks dangerous, and this doesn't
Input,
look.
video input.
So we'll see how much we have gone into the stomach by coming out. See that's all in the stomach. This is the stomach. This bulge has gone up till here into the stomach. So we'll keep on doing the dissection of the muscle, and then we'll extend our incision of the muscle to slightly lower level. So post-Heller's, you need not to do very long myotomy. You should do the very short myotomy. Now we are cutting this muscle. This is the longitudinal muscle you can see there. So I'll catch that and cut like this.
Now I request Dr. Sanjay Kumar sir to facilitate our moderator, Dr. Jayant Yadav sir.
Yes.
I request Dr. Sanjay Kumar sir to facilitate with the memento to Dr. Devendra Yadav sir. Singh sir, sorry. Yeah.
The peritoneum. So we'll keep on cutting this muscle till we go to that's the end of our tunnel. And you can see the peritoneal fat on the right side. That signifies that we have gone into the peritoneum and no need to go further. So that's the peritoneum. So that's the peritoneal fat. That's a complete myotomy. There is no further bleeding. And you can see this very nice myotomy. And this is our end. And then once we go into the stomach, you will find this very open up. And then there is no mucosal injury. So there will be a lot of bleeding once we are going. So we should not bother about stopping this bleeding by quack grasper because you may injure more mucosa. It's always better to clip because we know that there is no injury inside. There is no bleeding inside from the tunnel. We'll wash once. Make sure there is no bleeding. Suction and see each and every corner. So once you are sure there is no bleeding inside, you come out and those ooze from the mucosal edge will only be taken care by the clipping. You should not do coagulation of the mucosal edge because it may cause the mucosal burn and then closure will be still more difficult. So you can see Srinivas is opening the clip. I will go to the last corner of the mucosal incision, do suction and close. So first clip to be applied on the normal mucosa that elevate a tent-like structure so that subsequent clip can be applied very easily. So the first clip as you saw was on the normal mucosa. Open. The second clip will apply here, close. Nice. Complete open. Then go very close to the edges, close. Okay. So try not to bring the fold of mucosa, it should be the two edges. And I'll show you the technique of that. So you have to go very near. Like this. And then this is the submucosa. Close. Yes. So see that a part of submucosa has come in. That's a good closure. So we'll apply one more clip in between here. See that perfect closure. And one more to reduce the tension on this clip. Like we applied first clip on the normal mucosa, and if the last clip applied on the tip, that reduces the tension on the clips which are critical. Close. This is just to reduce the tension. So I just applied. Okay, so then I go into the stomach and suck out all the air so that the extubation becomes easy. And then you can inspect the mucosa. There is no mucosal injury, which is very important. And there is a perfect mucosal closure. No bleeding. That's all.
That was masterly. Now just one question.
Yes. Please tell me.
Mohan?
Yes.
Are you there?
Yeah. Can you hear me?
You just tell us, Mohan, in how many countries have you demonstrated poems so far?
More than 20 maybe. Yes.
Great.
Yeah,
We are so proud of you, and you're doing it so fast. We enjoyed every bit of it.
No, it's all
Thanks
blessing
a
of
lot.
seniors like you, and it's my hometown, and it's great moment for me to be able to demonstrate some of the procedure which we have learned in last 10 years. Thank you.
Great. Excellent. I hope to see you perform many more times.
Thank you, sir.
Mohan?
Yes.
Hello?
Yeah, tell me.
Sanjay here.
Yeah.
What do you think is the future of achalasia treatment? Is it going to be poem for all three types, or do you think that we can take a decision against poem in some cases?
Yes, I think future, this all are, I am seeing curative treatment for achalasia, some gene therapies or some molecular therapies coming up which will allow esophageal peristalsis to come back and ability of LES to relax and contract. Presently what we are doing is only palliation, that is to reduce the LES pressure, nothing more. Whether it is done by balloon, lap hellers, or poem. Each one has got their own merits and demerits. Poem being attractive because it's a surgical myotomy done orally. Laparoscopic is also good, which provides anti-reflux mechanism. Balloon is the most simplest method of doing. So all methods are still are effective, and each one has got merit. So I will not do poem in a patient who has large hiatus hernia, where there is 100% reflux which will happen, and it requires crural repair by laparoscopy also. So why not to give to laparoscopic surgeon to help in both the things? When there is severe
Is that a common combination you have seen? Large hiatus with achalasia?
No, it is less common, but it's not
It's
like
very rare.
not it's
still rare combination, but whenever it is the first choice. Laparoscopic repair is the first choice for that. Otherwise, majority of the treatments can be done by POEM. Submucosal fibrosis still pose challenge where we may have to abandon the procedure, but still if you probe too much places and have the ability to create tunnel any circumference, we will find some pathway usually.
So the way you do it seems so simple. It seems when any endoscopist would feel that I can do it, but doing,
Whole aim of demonstration not to scare anybody, and but this all come with lot of experience, lot of hard work, constant efforts, achievable. That should be the inspiration for everybody, but through proper training and hard work and many cases.
Certainly you are definitely an inspiration for many of us. Thank you, Mohan.
Thank you so much.
So are we doing the last case?
Yes, we'll finish all cases.
Yeah, that is I think the case is Arma. So now we are also relaxed. So let us revise what was done in the morning.
Okay.
See one more Arma and
Yes.
refine our knowledge.
ये वाला लगाना है. Force argon, 0.8 liters, 70 watt effect point. ये लगा. Mic बंद करो.
Hello. So this is our last case, a 58-year-old male patient, known case of GERD for last 5 years.